Check, check. Hello, test, check. Hello, test. Hello, hello.
Namaskar. Thank you for allowing me to speak to you today about
Hello. Good morning, esteemed faculties, speakers, chairpersons, and delegates. A warm welcome to you on this second day of SORCON 2025, organized by West Bengal branch of Indian Rheumatology Association and Scientific Society for Osteoarthritis Research. So yesterday's sessions were a resounding success owing to the contribution from all the faculties, the esteemed speakers, and the organizing committee. So let's continue the incredible journey of knowledge, collaboration on this beautiful Sunday of 6th of July, 2025, here in Kolkata. So continuing our theme of SORCON, that is shown by the green color that you can see everywhere, that is a marker of hope that shows that still there is some hope left for the patients of osteoarthritis. So for the first session, we are starting with, I would like to welcome Dr. Urmila Dhakar, ma'am, Professor of Clinical Immunology and Rheumatology, and Dr. Amit Kumar Malik, sir, Assistant Professor, PMR, AIMS Guwahati, on the stage. So our next speaker, the first presentation will be an online presentation, and any questions raised by the presenting delegates or faculty will be answered by our respected chairpersons.
Good morning, everyone. So today's first speaker is Dr. Tuhina Yogi. She is Professor of Medicine and Epidemiology, Chief of Rheumatology, Boston Medical Center, Boston University, School of Public Health, USA. Her topic of presentation is pain mechanism in osteoarthritis. So I welcome Dr. Tuhina Yogi. Her recorded lecture will be displayed here. She is not online. So start, please.
We may start now.
Namaskar. Thank you for allowing me to speak to you today about pain and osteoarthritis virtually. I'm sorry I'm not able to be there in person. As you may know, I am Bangali. I have family there in Kolkata, in Amta and Howrah, and Diamond Harbor. But I was not able to make it this time. And I hope I'm able to visit you in the future in person. So I'm delighted to speak to you today about pain and osteoarthritis. I know you already had a session on the intersection of neurology and osteoarthritis, so I hope this talk complements what you've already heard. And I'm just going to move on to my first slide on osteoarthritis epidemiology. According to the latest Global Burden of Disease study, over 600 million people have osteoarthritis, reflecting about 10 to 15% of adult populations worldwide. And the knee is the most common site of pain, and in fact, about 30% of adults report knee pain in the prior 30 days. Now, we know a lot about the structure, function, pathology, and molecular pathways acting in osteoarthritis, but a challenge has been to link that disease, the pathology, structure, molecular pathways, to the illness, the experience of the disease, the human response to disease. And we know a lot about what causes acute pain. The old Cartesian model of a peripheral noxious stimulus going directly to the brain is really what drives acute pain, such as touching a hot stove and quickly moving your hand back, or if you're running and you twist your ankle. But we know that chronic pain is more complicated than that. And in osteoarthritis in particular, there's this so-called structure-symptom discordance where some knees have pain but not much radiographic OA. Some knees have terrible-looking radiographs but not much pain. And so the overlap between pain and radiographic OA is incomplete. And because of that, some people have raised the question of whether or not pathology actually contributes to pain in osteoarthritis, or at least how much does it contribute. Now, we have some empirical evidence that there are structures within the joint that contribute to knee pain. So in this study, where one orthopedic surgeon brother performed unanesthetized arthroscopic examination of the other brother's knee, he poked at different tissues and he found that the infrapatellar fat pad, the ligaments, the outer aspects of the meniscus were all painful. The synovium was painful. The healthy cartilage, which is aneural, was as expected, not painful. It's only diseased cartilage where you get neurovascular invasion and can cause pain. In addition, one of the earliest studies that I did when studying pain and osteoarthritis, I took people who had pain in one knee and no pain in the other knee. And in this way, any differences between people are inherently controlled for. So any reason for a difference in pain between two knees within an individual should be due to something going on in the knee. And when you do that kind of analysis, here on the x-axis you have the Kellgren and Lawrence grade, which is the radiographic severity of OA. And Kellgren and Lawrence grade 2, as you know, is the definition of definitive radiographic osteoarthritis. When you do this kind of an analysis, you get a very strong association between structural severity and presence of pain. The problem is that structural lesions are common. And here is a study of meniscal tears done by Martin England, published in the New England Journal of Medicine, where he found that about the same proportion of people with knee pain as without knee pain had meniscal lesions. So this raises questions of whether or not meniscal lesions contribute to knee symptoms in people with osteoarthritis. And we did another study with Ali Gourmazi in which we took people who had no radiographic OA, and we found that overall there were lots of common structural abnormalities on MRI. 90% had some kind of abnormalities, and that frequency was similar whether they had pain or didn't have pain. So our traditional approaches to studying what causes knee pain is compounded by the fact that there are lots of other factors that contribute to knee pain. So in some other studies, we've understood that mechanical lesions, bone marrow lesions, contribute to knee pain, and inflammatory lesions such as synovitis or hoppus synovitis contribute to knee pain, and effusion as well. So we've come to understand that there are multiple contributors to pain beyond joint pathology alone. For example, for those that are clinicians, you know that if someone has poor sleep, poor mood, poor coping skills, or have catastrophizing, they experience more pain regardless of what you do for their underlying disease. What I'm going to focus on now are the neurobiological mechanisms that contribute to pain and osteoarthritis. And as clinicians, we already understand that there are some neurobiological mechanisms, because initially the knee pain might be quite localized to the medial joint line, and over time the pain can become more diffuse, and we call it referred pain. So to understand some of the advances, we need to understand some basics of sensation. So any noxious stimulus activates a nociceptor and is interpreted as pain, whereas non-noxious stimuli, such as a feather, activates low-threshold mechanoreceptors that is interpreted as touch. We know, as I said, that pain transmission is not this simple direct highway from the periphery to the brain. There are lots of modulation that occurs, both ascending and descending, through the spinal cord. And so central sensitization occurs when these nociceptors respond to subthreshold inputs, or they generate more action potentials, and then that is experienced as hyperalgesia, or more pain than is expected. Or these low threshold mechanoreceptors might respond to non-noxious stimuli and then that gets interpreted as pain or allodynia when pain is not expected. There are three main types of pain mechanisms that are important to understand. There's nociceptive pain, which in rheumatology, examples include joint inflammation, such as rheumatoid arthritis, or digital ulcers, such as in scleroderma. And so these are pain mechanisms related to a specific tissue lesion or disease. Neuropathic pain refers to a nerve lesion or disease, so there has to be some lesion of the nerve. And examples include carpal tunnel syndrome, mononeuritis multiplex. Importantly, there's no evidence of neuropathy in osteoarthritis. There's been no studies demonstrating any neuropathic abnormalities on EMG or by clinical exam. And then finally, the latest, newest term for pain mechanism is nociplastic. And this is the type of pain mechanism where there's no lesion or nerve damage, and examples include fibromyalgia and tension headache. So in osteoarthritis, there's definitely nociceptive pain mechanisms because you've got bone marrow lesions, synovitis, etc. But some people may also have nociplastic pain, where the pain is out of keeping with what we might expect from just the nociceptive lesions. So illustration of central pain mechanisms exist in the literature, and I'm going to show you here one of the first examples from almost 20 years ago. This was a trial of lidocaine injected into the knee, and when injected into the knee, there was expected pain improvement. What was interesting is the contralateral knee that did not get an injection also got a pain improvement, indicating there must be something centrally going on that is causing pain to improve in the non-treated knee. Now, in animal models, neurobiologic mechanisms can be assessed through electrophysiologic assessments, needles to nerves and the spinal cord. But we can't do that in humans. So in humans, we use quantitative sensory testing to get indirect assessments of the functioning of these different pathways. So for the peripheral nociceptors, we can use a handheld algometer and measure pressure pain threshold, or PPT. We prefer using mechanical stimuli because OA is biomechanically driven. So when these peripheral nociceptors are sensitized, that's peripheral sensitization. When the central nervous system is involved, that's central sensitization. And in either case, the pressure pain threshold will be lower than people who are not sensitized, meaning they have pain sensitivity more readily when the pressure is applied. Another measure that assesses the central nervous system is temporal summation. Here you apply a weighted punctate probe at a regular interval, once per second. And for someone who's not sensitized, that same stimulus that's provided will provide the same pain intensity that they experience. But someone who is sensitized will start to have those action potentials build up on each other and over time experience more pain despite the stimulus being static. And that's known as temporal summation. And then finally, the descending modulation can be assessed through a paradigm called conditioned pain modulation, where you've assessed the pressure pain threshold, and then you apply a conditioning painful stimulus, here forearm ischemia test, where you apply a blood pressure cuff and you have them do some hand exercises to induce forearm ischemia. And then you assess the second pressure pain threshold. And if the descending modulation is working, then those descending inhibitory pathways will lead the second pressure pain threshold to improve or increase. And so we've conducted these types of measures in the multi-center osteoarthritis study, which is a cohort of 3,000 older adults with or at risk of knee osteoarthritis. And I'll show you some data here using pressure pain threshold and temporal summation. What we found is that these measures are associated with pain severity, but they're not associated with radiographic severity or duration of osteoarthritis. And this was contrary to our hypotheses because we thought that the more severe osteoarthritis one has, or the longer osteoarthritis that they have, the more likely they are to be pain sensitized. But because radiographs are relatively insensitive, we also evaluated MRI lesions. And we found that inflammation from, as evidenced by synovitis and effusion, are associated with pain sensitization and its worsening over time, but bone marrow lesions are not. So while bone marrow lesions contribute to pain, the mechanism by which they do so is not through pain sensitization. But this lack of association with radiographic severity or duration led us to question whether or not pain sensitization is a state inducible by osteoarthritis or whether it's a trait inherent to an individual. To address this, Lisa Carlesso, who's an associate professor in Canada, came and did a postdoc with me in Boston, and we studied pain susceptibility phenotypes. So we took people who were free of persistent knee pain, and we assessed all of these different things that we know can contribute to their pain experience, including quantitative sensory testing. And we followed these people over 2 years. And we developed this latent class analysis, an agnostic data analysis approach. And we found 4 clusters of people. One group was sensitized with pressure pain threshold, one group was sensitized with temporal summation, and the other 2 groups had less of each. What was interesting is all 4 groups had similar prevalence of widespread pain, pain catastrophizing, depressive symptoms, and poor sleep. So while those things contribute to the pain experience, they don't differentiate between who's going to develop persistent pain. What we found is that this group, this blue group, who were most sensitized by pressure pain threshold, had a 2-fold increased risk of developing persistent pain over 2 years. So to further assess whether or not pain sensitization is a trait or state, which, as I should mention, the prior study that I just showed you seems to indicate that it's a trait inherent to an individual and predisposes them to developing chronic persistent pain. So here at Kosaku Aoyagi, he did a postdoc with me as well, and we looked at pain sensitization measures over 9 years. And what we found, we did a trajectory analysis, and what we found is that people were fairly stable over 9 years in terms of their pressure pain thresholds. So where they started was where they ended over 9 years, despite their radiographic OA progressing, despite trying different treatments, etc. So again, this is providing some indication that pain sensitization is a trait rather than something that changes due to osteoarthritis. And Kosaku also studied post-knee replacement pain. As you know, about 20 to 30% of people still experience persistent pain after knee replacement. And so what we looked at was these quantitative sensory testing measures about a year after knee replacement. And what we found was that temporal summation and inadequate condition pain modulation, or that descending inhibition, were the 2 factors that were associated with worse pain post-knee replacement. So this indicates that for some people, the central sensitization or descending inhibitory modulation is continuing to contribute to their knee pain. We've also looked at whether or not sensitization has an effect on physical function. We know knee pain severity affects physical function, but could these alterations in sensory input lead to abnormalities in motor output? And this work was done by 2 of my mentees, Pat Corrigan and Josh Stefanik, who are now at Cleveland Clinic and Northeastern University. And what we found was that, yes, pain sensitization did have some indirect effect on function through pain severity, but also had an independent direct effect directly on affecting physical function that wasn't simply due to pain severity. So this is starting to bring up a picture of some more global nervous system dysfunction in both the symptoms and the functioning in osteoarthritis. So what does this all mean for osteoarthritis? Some, but not all, pain in osteoarthritis is due to structural disease, and other pain mechanisms must also be addressed. So what are the implications for pain treatment? Well, we must think beyond structural targets in osteoarthritis and think about targets within the nervous system. And there are lots of pain targets for nociceptors so far. Nerve growth factor was well studied, and I'll comment on that in a moment. And TRPV1 is a receptor that's important for pain and is targeted by capsaicin, which is the active ingredient of hot chili peppers. And I tell patients that topical capsaicin is a Nobel Prize winning treatment because David Julius won the Nobel Prize a few years ago for identifying that the mechanism of TRPV1 receptor functioning. And there are a number of other targets as well. Promising pain targets in trials for osteoarthritis have included a whole bunch of pathways, but as you know, the nerve growth factor programs were canceled because the risk mitigation strategies were insufficient. But there are some trials and programs for the receptors of NGF. Sorry, I'll get to that in a moment. Another promising target is ADAMTS, which is a fragment of cartilage that not only affects cartilage damage, but also pain. But unfortunately, the most promising trial was negative. In terms of the TRK-A receptor, a promising trial was negative, whereas another was positive. So there's still more to hear about from this program. And then the latest is the P75 neurotrophin receptor, Levi-4, and those that were at ACR or EULAR will have seen that they have a positive pain effect. And so this is very promising. The other very promising target is the NaV1.8. And while there was a study in osteoarthritis, most recently there was an FDA-approved medication for the treatment of moderate to severe acute pain, another compound related to the one studied in osteoarthritis. So maybe this company will move to chronic pain and osteoarthritis for their compound. So just in closing here, I just wanted to take a moment to say that we have to have some caution with managing pain. Nociceptive pain is needed to prevent harm. We know what happens when you have an insensate joint. You get a Charcot joint. And so zero pain is not the goal for our patients, but rather we need to try to manage their symptoms so they can have good functioning and good quality of life. So how to target the right pain mechanism is another challenge. Imagine we have these 4 individuals that you want to enroll in a trial. They all have the same amount of pain, but person 1 has some widespread pain, some psychosocial contributors to their pain, and lots of pain sensitization. Person 2 has a lot of psychosocial factors contributing to their pain and some widespread pain, whereas person 3 and person 4 have a predominant contribution of their pain due to OA nociception. So if you have a drug targeting OA nociception, OA pathology, you would want person 3 and 4 in your trial, not person 1 and 2, because your drug is not going to work in those individuals. But unfortunately, right now, OA trials will take all of these individuals. And I think that is one of the reasons why many of our trials are negative. It's because our trial populations are too heterogeneous to pick up the signal in the small sample sizes and short durations typical of OA trials to date. So there are a lot of lessons learned about drug trial failures in osteoarthritis. But a key takeaway is individual phenotyping. We need to be able to target the right treatment to the right patient at the right time. And so I leave you with this summary that pain is multifactorial. Symptoms do not equal mechanisms, and we need to be able to measure mechanisms to move towards mechanism-based treatment and identify responder phenotypes. And overall, for osteoarthritis, there will not be one single magic bullet. We will need to use multimodal, multi-target treatment approaches. And with that, I thank you for your time. Unfortunately, I'm not there, so I can't take questions directly, but you may feel free to reach out to me through email or social media, and I will address your questions. And again, thank you very much for allowing me to present virtually. I hope to be there next time and have some shadabhat with posto and lonka, which are my favorite, or with hunepata. So I look forward to that when I'm next there. Okay, namaskar.
That was wonderful talk by Dr. Tuhina.
Because she is not here, if anyone want to add something or say something about mechanism of pain.
2 days, we've heard a lot about management of pain. And the take-home messages, as far as I understood, was when it comes to management of primary sensitization, it is fluoxetine. That paracetamol is of no use, and NSAIDs are of no use. For primary sensitization, the message I got was fluoxetine. Whereas when it comes to secondary sensitization, where the problem is up here, it is pregabalin. So eventually, the two take-home messages that I got was, in anybody with osteoarthritis, you can give fluoxetine, which is Cochrane reviewed, as well as pregabalin, and I believe there are a combination of drugs with both fluoxetine and pregabalin. There are two drugs which has not been discussed, and we all use them quite extensively, and I would like the comments from here. One is a potassium channel activator, which is flupatine. Flupatine has been around and seems to be a good drug for osteoarthritis because it's supposed to antagonize some of the receptors in the brain. And I use that in a dose of 100 milligrams for osteoarthritis, and I'd be interested if anybody else uses it and find it useful, and I find it useful. As for tramadol, I know that many use it, and we're not supposed to be using it because it's an opiate. I just wonder what the experience of generally the clinicians here are on these two drugs.
Thank you, sir. Chaturvedi, sir, you want to say something? No?
I definitely use fluoxetine, and because one of my relatives told me, in fact, I don't have much knowledge about that. So I was just listening, learning actually.
So we announce close the session.
We thank Dr. Tuhina ma'am for shedding light on the topic with such an expertise, and our wonderful chairpersons for kicking off our first session. So for the next session, I would like to call upon stage our other chairpersons, that is Dr. Kripa Shindu Gantad, Professor and Head Medicine, Jhargram Government Medical College, and Dr. Abhijit Ray sir, HOD Rheumatology, Bellevue and Fortis, Kolkata. Please, sir.
Good morning, everybody. Thanks. Thanks for your sparing your Sunday for this interesting talk. As we all know, osteoarthritis is not a disease just of wear and tear, but it is also a metabolic disease where obesity, insulin resistance, syndromes, metabolic syndrome, all of them contribute into expanding and making our cartilages weak. And to present this view, we have amongst us Dr. Prasant Dudagara, who is an MD/DM rheumatology and clinical immunologist from Rajkot. And may I request him to come on stage and start the presentation.
Thank
Dr.
you,
Prasant Dudagara, please. Thank you.
Thank you, Chairperson. And thank you, West Bengal branch of IRA, to invite me for presentation of metabolic players in osteoarthritis in this wonderful occasion of SORCON. So I will be very much brief. So So as we all know, the metabolic abnormalities encompass a range of conditions such as obesity, hypertension, dyslipidemia, hyperglycemia, and insulin resistance, which all can lead to osteoarthritis. So every 5 unit increase in the body mass index, there is 35% increase in the risk for development of osteoarthritis. So we all know that OA is not solely a disease of mechanical load, because we can also see osteoarthritis in the hand of obese individuals. So in the metabolic abnormalities, I will cover glucose and lipid, which are the common metabolic players for development of osteoarthritis. Coming to the glucose, so in the diabetic patients, this chronic high glucose concentration actually causes the development of advanced glycation end products. And this advanced glycation end products will alter the matrix in the cartilage matrix, because they have a special receptor which are called a receptor for advanced glycation end products on the surface of chondrocytes. And by binding to this receptor via toll-like receptor 4 activation, there will be development of the MAP kinase 5 activations. And via activation of this MAP kinase, there will be activation of interleukin 6, interleukin 8, and there will be also activation of matrix metalloproteinase and ADAMTS activation in the patients of diabetes. So it is causing the increased cartilage damage. Coming to the obesity and the pro-inflammatory cytokines. As obesity and diabetes have a very much high pro-inflammatory environment, and there will be development of tumor necrosis factor alpha, interleukin 6, interleukin 1 beta, which all will cause activation of nuclear factor kappa beta, and that via that pathway there will be activation of MMP3 and 13 and ADAMTS 4-5 in the chondrocytes, and this will all lead to activations of damage in the chondrocytes, and there will be also activation of the reactive oxygen species via development of this nuclear factor kappa beta pathway. So there will be also activation of the type 1 macrophage in the patient of diabetes. In this type 1 macrophage will produce the tumor necrosis factor, interleukin 1, interleukin 6, which all lead to MAP kinase pathway activation, nuclear factor kappa beta activations, and ultimately coming to the common downstream pathway and MMP13 and ADAMTS activation, which all lead to collagen damage. So we have some also mouse models with the ROS inhibitors. That have shown that inhibition of MAP kinase activity and decreased severity of cartilage damage in the mouse models. We have also ROS quenchers known as the black phosphorus nanoseeds, which have been studied in the mouse model, which actually eliminate the intracellular ROS, and it maintain the cartilage morphology and impede the reduction in the subchondral bone in the ACLT surgery-induced rat models of the knee osteoarthritis. In diabetic patients, insulin actually a pro-growth factor, but because of the impaired signaling via insulin resistance because of the impaired signaling, there is decrease in this growth factor signaling via insulin, and there will be no anti-inflammatory effect of insulin, and that will all lead to the pro-inflammatory environment. And insulin resistance actually promotes the progression of osteoarthritis. As we have obese patients with type 2 diabetes, there is elevated tumor necrosis factor in the synovium. But obese knee osteoarthritis patients without diabetes, there is normal TNF. So whenever obesity is coming with diabetes, it always comes with a cost, because in the diabetes there is insulin resistance. So coming to the lipid metabolism, we have lipids which are absorbed with two different mechanisms. Whatever the food which we are taking is composed of mostly triglycerides, and these triglycerides are of three types. One is the short chain fatty acids, medium chain fatty acids, and the long chain fatty acids. So short chain fatty acids and medium chain fatty acids are actually emulsified and directly absorbed into the blood, but the long chain fatty acids actually combine with apolipoprotein and cholesterol to form the chylomicrons, which are ultimately absorbed into the blood in the lymphatic systems. But after metabolism and absorptions, fat are divided into the four lipid groups: triglyceride, phospholipid, cholesterol, and plasma lipoproteins. So this whole four type of lipids will affect the development of osteoarthritis. Coming to one by one, triglyceride metabolism. So triglyceride is an ester component of glycerol and 3 fatty acids. So whenever we take the excessive lipid, it will be break down and metabolized by the lipases, resulting in the elevated level of glycerol and free fatty acids in the blood. As I already told, free fatty acids are of three types: short chain fatty acid, medium chain fatty acids, and the long chain fatty acids, according to the number of carbon atoms. And they will affect the development of osteoarthritis. So coming to the three different type of free fatty acids, these short chain fatty acids actually increase the GAGs, interleukin 6, and the poly-ADP ribose polymerase, and this all will lead to increase in the development of osteoarthritis. Short chain fatty acids will also increase the autophagy markers like microtubule associated protein and P65 protein, ultimately increasing the nuclear factor kappa beta signaling and the chondrocytes. So short chain fatty acids actually promote the osteoarthritis. There was one clinical study of around 2100 patients of osteoarthritis which showed that dietary short chain fatty acids in the patients, whenever it was increased, the width of joint spans decreased at 1 year, 2 year and 3 year in the linear model. So coming to the monounsaturated fatty acids and the PUFA. So I am not going deep into that, but here is a very beautiful diagram. As I already told in the previous slide, short chain fatty acids will promote the development of osteoarthritis via interleukin-1 receptors and nuclear factor kappa beta signaling, similar to the omega-6 PUFA. So omega-6 PUFA are the linoleic acid and the arachidonic acids, which will actually also promote the osteoarthritis via development of a nuclear factor kappa beta activation and ultimately MMP13 and ADAMTS5 activations. But the story is different with the MUFA. MUFA is actually good for cartilage health. Actually, it inhibits the T1 necrosis factor alpha and ultimately inhibits the nuclear factor kappa beta signaling and ultimately inhibiting the MMP13 and ADAMTS5. And similar story is with the omega-3 PUFA. This omega-3 PUFA is actually eicosapentaenoic acids and docosahexaenoic acids that all will lead to the inhibitions of the receptor and ultimately inhibition of the nuclear factor kappa beta signaling. So moral of the story, MUFA is good, omega-3 PUFA is good, but SFA is bad, omega-6 PUFA is bad. So that is also seen in this, whatever the orange that actually promoting the osteoarthritis, short chain fatty acids, omega-6 PUFA increasing the expression of interleukin-6 promote the osteoarthritis. MUFA actually inhibit the osteoarthritis. Omega-3 PUFA actually reduce the MMP13 ADAMTS and reduce the clinical pain symptoms and improves the motor function in the osteoarthritis. So this was all about the triglyceride. Coming to the second lipid, that is the phospholipid. So phospholipids are the main component of the biological membranes. So they are divided into the glycerophospholipids and the sphingolipids. So glycerophospholipids, common lipids are the phosphatidyl choline, ethylolamine, inositol, and phosphatidylserine. This is the lipid subtype which have been studied least for development of the osteoarthritis. We have very much few knowledge about this, but coming to whatever the knowledge we have, one of the very common component of the biological membrane, that is phosphatidyl inositol. It is converted to phosphatidyl inositol phosphate, whether it is 3-phosphate, 4-phosphate or 5-phosphate by a special enzyme that is called the phosphatidyl inositol kinases. And this phosphatidyl inositol phosphate is converted to biphosphate via enzyme that is called the PIP, phosphatidyl inositol phosphate kinases. We have different type of kinases in our body like type 1, 2 and 3, and there are development of different type of biphosphate and triphosphate derivatives. But one enzyme which have been studied in the mouse model is PIPK1C. It is a lipid kinase which is responsible for synthesis of phosphatidyl inositol biphosphate. But those mice with the PIPK1C gene deletion, they develop the spontaneous osteoarthritis pathological phenotypes, and there are some drugs which are in development by inhibiting this phosphatidyl inositol pathway. So Kosinka et al. Developed the lipidomic and ionization tandem mass spectroscopy methods to analyze the synovial fluid samples of early osteoarthritis patients, late osteoarthritis patients, rheumatoid and the control runners to look for the phosphatidyl component of the osteoarthritis patients in the synovial fluid. So this was a very interesting finding that as compared to the control in the early osteoarthritis and the late osteoarthritis, phosphatidyl choline concentration was significantly increased. Similarly, phosphatidyl choline and lysophosphatidylcholine, both components were increased in the osteoarthritis patients as compared to the control. And phosphatidyl ethylolamine was also increased, but it was not that much increased as compared to the PC. So median PC concentration in the synovial fluid of early OA was approximately 2.7-fold higher than that of the control, and late OA it was 5.4-fold higher than that of the control. How this is responsible for development of osteoarthritis, that is still an area of research. Coming to the third lipid, that is cholesterol. As we all know, cholesterol is there in the body via two sources. One is the endogenous biosynthesis and another is the intestinal absorptions. So cholesterol can actually alter the Indian hedgehog activity, and it has an important role in the cartilage development. So how it affects the osteoarthritis is via three different mechanisms. that is via three different receptors. One is called the liver X receptor, second is called the peroxisome proliferating activator receptors, and third is the ROR alpha, that is retinoic acid receptor alpha. So coming to one by one receptor, first receptor is the liver X receptor. So liver X receptor actually activates the reverse cholesterol transport. It promotes the conversion of cholesterol into bile acids in the liver, thus protects the body from the hypercholesterolemia. So actually liver X receptor is good for cartilage health. So expression of cholesterol efflux genes in the osteoarthritis patients is significantly reduced. So there was a chondrocyte osteoarthritis model when treatment with the liver XR receptor agonist actually significantly increased the cholesterol efflux genes like ApoA1 and ABCA1. I will show you this by image. Like here, this is liver X receptor, and actually LXR agonist actually activates this ABCA1 and ApoA1 gene, and it will promote this cholesterol efflux from the chondrocytes. So whenever there is cholesterol accumulation in the chondrocyte, it will promote the osteoarthritis, but LXR agonist will actually promote the cholesterol efflux and inhibits osteoarthritis. That is one of the mechanism. Second mechanism is actually it inhibits the P50 and P60 molecule, 65 molecule, and ultimately inhibits the nuclear factor kappa beta. So nuclear factor kappa beta is actually responsible for development of MMP30 and TNF alpha and ADAMTS5. So ultimately actually inhibits the pro-inflammatory cytokines. So LXR agonists are an area of research which will maybe promoting the development of the cartilage. So we have a very beautiful drug like metformin and berberine, which are the AMPK activators. And this AMPK short-twin pathway will activate this liver X receptor. So mechanism of metformin causing the promotion of cartilage health is via this LXR agonist. We have a very beautiful drug which is called the resveratrol, which is anti-aging agent which is used by multiple people. So this resveratrol actually causes activation of the liver X alpha receptor via promotion of the FOXO1 phosphorylation. Whenever it goes inside the chondrocyte, it will bind to the SORT1 and AMPK pathway, promotes the phosphorylation of the FOXO1, actually promotes the liver X alpha receptors and promotes the cholesterol efflux genes like ABCA1 and ApoA1 and promotes the cholesterol efflux. And it has also another mechanism by inhibiting the HMG-CoA reductase enzyme. It will inhibit the cholesterol synthesis also, promoting the cholesterol efflux and inhibiting the cholesterol synthesis, ultimately lead to the decrease in the chondrocyte adipose cholesterol accumulation, decreasing the OA phenotype. So resveratrol is a very good for chondrocyte health. We have also another enzyme which is called the ALCAT, lecithin cholesterol acyl transferase. It is an enzyme responsible for conversion of free cholesterol to cholesterol esters to form the mature HDL, which goes to the liver, and ultimately the cholesterol is secreted into the bile secretion and fecal secretions. So those mice which have a LCAT deficiency, whenever they are given the high-fat diet, because they are deficient in the LCAT, there will be development of the osteoarthritis pathology via accumulation of the cholesterol in the chondrocytes because of the deficiency of LCAT. So we have some clinical trials going on the LCAT activators. Coming to the second receptor of cholesterol, that is PPAR receptors. We have three different phenotypes like PPAR alpha, gamma, and beta delta. So we have different chromosomes, we have different site of expressions, different natural ligands like palmitic acid, palmitoic acid, all are the long chain fatty acids which are and the cholesterols which are actually natural ligands of the PPAR receptors. And basic functions of PPAR alpha, beta, and gamma is actually a fatty acid uptake and oxidations. But coming to the basic mechanism by which it is causing the development of osteoarthritis, this PPAR alpha and PPAR gamma actually inhibits the nuclear factor kappa beta and ultimately inhibits the MMP1, MMP3, and MMP13 and ultimately decreases the extracellular matrix degradation. Another mechanism of PPAR gamma specific is inhibition of the P38 MAP kinase pathway, ultimately lead to decrease in the apoptosis. It will also inhibit the mTOR pathway, and mTOR is an inhibitor of the autophagy. So ultimately PPAR gamma will activate the autophagy. So three mechanisms: decreasing the apoptosis, decreases the extracellular matrix degradation, and increases the autophagy, by which this PPAR alpha and gamma actually promoting the cartilage health. So we have some medications which are acting on these receptors and they are actually promoting the cartilage health. But coming to the PPAR delta is bad because increased expression of MMP2 and MMP3 in the chondrocytes whenever there is PPAR delta stimulations. So loss of PPAR delta protects the osteoarthritis cartilage. RXR receptors actually a bad receptor because it is a downstream of CYP7B axis, and those mouse models have shown that overexpression of retinoic acid receptor alpha, there is increased cartilage degradation related genes. So it may be a potential target for osteoarthritis treatment by inhibition of RXR. So hypercholesterolemia has another mechanism by promoting the osteosclerosis. It causes the ischemia, hypoxia, and inadequate energy supply in the joint and tissues. So coming to the lipoprotein, these are the last protein, last lipids, and as we know, it is a structure of phospholipid, cholesterol, triglycerides. We have different type of lipoproteins like chylomicrons, VLDL, IDL, LDL, HDL. We all know the basic biomechanism by which it is causing the cholesterol transport, but I am not going deep into that, how it affects the osteoarthritis. In the most cohort, as in the previous lecture, Tuhina madam showed that is one of the very good study. In most cohort, what we have shown that approximately 300 symptomatic osteoarthritis and 283 radiographic osteoarthritis patients, level of total cholesterol, LDL, HDL in the serum of OA patients were not significantly correlated with the joint cartilage loss or synovial inflammation. Still, we do not know how this HDL, LDL, and cholesterol are causing or inhibiting the osteoarthritis. But coming to the apolipoprotein, ApoA1, whatever is there in the green, it is actually good for cartilage. ApoA1 is good, ApoD is good, ApoE is good, but ApoB actually is bad for cartilage health. ApoC, we do not have the study. Coming to the leptin and adiponectin both have a special receptor on the chondrocyte, and by a stimulation of the MAP kinase pathway, ultimately causing the activation of nuclear factor kappa beta, ultimately promoting the osteoclast activation. So leptin and adiponectin are bad for the development of osteoarthritis, and there are some inhibitors in the development for leptin and adiponectin inhibitor. So this is the last slide. We have drugs like statins, which have been shown to have a good effect for inhibition of osteoarthritis in the mouse models and also in the clinical trials. So statins have been shown to have a protective effect in the development of osteoarthritis. Fibrates, they actually are PPR alpha agonists, and they have shown to have a protective effect. Omega-3 fatty acids, they also have shown the protective effect. While in case of ezetimibe, there is no effect on development of the cartilage degradation, and PCSK9 inhibitors, there is no effect. So combination of lipid-lowering drugs and anti-inflammatory drugs may be more beneficial in the OA phenotypes, and still existing data is limited. Thank you.
Thank you for nice presentation, Dr. Prasad. Now the session is open for interaction.
It's a very interesting talk, and on your last slide, it's very common practice in our country for auto prescription of patients, zinc, selenium, antioxidants, and they all take it, because they think it's a good idea. But I'm interested in the omega-3 versus the omega-6. And there are several, including doctors, who prescribe omega-3 for patients with arthritis and including lupus. Yeah. Now, do we have good evidence or trials with omega-3 on its use in osteoarthritis?
Yes, sir. Actually, omega-3 fatty acids, there are also clinical trials in the human models. So it was not only mouse models, but those studies were not specifically designed for looking at specifically cartilage morphology. But clinically, pain behavior was significantly reduced, and there was improvement in the motor functions with omega-3 fatty acids. And as far as my experience is concerned, I have 3 to 4 patients who have a significant improvement in their pain behavior, even in the rheumatoid patients, which were not having good response to the methotrexate and leflunomide, and they were given this omega-3 fatty acids by a different doctor, and they had a good result. But still, I am not using it.
I am on omega-3 and I find it useful.
So possibly our osteoarthritis prescription needs some modification and inclusion of statins, omega-3 fatty acids, and if we can give this fibric acid derivatives also. Maybe it may be area of research.
Thank you, Dr. Prashanko, for good deliberation. I have one question, that there are so many genetic condition where there is dyslipidemia in children also, and type 1 diabetes in children. Is there any prevalence of osteoarthritis in this group?
So by this mechanism, there will be an increased development of osteoarthritis, but literature I personally do not know, because I have not read about that specifically.
Any question, any comment? Okay. Now we close this session.
Thank you, Prashant sir and chairpersons for the insightful session on metabolic players in OA. So for the next session, please join me in welcoming our chairpersons upon stage. Dr. Swapan Misra sir, Professor and Head of Department of PMR at CNMC Kolkata, and Dr. Swarnali Mandal ma'am, Assistant Professor at Department of PMR, IPGMR Kolkata.
Thank you. Sunday morning. This day also very important for we the physiatrists because today is our National PMR Day. We are celebrating all over India, and that is with the theme prevent disability before it happens. So with this note, this topic also, lifestyle changes in osteoarthritis, we are going to share. And as you have already learned from different lectures that both it has got degenerative component by different impact to joints and also inflammatory components. So both together can be prevented by changes in lifestyle, food habits, ergonomics, and also for that, Dr. Arup Ratan Ghosh is here with us. He is Assistant Professor, PMR, Medical College, Kolkata, and I hope I welcome Dr. Arup to discuss about this topic and do justice to the subject. Thank you.
Good morning, everybody. Thank you, SORCON organizer, to invite me for this talk. Today is National PMR Day, and our this year slogan is prevent disability before it happens. And coincidentally, our talk is also relates with that thing. So osteoarthritis, most common degenerative joint disease, major cause of pain and disability. Lifestyle plays crucial role in causing, preventing, and managing OA. Most common joint involved in osteoarthritis are knee, spine, mainly fasciates, hand, mainly the IP joints. And those are the etiologies of osteoarthritis. Some are modifiable and some are non-modifiable. So non-modifiable, we know there's age, genetics, gender, female gender is more prone, and joint shape alignment and previous joint injury. But there are some modifiable factors also. Those are obesity, occupational stress, repetitive cause, overuse, physical inactivity, sedentary lifestyle, smoking, diet, poor posture, and inadequate sleep. Unlike genetics or age, lifestyle factors are modifiable. A relation of the lifestyle with the pathophysiology, mainly obesity increases mechanical load on knees and spine. Occupational hazards, repetitive hand use, and heavy lifting in spine and knee occasions, and sedentary lifestyles like causes the weak muscles, altered joint mechanics, and smoking and poor diet having impaired collagen health. So the obesity is excessive stair climbing, cross-leg sitting, and the squatting, etc. are the modifiable cause of knee osteoarthritis. And sedentary or prolonged sitting, heavy weightlifting, excessive spinal extension, and hyperextension is cause of spinal osteoarthritis. And repetitive hand movements in knitting or typing or any other occupational hazards, their hand OA can occur. So the role of lifestyle modification in preventing or delaying osteoarthritis. Knee osteoarthritis is mainly depends on the weight reduction. If there is 10% weight reduction, there is 50% reduction in pain, and each 1 kg weight loss reduces knee load by around 4 kg. It also slows the cartilage loss. So the avoid frequent squatting, cross-leg sitting and stair climbing, also important. Physical activities and exercise, mainly the quadriceps strengthening exercise, reduces pain and progression. Avoid prolonged inactivity, leads to stiffness and muscle wasting. There are some studies which actually states the obesity relations and exercise relations with the osteoarthritis causation and progression. And this study showed that the loss of greater than 10% of the baseline body weight have significant lower resultant knee forces and lower muscles, quadriceps, hamstring and gastrocnemius forces than participants that had less weight loss. There are some recommendations for weight management in osteoarthritis. Systemic review says the combination approach of diet and exercise were recommended for overweight or obese individual in knee and hip osteoarthritis. So the effectiveness of the quadriceps strength training in adults with knee osteoarthritis, a systemic review states that quadriceps strengthening as a part of lower extremity strengthening is effective in reducing pain in knee osteoarthritis and should be prioritized in patient-specific programs. And effective exercise includes straight leg raise, terminal knee extensions, and open and close chain maneuvers over 8 to 12 weeks. So next come to the walking. Walking is very highly recommended due to the effectiveness in enhancing cardiopulmonary endurance and lubricating joints. Aiming for 150 minutes of moderate intensity aerobic activity weekly, such as brisk walking. And these are some papers which tells about the walking effects. In individuals more than 50 years old with knee osteoarthritis, walking for exercise was associated with less development of frequent knee pain. Role of walking, how to walk in an osteoarthritic knee. Start slow, begin with the shorter duration, 10 to 15 minutes, increase as tolerated, aim for 20 to 30 minutes of walking per day. Use pain as a guide. If there is pain during the walking, then stop at that point. Maintain good posture, head should be up and shoulder relaxed, back straight to promote proper alignment. Engage core muscles. A strong core provides stability and support during walking. And land softly, that is focus on landing softly on heels and rolling through two toes, which helps absorb shock. And supportive shoe is very important. Good arch support and cushioning to absorb impact, avoid high levels, replace worn out shoes. And incorporate rest days. Rest should be incorporated within the exercise and walking schedules. And other things important in osteoarthritis knee, incorporated stretching and range of motion exercises keep joints flexible and alleviate stiffness. Drinking plenty of water and is essential before, during and after workouts. For effective management of knee weight, achieving a daily goal at least 6,000 steps is advised. Avoid high impact sports, movements that place intense pressure on knees like deep squats, forward lunges and leg extensions. And the alternative exercises like cycling, swimming, aquatic aerobics and yoga also advised. Now go to the spine spine osteoarthritis. The main motto of spine osteoarthritis reduction is weight reduction. First, use ergonomic chairs for posture correction. Workplace modification like ergonomics desk setup, good for prevention of spinal pain and also good for other cumulative trauma disorders. Core muscle strengthening is very important, and avoid prolonged sitting. Frequent short breaks every 30 to 60 minutes, stretch and change posture. These are the proper sitting posture. And here another picture showing the wrong one along with the right one. You can differentiate between those two postures. And there are some home and environmental modification required for the spine osteoarthritis along with the low back pains. These are kitchens, workplace modifications. Now goes into the hand osteoarthritis. The causes of hand osteoarthritis there are many occupational hazards along with working in same positions. So to counter this hand osteoarthritis, we should limit the repeated fine tasks, use the ergonomic tools and adaptive devices. Hand stretching exercises will be incorporated into the program. These are some adaptive devices shown in the screen. These are used for different actions where our joint protections and energy conservations will be instituted. These are some other devices for hand osteoarthritis persons. This may be used in rheumatoid arthritis patients also. These are some other adaptive devices. These are lots of adaptive devices. I am not going to enumerate them. So the role of lifestyle modification on osteoarthritis treatment is mainly slows progression of degenerative changes, reducing pains, improving function, delays need for surgery. And lifestyle modification, which can be useful in treatment also, includes the weight loss, exercise, postural care, anti-inflammatory diets. The anti-inflammatory diets are mainly omega-3 fatty acids and antioxidants. So the diet in osteoarthritis, you have a good picture. You have seen many dietary forms, which are actually omega-3 rich foods along with full grains. There are paper among the diet modification reducing pain and improvement function in adults with osteoarthritis, systemic review. Here is evidence that counseling adults with OA to replace refined grains and processed foods with whole plant foods, fish and plant oil may have a favorable effect on pain and physical function. So consume high phenol, high omega-3 fatty acids diets report significant improvement in pain and physical function. Now coming to another factor, there is smoking. Smoking is always culprit in all the health issues except a few other diseases. Here also is culprit in the osteoarthritis patients. Relationship between the smoking and OA is complex and contradictory in some cases. But most of the literature supports that the inverse association between cigarette smoking and risk of knee OA irrespective of the study design. Newer studies and meta-analysis indicates that smoking is associated with increased risk of pain and functional disability in OA. Smokers report higher pain level due to neurogenic and inflammatory sensitization. Smoking negatively affects cartilage metabolism and increases systemic inflammation. So association of smoking and osteoarthritis in US, there is a around 20 years trial They show the large national study highlights a positive association between smoking and osteoarthritis prevalence in the general US population. The causal impact of smoking also there. Similarly, lifetime smoking elevates the risk of knee OA by 101%, hip OA by 55%, and knee and hip OA both commonly with 84%. So next is occupational hazard. Occupational hazard is also a big issue for osteoarthritis, mainly osteoarthritis hand. Occupational risk in knee osteoarthritis, a systemic review and meta-analysis and observational study shows that agriculture and construction sectors, which typically involve heavy lifting, frequent climbing and prolonged kneeling, squatting and standing, carries increased odds of knee OA. So in conclusion, there is healthy lifestyle is very important as it plays key role in development of OA, prevention of OA, and management of OA. Targeted and individual lifestyle modification can significantly reduce OA burden. Active lifestyle, maintaining proper diet and proper BMI, posture cares, regular exercises, adequate sleep and resting periods, and smoking cessation are very important. Finally, good mental health and motivation. It is also required to ensure healthy life. In this current era of stressful lifestyle, we have to maintain all these things. This is my reference, and thank you.
Thank you, Dr. Ghosh, for the wonderful presentation. The session is now open for question answers. If there is no questions, then we can call the session as closed. Thank you.
Thank you, Dr. Arupratan sir, for the wonderful talk on a very important topic. Before proceeding to our next session, I would like to make an important announcement for everyone. We will be having e-poster presentations in the art gallery downstairs from 11 a.m. and the quiz preliminary rounds will take place in conference room 4 from 11 a.m. Repeating once again, the e-posters in the art gallery downstairs and quiz prelims in conference room 4. So proceeding to the next session, let's welcome Dr. Ved Chaturvedi sir, consultant rheumatologist at Gangaram Hospital, Delhi, and General Secretary of APLAR. Joining him is Dr. Partha Pratim Pan sir, Professor and HOD of PMR, North Bengal Medical College, to chair the next session. Sir.
Yeah, so the very important lecture by Professor Vinod. He doesn't need any introduction, and all tall people get more attention. So he's tall in rheumatology also. He's a consultant rheumatologist at Calicut, and he's trained in UK. And all this crowd actually know better than me about him. His his awards, his publications. As you can imagine, more than 200 publications, and book chapters. And I sometimes wonder, every day he's there in the. It's a difficult job, and whatever award we have, probably he has received. He's starting from PJ Mehta oration or IMA orations, or all the orations of Euler Scientific Travel Award, and now, and he's co-editor of the Oxford Rheumatology, so it's very, very important for all of us. And he's a emeritus regional advisor at the Royal College of Physicians of Edinburgh, an honorary secretary of course, Indian Rheumatology Association. And he's co-convener of the APLAR, which I'm associated. APLAR is Special Interest Group. It's not easy all these to achieve there, because you have to work very hard. So he's special interest groups in the women health in autoimmune rheumatic diseases. I have seen a lot of SIG doing very important job in APLAR, but this women health was neglected. And he's a convener of the IRA Reproductive Rheumatology Special Interest Group, and he's the editor-chief of the IRA newsletter, member, World Association of Medical Editors, and he's PhD co-supervisor, Manipal Medical University, Higher Education, Manipal, and he's a past editor-in-chief of Journal of Royal College of Physicians of Edinburgh, and past editor-in-chief, Indian Journal of Rheumatology. So, Professor Vinod Ravindran.
Thank you, sir.
I thought I'll read everything, because I myself have not read. So today I thought I'll read it everything from A to Z.
Yeah, I was thinking that I had to cut short this slide.
Yeah,
Thank you, sir.
I wanted to cut it short, but I purposely read it whole. Thanks.
Thank you, sir. Good morning, everyone. It's lovely to be back in Kolkata. And thanks to the Society for Osteoarthritis Research and the West Bengal State Chapter of the Indian Rheumatology Association. And thanks, sir, for highlighting the journal. Look this up, and please consider the journal for your next original work. And yeah, it's a long way from where I'm based to Kolkata, but we had a lovely day one yesterday. So the topic given to me is the obesity and osteoarthritis. Is there any crosstalk? So first, disclaimer I want to submit is that I'm not an expert in osteoarthritis. So if you're wondering, why I'm here, I was also wondering. But then I got this, it still is the most up-to-date book on osteoarthritis in India. So this I edited in 2022, 2 years ago. And then in this textbook, Principles and Practice of Geriatric Medicine, the 5th edition this year, me and Kushagra wrote a chapter on osteoarthritis. So probably these are the credentials making me fit to make this presentation. So in our day-to-day life, we have lots of examples of crosstalk, but scientifically, crosstalk means that the signal interference, to put it very simply. So what has happened that traditionally the concept of osteoarthritis dividing into two things, which is primary and secondary. Primary we know is idiopathic, no cause is known, and secondary because of the other factors which might lead to early or faster degeneration of the joint in question. And the list of causes of secondary osteoarthritis is also well known. We have in rheumatology a lot of autoimmune rheumatic diseases which because of inflammation can cause. We have lots of metabolic bone diseases, and then we have some anatomical factors which can, if left undetected and uncorrected, can lead to secondary osteoarthritis in future. Now, if you consider the risk factors for osteoarthritis, well known is obesity. Okay. So, as in the previous talk, it was said that, you reduce the weight and there lies the key. But then comes the question, is this association, is that simple? So, as the Murphy's laws say, nothing is as easy as it looks. So what has happened that from a traditional viewpoint where we said the increased body weight causes mechanical stress on the joints, and that is the primary reason why osteoarthritis develops in those joints, but then we are unable to explain why it happens in the hand, or why it might happen in the shoulder. So nowadays, obesity and the sort of, the role of inflammation has also begun to be considered. So what I'll do is to make it very simple. I have got these 5 sort of things for you. One is the mechanical stress. So this is well known to us. So we know that both the sort of compressive forces and the shear forces on the joint, because of the increased body weight, can lead to joint degeneration as the time goes on. So this was a famous trial, you all know about it, ADOPT trial, Arthritis Diet and Activity Promotion trial. What was interesting to see here is that for every sort of 9.8 N weight reduction, that is typically 1 kg, there was 4-fold forces on the knee joint. And when this weight was reduced, the joints performed better. So the summary is that for each pound of weight loss, there is a 4-fold reduction on the load exerted on the knee joint per step. And if you calculate how many average steps we have to take every day, you compound that, and then you can know the beneficial effect of weight reduction because of a negation of these factors related to shear forces, which are both horizontal and compressional. So yes, it is well recognized. So for every ounce of weight, I will not say pound of weight, reduction is important for your patients with osteoarthritis. Then comes the biomechanical alteration. So what happens if you consider the chondrocyte, on the top you have got, in the bottom you got the normal mechanical stress. So there is chondrogenesis, there is maturation, and there is an homeostasis. So whatever cartilage is being lost, it is being replaced, and this cycle goes on and on. Then if there are abnormal forces, mechanical stress on the joint, then what is happening that instead of chondrogenesis, you have hypoplasia. You have lack of differentiation and maturation. And then it leads to degradation, which is not being supplemented by the ongoing healthy cycle of chondrogenesis and homeostasis. Now, this shows beautifully with each sort of phase of your stance, gait cycle. In obese individuals, there is very high mechanical stress, and this is the tibial peaks you can see. Okay, so here you got the red one, extreme sort of mechanical stress is coming on the first loading peak and the second loading peak of a gait cycle. But otherwise also, compared to the healthy weight and overweight individuals, you have lots and lots of mechanical stresses over here. So the summary is that obesity can lead to abnormal gait patterns and the weak muscles. There is a misalignment of the joint, such as varus deformity, and that is all going to increase this mechanical stress, and it will lead to early and faster degeneration of the joint in question. Then the third is the myokines and the muscle health. So the myokines, the muscle as an organ itself, has attracted a lot of attention in the recent days. So if you consider these various sort of candidates over here shown in this diagram, the myostatin on this side and the IL-6, they will lead to muscle atrophy and decrease the muscle mass, and muscle atrophy and inflammation, fatty acid oxidation, that is the fat replacement. All the other things are healthy for the muscle. So what happens in the individuals who exercise, you have lots of these sort of agents which actually promote the healthy muscle. Okay. So in individuals who are obese and not exercising, there is more and more detrimental effect on the joints in question, leading to osteoarthritis. So obese individual exercise and diet control, that is probably the best way, and that is the message I want to give here. So the release of myokines, which are beneficial in terms of regulating the inflammation and the muscle function, are important. So obese individuals, if they are exercising, of course, they are going to have much beneficial effect. Then comes the metabolic factors. So metabolic syndrome, you know that dyslipidemia, hypertension, and diabetes, and lots of other things. And it is a well-known reason to have lots of problems, chronic kidney disease, chronic cardiovascular disease, non-alcoholic fatty liver disease, type 2 diabetes, and several carcinomas. So now, if you consider this, and individuals who have metabolic syndrome, both in men and women, they can have knee osteoarthritis and hand osteoarthritis. If you consider the knee osteoarthritis, it would be more symptomatic, more in women, and typically it is BMI dependent, meaning more is the weight, more is the problem. But if you consider the hand osteoarthritis, it is not that sort of, clear-cut association with the BMI. And here the incidence is actually same between men and women. So the metabolic syndrome, including diabetes, dyslipidemia, and hypertension, can contribute to osteoarthritis. So my next segment would be on inflammation. So we have heard from Prashant that inflammation, then we heard from our PMR colleague that the abnormal shear stress and the weight can also induce oxidative stress and lead to osteoarthritis. Then finally, I got this inflammatory pathways for you. I think there is a detailed talk in the afternoon on inflammation in osteoarthritis, so I'll be brief. If you consider these two figures, so one, the lean individuals on this side, and you have overweight, obese individuals on that side. Now you look at all the candidate, what is called the immunological, parameters here, not only in terms of differentiation, expression, and maturation, there is a difference between these two. So you have more maturation and more expression of things you don't want in obese individuals. And of course, that is not seen in the lean individuals. And whatever inflammation you have, that can be considered a physiological inflammation. But here you have pathological inflammation, which will lead to a faster and early osteoarthritis in these individuals. So these two mechanisms we know very well, that is increased joint load and dysbiosis, but then you got this several different type of immunological inflammatory activities happening, contributing to the osteoarthritis in obese individual. And typically in MRI, it is shown as knee fusion and synovitis and the interpatellar fat pad synovitis. So these are also targets of some of the therapies as we had discussed, I think, yesterday. Prashant beautifully demonstrated the use of, or the proper use of diet modification in terms of management of osteoarthritis. You can see that the polyunsaturated fatty acid, which is N3 version, this blocks a lot of pathways related to chronic low-grade inflammation, which can cause pathological obesity-related osteoarthritis. So now, as we speak, there is a lot of research going on in terms of effective and appropriate delivery of polyunsaturated fatty acids for individuals who have obesity-induced osteoarthritis. And over a period of time, you have more stabilization of these molecules, and it is hopefully will convert into potentially therapeutic options for our patients who have these problems. So adipose tissues are metabolically active, and they release many types of cytokines and adipokines, which will promote the joint inflammation and joint damage. And the symptoms, so referring to Tuhina and Yogesh talk also, you can see that why these individuals have much more pain, which you can explain by whatever findings you have. So there is a role of this chronic low-grade inflammation in these individuals who have obesity. Then finally the question comes how to manage these individuals. Now, if you see, now by the way, this chapter in the book was written by Kaushik and the organizing secretary of SORCON 2025, Dr. Vishwajit. So the weight reduction is a part of the core treatment strategy of osteoarthritis. Okay, and it comes right on the top. So no wonder in all the guidelines, weight loss is almost universally agreed or strongly recommended, any guidelines you consider. So then comes the question that how much you should aim for. So typically 10 to 20% of reduction on the BMI is more beneficial compared to an untargeted approach towards weight management. So weight reduction definitely a yes, and then of course more is better, as we say, for management of hypertension or dyslipidemia. So this is a sort of the summary slide for you. So traditionally our thinking related to obesity-induced osteoarthritis was that it is only because of the increased mechanical stress on the joint. But current and ongoing research tells us that this is not the case. You have a lot of immunological phenomenon on the obese individuals, which is causing detrimental effect on a joint, which will lead to a sort of fast and early osteoarthritis. And these joints are not only the weight-bearing joints, such as knee or hips, but also the joints which are not typically weight-bearing, such as hands and shoulders also. So this is the current state of the art as far as this particular topic is concerned. If you combine the talks from Dr. Prashant and our faculty from the PMR, and what is following on this afternoon on inflammation and osteoarthritis, you get a pretty good idea where this research is going to lead to. Now, this is of course, osteoarthritis is not topical rheumatology, it is a global rheumatology, osteoarthritis. But if you are interested in this book, has been released early last month. And then if you are interested in holding on to this or getting a hold on the copies of this book, that's the Publishers Workshop website. So thank you very much for your kind attention.
Thank you, Dr. Ravindran, for a very elucidative talk. The session is open for any question.
I just wanted to ask you, patients who have had bariatric surgery, have you found any difference in their osteoarthritis after they've had bariatric surgery?
Sir, I have not come across any direct literature, but you can sort of, postulate that the weight reduction, so the issue with the weight reduction is that whatever has happened, it is not going to be reversed. So whatever pain or the suffering is to the individual because of the increased mechanical stress would be negated. But whatever damage has happened will be there. So comes the question of, if you do the bariatric surgery, the mechanical load is off, and then you build on the the muscular strength, and that, as I showed in the second component, is also helpful. But of course, it's not a preventative surgery for the obesity-induced osteoarthritis.
Thank you, Dr. Ravindran. It is well known that mechanical factors contribute to the weight-bearing joints, as you mentioned. Now, when it comes to hand osteoarthritis in particular, nodal osteoarthritis, obesity, have there been trials to connect obese patients directly to hand osteoarthritis, invoking the inflammatory theory? That's the first question. And secondly, even if they're not diabetic, what would be the role of metformin in those?
Yeah, and these are some excellent questions, Dr. Rajmani. I will try my best to answer it. So the concept here is, where we used to think is primary, we are coming to sort of acknowledge that is all because of low-grade inflammation caused by obesity in individuals who are obese. Okay. So similarly, so the question is, you can see that this link is not that straightforward, because lean individuals can also have hand osteoarthritis. And in last week only I saw two patients in my clinic. So the effect of obesity, even if it is because of low-grade inflammation, is more pronounced than clear-cut in weight-bearing joints. Okay, so that is the caveat. That's why in terms of expression, you see different sort of, male-female distribution, and also the pathways which are involved are not that distinct. And the second question was role of metformin. Metformin, I think, so my understanding about metformin is that it can be part of your management strategy to reduce the body weight, but it cannot be the only thing. I have shown you that diet and exercise, these are the only two ways to actually, address this problem, because you have to tackle the issue of lack of muscle tone and strength also. That will come only by the exercise. Yes, sir.
Good morning, sir. Thank you for your nice deliberation. I have two small questions. That to reduce the obesity, you have also advised about the different exercise protocols. But in your picture also, as I know, that there are multiple exercises can't be done by the osteoarthritic patients in the weight-bearing regions, like the knee way, hip way. They can't do all the exercises. So what kind of exercise do you advocate primarily? This is my first question.
So this is a preventive strategy. That's what I'm saying. That don't become obese. Okay, once you are obese, as you said, there is a lot less you can do about the situation. So these are preventative strategies. So obese individuals beyond a point in obesity itself, it will be difficult for them to actually lose weight. So that is, of course, a big challenge in clinical scenario.
My second question is, do you advocate the present weight-reducing drugs like GLP-1 inhibitors like tirzepatide or liraglutide or semaglutide, these things in the management of the obesity who are prone to osteoarthritis or in the early stages of osteoarthritis?
I think, yes.
There was a paper use of the semaglutide for the osteoarthritis in obese patient. So is it can be used regularly, or what is the recommendation?
Thank you, sir and ma'am. As a rheumatologist, I would say I have hardly any exposure to these medications.
There is no recommendation.
There is no effect. I would say that especially the newer drugs, weight-losing drugs, I think jury is still out. Their usage itself in the given indications for which they have been sort of, undergone trials is not universally accepted. So I would be wary of anybody using sort of, these therapies unless there is a metabolic sort of, reasons for them to have it, not just because the weight reduction should. Because in terms of weight reduction, the question comes with what is the sustainability? Once you come off the drug, then what is left? What can you do? Can you continue on the drug lifelong? Because osteoarthritis is lifelong. Thank you, sir.
Semaglutide. Regarding semaglutide is probably a milestone in the treatment of osteoarthritis, because it shows the previous trends, what Dr. Vinod Ravindan showed, that reduction of weight is not equal to the pain reduction. Pain reduction is much more, at least 4 to 5 times than the reduction in weight. Yeah. That is the milestone. But regarding semaglutide, I have a caution. Already there are reports that semaglutide may produce significant amount of depression and suicidal tendency also.
Thank you, sir.
I think last question. Yeah.
Small question. Is it the overweight or cumulative weight gain is the fault?
Is it?
Is it the overweight? For obesity, overweight causes the osteoarthritis, or cumulative weight gain is, which one is?
Is it like, so if there is a sudden gain in weight, there will be some time before an individual develops the signs and symptoms of osteoarthritis. But if it is a cumulative process, then of course your age is also increasing, the muscle deconditioning is also happening, and then it becomes a problem beyond a point.
That is the key.
Yeah, thank you, sir.
You have mentioned about the diet, the food rich in PUFA is good for osteoarthritis. Can you mention just directly that helps in the to prevention of osteoarthritis, which are the diet? what will be the advice for the osteoarthritis patient? These are the diets should be avoided. Not causing indirectly the obesity. In the
I think,
other
you know, I think obesity itself is a...
No, not for
I
the
can-
directly
I-
obesity. Suppose red meat, alcohol, is it a...
I can tell you, now in corporate hospital, there's a department of obesity. Forget about osteoarthritis, ISD.
not
and
reducing the body weight, but
Sir,
with the direct...
I would try to give you a different answer. When I was reading the literature around this in preparation for this talk, the question I wondered whether can this PUFA be injected into the joint? I did not find any literature supporting that. Now, if you consider, the weight management strategies or the treatment of what is called the metabolic syndrome, the drugs, the diet which is used is actually rich in PUFA. Okay, and that is where, so the research is, how can make the drug, if you consider PUFA as a drug, how you can make its delivery better and the stability better? That is the question, which is happening in terms of research.
Yeah,
Thank you, sir.
epidemic of obesity, and obesity itself is a huge conference by itself. There has to be a conference on obesity. If only those questions which is there in the mind can be answered. Vinod can't answer all those.
And may I say only obese individuals can come. Thank you.
Thank you so much. Thanks for
Thank
an
you, sir.
excellent
Thank you.
presentation. Thanks.
A quite relevant and important talk on obesity and OA, and who could have been better to touch upon the topic than respected Vinod Ravindran sir himself. Thank you, sir. So, bringing to your notice once again, for the presenters, the e-poster will be taking place in the art gallery downstairs from 11 a.m. and quiz prelims in conference room 4 at 11 a.m. The respected faculties who would be judging the e-posters are informed that the e-posters in the art gallery, the judging session will be from 1 p.m. So let's start the session 2 of the day and get some insight into the basic sciences in osteoarthritis. For the first talk of this session, I would like to call upon stage Dr. Anirvan Bhaumik sir, Assistant Professor, Department of Medicine, Tripura Medical College, and Dr. Arghya Chattopadhyay sir, Consultant Rheumatologist at Asian Institute of Immunology and Rheumatology, Kolkata. Sir.
Good morning, everyone. As we all know, osteoarthritis is due to some wear and tear process. We also call it a degenerative disease. With all our sessions previously targeting the pathology, the risk factors, the treatment, and the preventive strategies like lifestyle modifications, diets, and also the drugs targeting the chondrocartilaginous system. Now today we have a session this time which gives a fresh angle to this whole discussion. Whether we can regenerate or again get whatever we have lost, that is this whole chondrocartilaginous system. So without wasting much of our time, I welcome Professor Saurabh Ghosh from IIT Delhi for this talk on chemically modified silk gelatin biomaterial for cartilaginous tissue engineering. Welcome, sir.
Thank you for the organizers for giving me chance to present my talk. So, since yesterday I have seen many times this presentation was showed in this conference. So we can present that osteoarthritis is a chronic degenerative disease marked by phenotypic alternation including degeneration of articular cartilage, extracellular matrix degradation, synovial inflammation, neovascularization, and osteophytes formation. So, yeah, thanks. So basically, we will focus on hypertrophic chondrocyte. So here we can see that all these chondrocytes will become much clustered and they will be larger in dimension. So when I was working with Professor David Kaplan in 2008, we have this study where we cultured silk and chitosan, and then we conjugated silk with BMP6 and chitosan with BMP6, and then we isolated all this primary chondrocyte as well as adipose tissue derived MSCs, bone marrow derived mesenchymal stem cell, and I went to Professor James Thompson's lab, and from Professor James Thompson's lab we isolated embryonic stem cell, because Professor James Thompson was the pioneer in embryonic stem cell differentiation. And then by two different protocols, we try to differentiate embryonic stem cell to mesenchymal stem cells. And we found that aggrecan and collagen type 2 was equally upregulated in all conditions. But if you look at very carefully about collagen type 10 was also very sharply upregulated. So that means we are successful in inducing chondrogenic differentiation using all these cells, but we cannot control the differentiation with respect to collagen type 10. So then we have, since last many years, we are working on cartilage development formation, cartilage development using osteoarthritic chondrocytes as well as mesenchymal stem cells. So we can try to differentiate these mesenchymal stem cells to SOX9 and collagen 2 type cells, and then we can try to differentiate towards articular cartilage. But there is another issue that we cannot have, we can have transient cartilage. So by BMP2, 6, Indian hedgehog signaling pathway, VGF, they will also be upregulated. So we got this hypothesis that if we form cartilage by forming wind, and then there will be noggin as a layer, and then BMP will be clustered, then probably we will be able to develop permanent cartilage. So as I mentioned, our lab is focused on 3D bioprinting, and then we formed we published many papers using silk and gelatin to form the bioink, and then we published that then we can have long-term cell viability, as well as we strongly upregulated Wnt beta-catenin cellular signaling pathway. But the small molecules and growth factors we are using to develop chondrocytes are exogenously added to the media. But all these small molecules are having very short half-life. Then we try to, by 3D bioprinting, we ensure that all the cells will be uniformly distributed, but all the cells will add small molecules and growth factors non-homogeneously. And then cartilage, the chondrocytes, we will try to have normal chondrogenic differentiation, but the maintenance of stable articular phenotype in osteoarthritic medium has not been studied. So to chemically conjugate the small molecules, various small molecules we try to conjugate with silk fibroin, and then how we can assess their release profile, and to analyze all the small molecules which are covalently conjugated to the bioink, so that might be able to help to mitigate the problem of hypertrophic situation. So this is first example by which we can form cartilage. So we can first focus on large latent complex of latent TGF-beta3, and then we'll try to release that study by cyanuric chloride, and we published this study in Advanced Healthcare Material.
So when we add TGF beta 3, it will be depleted very fast within 4 to 6 hours. So then in vivo, this TGF beta propeptide will form a multimeric complex with matured TGF beta polypeptide and a latent TGF beta binding protein. So in vivo situation, when these three complex will form a multimeric complex, then only it will be activated. So the covalent conjugation of TGF beta 3 with silk fibroin matrix using cyanuric chloride coupling will be very much beneficial to replicate this large latent complex formation of TGF beta 3. So we try to form that type of complex using computational modeling, and then it was validated by ATR FTIR. And then we tried to, we got healthy human chondrocytes from Apollo Hospital, and then we also used human bone marrow mesenchymal stem cells, and then we have silk, only silk, and then where we added TGF beta in media, and then where we have covalently conjugated silk and TGF beta. And in last form, you can see in last row, we can see that the silk and TGF beta is covalently conjugated. And then we try to study about all safranin O and Alcian blue. And we can conclude that where we have covalently conjugated this silk and TGF beta, it got very, very good expression of these proteoglycans. Then we studied gene expression from those cells, human articular chondrocytes, as well as human bone marrow mesenchymal stem cells. And then we have, in the pink color, we have the highest expression of silk TGF beta when we checked collagen type 2 and agrican. And when we have silk, which are at day 28, then the collagen type 10 and MMP13 was significantly downregulated. And TGF beta R1 was very strongly upregulated in both cells. So then that will give us some conclusion that gene expression studies confirmed elevated expression of chondrogenic genes and downregulation of hypertrophic markers of TGF beta 3 covalently conjugated to silk compared to all other conditions. Then second strategy will be to inhibit inflammation and bone marrow signaling pathway. And then we already mentioned that we have reported that there will be Wnt beta-catenin pathways are severely upregulated in silk gelatin bioink. And then probably if we can create the inflammatory hypertrophic condition, then probably we will be able to replicate cartilage formation. But the problem is if we have LDN 193189, so the LDN should be up continuously. It is a very short half-life from 1.6 to 4 hours. And IL-1RA will have 4 to 8 hours short half-life. And TGF beta 3, as I mentioned in fast case, it will be completely depleted around 50 minutes. And then we published another paper in SES Applied Materials and Interface. So first we try to develop a molecular model, and then we analyzed all different conditions. So where silk and LDN is conjugated, silk, CYCL and LDN is covalently conjugated, TGF beta and then silk, CYCL, TGF beta. So all this, after developing that model, we tried to form ATR FTIR, and then here in this particular case we try to see if how LDN, if it is mixed in the media, how it is degraded, and if we can have covalent conjugation, then we will have strong and continuous release of LDN with respect to in the media. Then how we optimize the 3D bioprinting process by varying the concentration. We have 3 different conditions where only silk gelatin and then we covalently conjugated CYCl with respect to silk gelatin, and silk gelatin which is covalently conjugated with diazonium coupling. And then we have shear thinning behavior in these three conditions. And then we try to print the structure into form a cartilage by 3D bioprinting method. And all these three conditions are more or less similarly expressed in this 3D bioprinted condition. Then we collaborated with Professor Ivan Martin's lab, and from Professor Ivan Martin's lab, we isolated human bone marrow derived mesenchymal stem cells from 3 patients. So donor 1 is around 43 years old, donor 2 is around 18 years old, and donor 3 is around 28 years old. And then we transferred those cells from Switzerland to our lab in Delhi. And then we tried to measure all gene expression with respect to donor 1, donor 2, donor 3. And then our condition was that first we tried to induce chondrogenic differentiation media or proliferation media for 14 days. And then osteogenic media, this osteoarthritis inducing media will be for another 28 days. And then how this gene expression is changing. And then we got gene expression from these 3 patients, and we compared these 3 patients' data, and we conclude that the donor 2 human bone marrow mesenchymal stem cells are displaying maximum chondrogenic trait by gene expression, and then by Alcian blue staining. And the bright field microscopy image will reveal homogeneous cellular distribution in 3D bioprinted condition. Then we try to analyze the gene expression pattern and the biochemical estimation from donor 1, donor 2, donor 3. So this is the gene expression pattern from donor 1. And then the conclusion is IL-1 RA group will demonstrate the highest expression of chondrogenic markers like collagen type 2, proteoglycan, SOX9, and it will be significantly downregulate all the hypertrophic markers, for example, collagen type 2 and MMP13. And then we also studied all different other markers, for example, Noggin and DKK1. So they are also very strongly downregulated if the BMP signaling pathway is activated by if we can inhibit the BMP signaling pathway. So this is collagen, this donor 2, and this is donor 3. But if we can analyze the gene expression pattern of donor 2, we can conclude that despite we try to induce inhibition of that BMP signaling pathway, this donor 2 is showing continuous upregulated elevated expression of LDN. And that will indicate that the BMP signaling pathway is probably, it is depending upon different isomers of BMP will play very important role in cartilage formation. And then we checked after gene expression, we can conclude that probably the donor 2 is expressing the highest level of protein expression and by histology. And then we can conclude that highest collagen type 2 protein expression is expressed in IL-1 RA conjugated group, both in presence of inflammatory condition in day 28. And lowest collagen type 10 expression was observed in IL-RA condition when it is covalently conjugated in pro-inflammatory condition. And then we also studied collagen type 2 and collagen type 10. So both LDN and TGF-beta IL-1 RA, when they are covalently conjugated, they were downregulated compared to the control condition. So then for third strategy, we try to collaborate with Professor Amitabh Bandyopadhyay from IIT Kanpur. And then in this strategy, in first strategy, we try to covalently conjugate only TGF-beta. And then in second strategy, we try to conjugate 3 different molecules with our bioink. And in this is the in vivo study where we try to dissect the anatomy, that anterior cruciate ligament, and then we allowed that mouse to grow for 28 days, and then we try to have 2 months, 4 months, and 6 months of data, and then so this is 2 month and 4 months data, and 6 months data is still cooking, and then we can conclude that there will be successful regeneration of articular cartilage post 4 months implantation, and that is showing by very dense safranino staining and collagen type 2 staining. So we can conclude 5 different formations. So right now we are focusing on these 5 questions. So hypertrophic differentiation is very similar to endochondral ossification process. So this acquisition of dedifferentiated phenotypes of primary chondrocytes during expression of maybe it can be one reason which can lead to hypertrophic phenotype. Intrinsic property of stem cells to undergo hypertrophic maturation under the influence of chondrogenic stimulants through the dysregulated activity of chondrogenic signaling pathway. And maybe there are various papers where HIF1 alpha and HIF2 alpha are playing very important role in playing the hypoxia. We are now trying to control that hypoxia using our bioprinted construct. Imbalance in mechanical loading condition during in vitro chondrogenesis will also lead to different cartilage formation. So it might be transient cartilage or a permanent cartilage. So by playing with the mechanical loading, we can study which condition will try to develop this cartilage. And so far, we conjugated these 3 different molecules with the bioink. So can we apply a strict checkpoint to ensure a proper balance between chondrogenesis and hypertrophy? And thanks for your kind attention.
Thank you, Professor Ghosh, for an insightful talk on futuristic therapy of osteoarthritis. Before opening this for the hall to questions, I have a couple of questions, sir. How much this can be clinically translated, like how this is a lab parameter. So if we look into the history of rheumatoid, like we're very excited with the invent of interleukin-1 inhibitors, and we thought it's a cure of the rheumatoid arthritis. But when translated in the clinical setting, that it failed. So this lab parameter, how much you think that can be clinically translated? Second, we are mostly concerned with the knee osteoarthritis, though it can happen with other joints. So there is a significant portion of the mechanical factors that plays into the role of the knee osteoarthritis. So whatever cartilage will regenerate with this process, do you think that will be good enough to clinically translate into the pain relief and functional disability improvement? And is the dose-dependent hypertrophy what is the concern? So if used for the mouse model, whatever doses for human, whenever using the higher dose, whether there will be chances of getting malignancy or not?
Yeah, these are very relevant questions. So we are collaborating with Professor Amitabh Bandyopadhyay. He is the next speaker. So we are trying to study. This is the first report about human about rat to develop knee joint cartilage. So after that, we need to use this model on beagle dog. So after that, maybe we will take it further for human clinical trials. For your second question about the mechanical loading, so now we are trying to study by bioprinting, we will study that how different type of loads will play different, maybe so for one group it will lead to very good cartilage, in another group we will see that if we apply very much mechanical loading, it will also destroy, and then whether that destruction will lead to hypertrophy. So that we will try to study. And what is your third question?
So, is there a chance of dose-dependent malignancy?
So that we cannot study, we cannot conclude right now.
House is open for the question. Just.
One thing is a little bit confusion for me. The donor number 2, donor
exactly. So it was a very younger patient, so it could be age-dependent process, or it can be different BMP isoforms can also play very important role. So we are studying on that.
Do you think, sir, any role of the genetics, like individual genetic signature, will play a role in for the thing, sir?
Good morning. Here, sir. Here. Yeah. Excellent approach, and possibly this is the future of medicine, cell therapy. Cell therapy. I have a one query or two queries. What is the long-term effect number? Because when you put something, and if you look that it's fine, but what is the long-term effect? Because you have activated various signaling like WNT signaling, and that produces small molecules and that goes to the body and whatever happens. That's one concern. Second, that it's very known nowadays that the mechanical force altered the gene expression. So whatever we are showing in the three-dimensional model, in the gel in vitro model, that may be modulated when you put into the knees and underweight and other things. So that has to be looked into that. How mechanical force alter the gene expression in real life.
So for this cartilage bioprinting, we have studied that at least we can keep that cell for at least 2 months. So till 2 months, what happens I can tell, but what will happen after the long term, that we do not know the answer.
No, but that has to be looked into, I believe, because you are replacing some external cells within the body, etc. So you have to look into.
Sure.
And second, how mechanical force altered the gene expressions, rather basically that's possibly a.
So there are groups who studied about the role of mechanical loading on different cartilage formation. So we have just studied that process.
Okay, no, that's fine. You know, these are the 2 points I believe has to be focused on.
Sure.
Thank you very much.
Excellent talk. So I was captivating with the thought process that now we have a scaffold that we can take up the negate the whole overall pathology. But my question is, how do you deliver in a real life? So what is the concept that you are thinking how to deliver this idea? And what will be the start signal? What will be the stop signal in a real life?
So we have first we published lot of papers on cartilage tissue engineering. So now we are trying to develop collaborative study using rat model. Then we will try to translate to beagle dog model. And then probably if everything goes all right, then we will probably take it to Apollo Hospital. And then Apollo Hospital's doctors, we are already discussing with Apollo Hospital's doctors. They will probably initiate the collaboration. So right now we cannot know the answer.
Thank you, sir, for an excellent and insightful talk. If there is no more question, we'll close the session.
Thank you.
Thank you, Saurabh sir, for this wonderful talk. Again, for those interested, we will be starting the quiz prelims in conference room 4 from 11 a.m. That is in 10 to 15 minutes. And for the poster presentation, it will be taking place in the art gallery downstairs, that too from 11 a.m. And the judging session will be from 1 p.m. So join me in welcoming our next chairpersons on stage, Dr. N. Romi Singh sir, professor and former head of department of PMR at RIMS Imphal, and Dr. Manish Kumar sir, consultant rheumatologist from Patna. Sir, please.
Good morning, one and all. So we're having another very interesting session on basic sciences. It's on articular cartilage can be regenerated experience from Murine model. So it's very interesting for all of us, the clinicians, when basic sciences can be translated to something like regenerative medicine, which we all are talking about. So without further delay, I request speaker, Dr. Amitabh Bandyopadhyay, to come over and take mic. So regarding the regenerative medicine, yes, we have heard from the previous speaker. Now, these are all in probably phase 1A/B trials, which we are going to translate. So we hear from you, Dr. Amitabh.
Thank you very much. I must thank the Society of Osteoarthritis Research to give me this platform. I am basically an embryologist. I study how our limb develops and how it attains its shape. And then one thing led to the other that I will take you through very briefly. And today I am making a claim that articular cartilage can be regenerated based on our studies on murine models. So how it all started. So as you all know that our bones are formed through endochondral ossification, and initially the whole element was purely cartilage, and then majority of it becomes bone. Only the two ends remain as cartilage. So we asked a very fundamental question that how is it that the same cartilage gives rise to two different kinds of tissues? One is bone and the other is permanent cartilage or joint cartilage. And we figured out that there is one population of proliferating cells, which we call the distal proliferative zone cells. Those cells, if they come under the influence of BMP signaling, they will become bone-forming cells. And if they, I'm trying to turn on the pointer, and if they experience Wnt signaling, then they will become articular cartilage or joint cartilage. So that we published in 2015. Then we built onto it. We knew that in the embryo, if you do not allow the embryonic limbs to move, then the whole cartilage becomes bone-forming cartilage. So we wanted to know what is the molecular basis of it. And we figured out that if there is no movement, then the cells which are supposed to become joint cartilage, they then get exposed to BMP signaling, and as a result, the whole element becomes bone. So that is 2018 work. After that, we started to think that there is a striking similarity between the pathology of osteoarthritis and endochondral ossification, because in both the cases, cartilage, through identical steps, become bone. And I knew from my postdoctoral work that without BMP signaling, no bone formation is possible. So therefore, we asked a question that, is activation of BMP signaling sufficient for osteoarthritic changes in adult articular cartilage? So far, we were working with embryos. So we used genetic means and many other means to actually demonstrate that activation of BMP signaling is sufficient. But what was the first insight in the literature, that if you induce osteoarthritis surgically by cutting the anterior cruciate ligament, you see that the cells, they become BMP signaling positive. So I would request you to kindly remember that phosphorylated SMAD159 immunoreactivity is the sign of BMP signaling being active. And what we did next is that we took young mice where there is no sign of osteoarthritis. We only injected little bit of BMP protein in the intra-articular space, and you see within 2 days, BMP signaling is turned on, which is normally not there, and the two markers that we follow, type 2 collagen for healthy cartilage and type 10 collagen for osteoarthritic cartilage, and you can see that the type 2 collagen is completely gone within 56 days. It goes from, good to low in 28 day, and 56 day it is gone. You can see the quantification on the graph next to it. Not only that, you see that the saphenous staining is completely gone. That means that there is no cartilage. That matrix is gone. Then my student, Bhupendra, he set up this very elaborate scheme to study osteoarthritis in aging mice. And you see that as age progresses, at 6 months, you do not see the joint cartilage cells expressing BMP signaling. By 18 months, you see it is started. 24 months, it is raging, and it goes on. So again, the quantitation is there. And as you would expect, that the type 2 collagen from the surface articular cartilage goes down within the same period, and type 10 collagen comes back on. So besides post-traumatic, the age-induced model also shows that BMP signaling comes up. Then my student Sahiba, who will be giving a talk in the afternoon, along with my colleague Professor Sai Paidi, they created a obesity-induced mouse model. And you can see that if the mice is fed high-fat diet and gains weight, then osteoarthritis sets in, which is well known, but it is associated with uptick of BMP signaling. Sahiba also wanted to set up a model for post-menopausal osteoarthritis. So initially she did ovarectomy by removing the ovary, and within 28 days, which is very aggressive, you see upregulation of BMP signaling. Now she has used another model that she will present. There also, you see that BMP signaling is coming up along with osteoarthritic changes. So therefore, you see that activation of BMP signaling is involved with every form of osteoarthritis, irrespective of how it occurs. So then the question is, can BMP signaling inhibition reverse osteoarthritis? I would request you to take a note at the time point. In adult mouse, P120 meaning 4-month-old mouse, that is adult, there, if you cut the ACL, hypertrophy and wear will set in within 28 days. Here, I am interfering with it after 35 days of surgery, meaning by this time, all the cells are supposed to be hypertrophic. And you see that even then, when I inject this BMP signaling inhibitor called LDN 193189, see that the call-to expression again came back, which was lost in the vehicle-treated animals, and call-10 expression is largely down. What it means is that when I injected, cells were already call-10 positive. Even then you see some recovery or reversal. Even with age-induced way, you can imagine that 24 months of history of aging and only 1 month of treatment with LDN, we see protection. Now, the issue is that in these cases, osteoarthritis is already there. Then we are inhibiting BMP signaling and we are seeing formation of type 2 collagen expressing cells. So then the question that we wanted to ask is, can osteoarthritis be reversed? And if yes, what is the mechanism? So in our earlier paper published in 2023, we realized, and for the audience I should tell you, I am not showing you the data, that at least in mouse, the joint cartilage cells are very long lasting. So if the same holds true for humans, most of you sitting in this room have joint cartilage which you were born with. Okay? So normally they are quiescent. Do ACL transaction, osteoarthritis inducing surgery, you see massive cell proliferation. This is BRDU incorporation data. I will come to it a little later. So we thought that maybe the articular cartilage cells proliferate and try to heal, but obviously it cannot heal. So we wanted to know what is the fate of these newly born cells and how it interacts with the BMP signaling manipulation. So we set up this elaborate experiment. We conducted the ACLT when the mouse was 10 weeks old. We injected BRDU, so when cells proliferate, they incorporate DNA monomers into polymers. So thymidine is a normal DNA monomer. BRDU is an analog of that monomer, which you can detect with an antibody. Now please remember that if the cells divide multiple times, then you will not be able to see the BRDU because it will be too diluted. If the cells take it up and sit there, BRDU will be detectable. So now we put BRDU on day 7, 8, 9, just to remind you that by day 28, osteoarthritis has set in. We injected either vehicle or LDN on 42nd day. It is raging there. And we harvested on 84th day. And you see what happens. See, we are only tracking the newly born cells, cells that took up BRDU because of the ACL transaction. You see, those cells in vehicle treated, they are not expressing type 2 collagen, they are primarily expressing type 10 collagen. So it is the quantification. But if they were treated with LDN, then you see that the type 2 collagen expression comes back, type 10 collagen expression goes away. Now you see the number, that it was an 80-20 distribution without LDN and a 20-80 distribution with LDN. So the only way it can happen is that the cells that were born post-ACL transaction became hypertrophic. With BMP inhibition, they again came back. Now we started scratching our head that how can it possibly happen? Because hypertrophic cells are supposed to become bone. So my student Fauzia, whose work I am not talking about here elaborately, she found from the literature that there are some instances where they found that hypertrophic cells take up BRDU, which was really unthinkable. Before Fauzia pointed it out to me, I did not know that, because we all thought hypertrophic cells are the end of life for cartilage. Not only that, there is another publication in zebrafish during development that hypertrophic cells express a marker for stem cell. Okay? So we looked at in our setup. So after doing the ACL transaction, we looked at two markers of stem cell, OCT3 and NANOG. And you can see that all the hypertrophic cells, like this green is for coltan, so all the hypertrophic cells, they actually express these stem cell markers. We are now studying it much more elaborately in a system where it is reversible. Osteoarthritis is reversible. So just like as you all know that if you put a cast in a hand or a leg joint, there will be temporary osteoarthritis. We have recreated that in mouse, and Fauzia is studying it in detail. She will talk about it in the afternoon session. That there also you see upregulation of phosphosmat, as Sir was talking about, the role of gene loading in gene expression changes. So we are studying it in detail. And type 10 collagen expression comes up within 28 days. And when you remobilize, just like what happens with us, type 10 collagen goes away and type 2 collagen comes back. So this is a perfectly reversible system without any genetic intervention, no surgery, nothing. So Fauzia is studying in detail to understand the genetic underpinning of this whole thing. So what is our working hypothesis now? Our working hypothesis is that all murine models of OA trigger activation of BMP signaling in the joint cartilage. Exposure to BMP signaling induces hypertrophy in the cartilage cells. These cartilage cells seem to be stem cell-like. And now, depending on whether there was a molecular perturbation or mechanical perturbation, if you restore the system, then the hypertrophic cells, which are stem cell-like, they get an opportunity to become healthy cartilage. If you don't give it the opportunity, then it will become bone. So far, I addressed the title of my talk, I will now give you a little bit. In the last session, there was discussion about translation. So we are quite gung-ho about BMP signaling inhibitor as a drug target. I'll tell you why we are so excited about it. That when we treat with BMP signaling inhibition intra-articularly, local inhibition, you see that all the inflammatory markers that we have checked so far is gone. So, but I do not think there is any result that does the reverse. That if you block inflammation in an osteoarthritic model, the Colton expression will not go down, okay, or phosphosmad will not go down. So, but we have one limitation. So far, we have not been able to assess pain. We are trying to get the setup done. Second, this BMP signaling inhibition is quite interesting. The half-life of the chemical is only 4 hours. But once you inhibit, the effect lasts for at least 3 months in mouse. We investigated a little bit, and we saw that the BMP receptor in a cell culture system, it goes away if you inhibit the signaling pathway. You look at it here, you can see the distribution. BMP receptors are all lined up along the fibers. You treat with BMP inhibitor, it largely goes away. Little remnant is here and there. Maybe that's why it takes so long. So the takeaway message is that BMP signaling is the common denominator for all forms of osteoarthritis. Induction of OA triggers hypertrophic differentiation, and hypertrophic cells have stem cell-like property, can revert to healthy cartilage if BMP signaling is blocked. Problem is that I cannot go for clinical trial or even large animal trial with LDN because it costs money. No sane individual will invest money in it because this chemical is available off the shelf. So you cannot hold patent. So now, in collaboration with my colleague, Professor Ritika Gautam, we have identified novel BMP antagonists. My student, Chanu, is talking about it right now in the poster session. Long time back, I created a cell line, which is a BMP responsive reporter cell line. Using that cell line, we screened close to 250 compounds, and we identified 3 very high quality antagonists, and now we are chasing those. Okay? So thank you very much for your attention. I will take any question.
Yes, that's a wonderful insight you've given us, Professor Amitava. Now the topic is open for discussion or comments, please.
Fantastic.
Thank you,
You have shown at least cellular heterogeneity in the cartilage, looking into 2, 3. So, is there any report of single cell sequencing in this using the cartilage? Because the cellular heterogeneity is likely to be more.
Yeah. So, sir, molecular biology is my forte, and I am very conservative. I'll tell you why. See, in the cartilage, the cell population is only 5%. I am apprehensive that when I try to isolate cells from that normal articular cartilage, I will disturb the mechanical environment, and the gene expression will change by the time I go for single cell sequence.
I understand. That's a concern, I understand. But still, the heterogeneity could be
Yeah.
manifold. And again, in the what are the receptor for BMP responsive receptors and WNT responsive receptor?
Yeah.
Because as you shown in the first slide, possibly or second slide, that they are responding to, there is a heterogeneity in the cells. Some cell is responding to the BMP and some cell is responding to the WNT.
Yeah. So just to clarify it a little bit, I view it slightly differently. You imagine the very early bone as a cylinder, and only this population is proliferative. When within an enclosed space the population is proliferating, it has no option but to grow in these 2 dimensions. So now the signaling ligands are localized. Wnt is only expressed on the surface. So those that will move there, they will face Wnt, and the other that will move towards the center, they will face BMP. BMP has its own receptor, BMP receptor 1A and BMP receptor 2. And Wnt has its own receptor, which is kind of like a G protein coupled receptor.
So there is a special distribution.
Yes.
So again, in that case, I will request you to think about that the nowadays single cell coupled with the special single cells, that will give you possibly is a more comprehensive idea.
Yes.
Thank you very much. It's fantastic.
Thank you. Thank you.
So if there are no more questions, we'll close the session. So both the chairpersons would like to thank the organizers of SARCON for giving a chance to chair the session. Thank you.
Well,
one and all.
thank you.
Thank you, Dr. Amitabh sir, for your enriching talk on such a complex topic. Respected delegates and faculties, I have an exciting announcement for you. Those interested in becoming the member of SOAR can now avail it at a discounted membership fees of 5,000 rupees. To register, please visit the IPCA registration desk located outside. I would also like all of you to know that we have already started the e-poster presentations in the art gallery downstairs and the quiz prelims in conference room 4. Those interested can visit. So for the next session, let's welcome upon stage Dr. Vijay Lakshmi Venkateshan Ma'am, Director, Research at Region X Orthosport and former Scientist G, ICMR. Joining her will be Dr. Niladri Sarkar Sir, who is the Head of Department of Medicine at IPGMER, Kolkata. Sir, ma'am, please.
A very good morning. So I thank the organizing committee for giving us this opportunity to chair the session. And on behalf of my colleague, so we invite Dr. Rudrapan Chatterjee, Assistant Professor, Department of Clinical Immunology and Rheumatology, SGPH Chandigarh, Lucknow, to come and deliver the talk.
Okay, so a very good morning to everyone, and thank you, the organizers, for presenting me with the opportunity of presenting today. So I'll start off with apologies because what we were promised in the program was probably a Lamborghini, and what's turned up is a bit more disappointing. But to take that metaphor further, both of us, immunology of osteoarthritis is like a bumpy Indian road. We don't work primarily in basic immunology of osteoarthritis in our research. So we'll get you to your destination. The ride will be a little bumpy, and maybe you won't feel as good about it with me as you would have with Dr. Amita, but she's unfortunately got a fracture, couldn't travel tonight. When you think of osteoarthritis, you don't think of an autoimmune disease. You think of it in terms of a degenerative disease related to trauma, to aging, and metabolic derangements. But although a room full of strapping young individuals might not worry about these things that much, who does care about these things is your immune cells. They are bothered about these in the terms of mechanotransduction, in terms of immunosenescence, as well as immunometabolism. So looking at a joint in osteoarthritis, you have and this is the prototypic knee joint where we see osteoarthritis. You have the femur and the tibia, the synovium in between, and the intrapatellar fat pad. The most important here being the synovium, which has a lining and a sublining, and this is an immunologically active tissue made of type 1 synoviocytes in the lining, type 2 synoviocytes, which are fibroblast-like in the sublining, and you have the fat pad, which has adipocytes and some immune cells. In osteoarthritis, there's a lot of dysregulation, the lining and the sublining hypertrophies, there's infiltration with immune cells, including mostly innate immune cells, but also some adaptive immune cells, and they produce a lot of cytokines, adipokines, and cause cartilage destruction ultimately. And a similar process is ongoing in the adipose tissue, intramedullary fat pad. You have a lot of adipocyte hypertrophy and immune infiltration, and resulting cartilage damage. So this is just histopathology of the same, where you see the lining layer hypertrophy with infiltration by various immune cells. The sublining layer actually forms hypertrophy of the blood vessels, along with sometimes you see secondary lymphoid organs there due to infiltration of lymphocytes as well as monocyte macrophages. And ultimately, this results in fibrosis. There's a lot of collagen deposition, dysregulated collagen deposition that causes fibrosis in the synovial tissue. So is the synovium in osteoarthritis really inert? And we now have very high resolution single cell data that shows that it's not. The predominant cell type there is the subintimal fibroblast, followed by the intimal fibroblast, which are immunologically active cells. And then you have this group of HLA-DR positive cells. Now, HLA-DR is a marker of immune activation, and it consists of these cell types, inflammatory macrophages, as well as immune regulatory macrophages. And so the body is developing inflammation, but it's trying to simultaneously fight off inflammation. And osteoarthritis results from an inability to shut off this low-grade inflammation that's there. You also have some smooth muscle cells, endothelial cells, as well as some T cells and mast cells. So what are the cytokines that these inflammatory cells are producing? Mainly it's the inflammatory cytokines, IL-1 beta, IL-6, and TNF-alpha. And these are being produced mainly by the inflammatory macrophages. If you look at the synovial tissue, you can very beautifully co-localize these cytokines to the individual cells. So synovial fibroblasts that are CD14 high produce IL-6, whereas the synovial monocyte macrophages, which are showing TLR2 upregulation here, also produce IL-1 beta. So these macrophages that infiltrate into the human OA synovium, they are what are known as classically the type 1 M1 macrophages. These are inflammatory macrophages, and you can see that by the marker inducible nitric oxide synthase, whereas CD206 is a marker of M2 type of macrophages, which are immune regulatory macrophages that tend to bring down inflammation. So in the human OA synovium, you have a lot of M1 macrophages infiltrating, as you can see, and downregulating of the M2 macrophages. And this is just, again, confocal microscopy demonstrating the same. F480 is just a marker of macrophages. And in the OA synovium, you can see the macrophages co-localize with inducible nitric oxide synthase, which is suggestive of M1 inflammatory macrophages. So what happens when you take away these macrophages, and in a displaced medial meniscus mouse model, if you knock out CCL2, which is a marker of M1 macrophages, you see that M1 macrophages go down. There's a decrease in the damage associated with osteoarthritis, and there is a marked decrease in the inflammatory cytokines. IL-1 beta goes down, and all your aggregations that destroy the synovial tissue and cartilage actually go down. So just summarizing the conventional immune mechanisms, mainly of the innate immune system, you have your macrophages and chondrocytes that are engaged in a positive feedback loop. The macrophages produce lots of inflammatory cytokines. They result in chondrocytes producing aggregases. Chondrocytes also release IL-6. That in turn, again, positively upregulates your inflammatory macrophages as well as your fibroblast-like synoviocytes. So is there a role of adaptive immune system in this pathogenesis? And there's a real debate whether it's a cause or effect of osteoarthritis that you have adaptive immune cells in the synovium. This one study had a good follow-up of the clinical phenotype, and they looked at the immune phenotype associated with the clinical progress. So they found 4 phenotypes, immune phenotype 1 to 4, where immune phenotype 1 really has a predominance of lymphocytes. And then it's a spectrum to immune phenotype 4, where you have a predominant of your innate lymphoid cells, your monocyte macrophages, and your myeloid cells. So, as I said, immune phenotype 1 associated with a lot of cytotoxic activated lymphocytes, as well as helper lymphocytes, and some monocyte macrophages. whereas immune phenotype 4, which they call aggressive, had more myeloid cells, more macrophages. Immune phenotype 2 and 3 had more NK cells, some monocyte macrophages, but neither of the activated lymphocytes or the activated myeloid cells of immune phenotype 1 or 4. How did that translate clinically? You saw that immune phenotype 1 had good disease control. Less of them progressed to severe osteoarthritis, whereas immune phenotype 4 with the more myeloid phenotype really progressed in terms of their clinical osteoarthritis. This is something that you see even in rheumatoid arthritis, where more myeloid infiltration in the synovium is associated with a more severe phenotype that is difficult to control. So I've given you a glimpse of immunology, and to take you back to the clinic now, we have this 36-year-old female, pretty young you would say, and she's come with classical non-inflammatory hand and knee pain, and she has this nodal form of osteoarthritis in the hands that you can see, and a very typical family history where she, her brother, and her father all have early onset osteoarthritis. Routine and endocrine investigations were normal, and so we were a bit perplexed. Why are they getting osteoarthritis this early? Now, you need a lot of conviction to tell a family of 30 and 50-year-olds that you need to get genetics done for a disease like osteoarthritis, and thankfully we have Dr. Abel with us, who has plenty of conviction for everyone to go around, so he convinced the family to actually undergo genetic sequencing. And it came up to have this autosomal dominant mutation in TRPV4, which is a calcium channel, but also interestingly, it's a mechanosensor. So it provides a link between pressure sensation and the immune system. So this is a busy slide, but I'll take you through it. So your body is constantly undergoing mechanical stress. You have stress in the form of shear stress. You have stress in the form of hydrostatic pressure of your blood vessels, and your immune cells have methods of detecting the stress. So we discussed just now the patient with TRPV4 mutation. There's also a mechanosensor called piezo1, and these are calcium channels. When they sense pressure in the external environment, they increase calcium sensing inside the cell, and this activates the calcineurin NFAT pathway, mTOR activation, and results in immune proliferation. Other mechanosensors include the Hippo pathway. So the important protein there is YAP and TAZ. So YAP and TAZ, they again sense mechanical transduction, mechanical pressure, and they then translocate to the nucleus, increase production of inflammatory cytokines and inflammatory milieu in the cell. Lastly, you have the integrins. So integrins interact with the extracellular matrix directly by engaging the cell, and they are linked inside to the F-actin molecules, which form the microtubular skeleton of the cell, and they also result in translocation of this MRFTA protein to the nucleus and a pro-inflammatory phenotype. So what happens when you have, I'm only going to discuss one article on piezo1 and how piezo1 is expected to cause osteoarthritis. So if you take porcine chondrocytes and stimulate them with IL-1 alpha, you see that piezo1 mRNA expression goes up. The same is seen in humans. If you take cartilage from humanoid patients undergoing surgery, you see that piezo1 expression is markedly increased in OA synovium as well, and this results in increased calcium influx into the cells, as we discussed, and this actually increases mechanosensitivity and increases inflammation in osteoarthritis cartilage. How does it increase mechanosensitivity? Well, there's experiments with looking at F-actin. So if you stimulate chondrocytes with IL-1 alpha, piezo1 goes up, but simultaneously F-actin goes down. So F-actin causes your cells to be stiff, it gives your cells structure, and if F-actin goes down, your cells become soft, they're more prone to mechanical stresses and mechanical injury, and you can see this in porcine chondrocytes, as well as in human OA chondrocytes, where the fluorescence intensity of F-actin goes down significantly in osteoarthritis cartilage. So increased piezo1, decreased F-actin, and susceptibility to mechanical injury. So I'll move on to the second key point here, which is immunosenescence and inflammation. So your immune cells are prone to age just like everyone, and this results in a senescence-associated secretory phenotype, which is associated with a large nucleus that is not dividing as fast, and as a result, it accrues a lot of endoplasmic reticulum stress, it accrues a lot of mitochondrial dysfunction, it accrues a lot of lysosomal dysfunction. And these cells predominantly produce inflammatory cytokines at a very low level, so immune regulation is gone, and your cells are producing low-grade inflammation that is persistent and difficult to control. So these are the cytokines associated with immunosenescence, and you can see it's very common with the cytokines we associated with osteoarthritis, IL-1 beta and IL-1 alpha, as well as IL-6. IL-6 is also known as the geriatrician's cytokine because it is associated with inflammation. And that brings us to the realm of senolytic agents. This is a mouse model of osteoarthritis known as the anterior cruciate ligament tear mouse model. You artificially tear the anterior cruciate ligament, and these mice develop osteoarthritis as they age. And they have been given here a senolytic agent by the name of UBX0101. And what that causes, first and foremost, is a downregulation of these CDK and 2A positive cells. So CDK and 2A is a marker of senescence. So basically your senescent cells are going down, so your senolytic agent is working. But what that also results in is a decrease in the inflammatory cytokines. So IL-6 levels go down markedly here when you give a senolytic agent. Your agarikinases that are damaging your cartilage goes down, so your cartilage destruction goes down. And you can see that beautifully in this histopathology where your cartilage is well maintained when you give a senolytic agent, whether it's completely gone when you have just a normal vehicle. Coming to our last point, which is about immunometabolism. So when we have something known as visceral fat, all of us, and your Hoffa's fat pad, or the intrapatellar fat pad, which is there in everyone's knee, is one such pocket of visceral fat. You can see these beautiful globules of adipocytes here on the electron microscope. And there's a large follow-up study in the US of patients with radiographic osteoarthritis, and they were followed up over time to see who develops aggressive osteoarthritis, and they looked at serial MRIs. And what they found was when you have an aggressive, progressive OA, you have this Hoffa's fat pad lighting up, very hyper-intense Hoffa's fat pad lesions, along with synovitis as would be expected in the knee joints of these patients. And Hoffa's fat pad hyperintensity has an odds ratio of 2 for accelerated degenerative osteoarthritis. So we now have insight from single-cell studies into the intrapatellar fat pad, just as we have from synovium, and we now know that the cells there in the intrapatellar fat pad are very similar to synovium. So you see a majority of them are macrophages. The innate immune cell is very active, macrophages and dendritic cells. You have the adipocytes. Surprisingly, the intrapatellar fat pad is more immune cell than it is actual fat. So lots of pro-inflammatory macrophages there in the intrapatellar fat pad, and then you have fibroblasts and your normal endothelial cells that would be expected. So what's happening in the individual chondrocytes and the immune cells? There are a few pathways active. So whenever you have any inflammation in any immune cell, the immune cell shifts from oxidative phosphorylation, which is its normal mechanism of generating ATP. It's a very efficient process, produces a lot more ATP, but it's also slow. So it shifts to glycolysis that produces a lot of readily available ATP, but a lot of oxidative stress. And it activates the PI3K mTOR pathway, also activates the NF-kappa beta pathway, and causes pro-inflammatory cytokine production. Now, AMPK activation is a wonderful inhibitor of this inflammatory pathway, and we have AMPK activators available with us for centuries. That's metformin. Metformin will actually abrogate all this inflammation, but who cares about metformin when you have a sexy new kid on the block, which is semaglutide? And you see with semaglutide, you have a lot of weight loss, but also a lot of decrease in the WOMAC pain scores of osteoarthritis. So semaglutide actually also increases AMPK activation, decreases mTOR activation, and decreases inflammation in the joints. So this is the summary. If you have lean adipose tissue, you have more regulatory cells there, M2 macrophages, Th2 cells, Treg cells, more oxidative photophosphorylation, whereas hypertrophic adipose tissue has more inflammatory phenotype, M1 macrophages, myeloid cells, Th1 cells, CD8 cytotoxic T cells, more glycolysis, more oxidative stress. So take-home messages: osteoarthritis is not purely a degenerative disease. The innate immunity is active in the joint and visceral fat. Immunosenescence, immunometabolism, and mechanotransduction, the holy trifecta of immune pathology in osteoarthritis. And we have green shoots in disease-modifying therapy. So semaglutide is promising. We have senolytic agents in the pipeline. With that, I welcome you to Lucknow if you have the opportunity. We have a wonderful institute and a wonderful city. And thanks to the Department of Immunology at SGPGI and my lovely wife. I wake up every day and pinch myself to see that she's not dumped me yet. Thank you.
Thank you, Dr. Chatterjee, for your excellent presentation. Now this session is open for discussion.
Dr. Chatterjee, that's a wonderful insight. I have a small clarification, like you expressed that phenotype 1 and phenotype 4 being responsible something like inflammatory mechanism.
Yeah.
Is it linked with something like mechanoreceptors, like obesity control we are discussing in management? Could you highlight, please?
Yeah, so in that study, they have not looked at mechanotransduction. That was actually a bit older study, and mechanotransduction was not really in the basic science world at that point of time. So they have not looked at that individually. But yeah, mechanotransduction is very important in any immune cell, even for lymphocytes and myeloid cells. That should be a future avenue for research, definitely.
Lovely, amazing talk, and that's sort of horizon-breaking talk. My question, I have a major interest in imaging. Particularly, I'm a rheumatologist with a major interest in ultrasonography. And Hoffa's fat pad, we see, it's so easy to visualize. Yeah. And we see it and we just disregard it, said move on. So are you suggesting from your talk that we really need to take a special interest in the Hoffa's fat pad, for example, in NEOA? Is that where the money lies?
Yeah, so definitely I would put the Hoffa's fat pad as important as any visceral fat. There have been studies on ultrasound where they've looked at the Hoffa's fat pad volumetrically and shown that increase in the Hoffa's fat pad dimensions do predict severe osteoarthritis. We are not looking at it in the clinic. You're very right in that. We should generate data on, because the Indian obesity phenotype is very different from the phenotype we see in the West. And I don't think anyone here has looked at the Hoffa's fat pad systematically to see how it is affecting osteoarthritis in Indian patients. Definitely, I agree.
Thank you.
So, Dr. Rudrapan, I have a couple of questions. As you said that fat infiltration is also a major cause. And now there are several studies which is recently published in Journal of Clinical Investigation, I think 2004 December issue, where they say that the leptin component is actually a major target, and downregulating the expression of the lectin, especially in the murine model, they have shown to a large extent that the osteoarthritis related pain as well as some of the important factors what you have listed here, okay, the immunological components, they have actually been reduced in, although we can't see it as reversed. Yeah. The second question is, for immunity, for example, immunological parameters associated and the immunotolerance, there is down the line the epigenetic and microRNA, which are very, very critical for the rheumatic arthritis as well as for osteoarthritis, because there is a memory, there is a signature built in. So that is what is being now dissected out to know how can we actually go at the immunological level in the management of osteoarthritis versus the rheumatic arthritis. So can you throw some light on that?
With your first point, adipokines, they're a universe unto themselves, very difficult to target. That is why probably they've not captured the imagination as much. Easy to modify, basically, maybe by exercise and more lifestyle changes, but difficult to target therapeutically. Perhaps that's why they've not captured the imagination as much. Regarding your second point, I just forget. Yeah, so microRNA, as with all rheumatic diseases, epigenetics, there have been lots of twin studies looking at how it affects environmental effects, affect the immune phenotype. MicroRNA, again, very difficult to target therapeutically. It is linked to your environment. There are lots of factors that affect microRNA. very difficult to target therapeutically. You cannot really, and it's very redundant. There are lots of microRNAs that get upregulated, lots that get simultaneously downregulated. We don't have a whole systems approach right now to know what the whole system is doing. So, but definitely avenues for research.
So if there are no questions, we thank the speaker for the excellent presentation, and I think thanking one and all for the support. Thank you.
Thank you, Rudrarparsan, sir, for the wonderful journey through this topic as you had promised. So, after covering the session 2 of the day, we are now entering the session 3, which will deal with interventions in osteoarthritis. To chair the first talk of this session, let me call upon stage Dr. Alok Shobhan Datta sir, Head of Department of Orthopedics, IPGMR, Kolkata, with Dr. Dinesh Jaiswal sir, Consultant, Ortho-Spine Surgeon at ILS Hospital, Damdam. Sir, please.
A warm welcome to all. You have been through the morning session. Wonderful speakers, excellent topics. Now this is where we surgeons come in, the intervention part. Our next speaker, Dr. Ranjan Kamila, a surgeon of repute at Apollo Hospital, Kolkata, will take you to a wonderful journey of what's magic the surgeons can do when the patients come wobbly to your clinic and after all the medicines have stopped working. Dr. Kamila, over to you, sir.
Thank you very much for the introduction, and good morning, everyone. It is my sincere thanks to the organizing committee for inviting me for this, delivering this lecture here. I'll be talking on the surgery in knee osteoarthritis. You know, you have seen all how the medicines work and all the immunology and everything. And I'm going to basically describe how we surgeons work to make the patient's life better. And we just want to give a concept for the physicians, a perspective from the physician's point of view. So we all know that total knee replacement in osteoarthritis is an effective and cost-efficient procedure, and in India, over 2.5 lakh knee replacements are being performed every year. If you look at the data, implant survivorship is at least 95% at 10 years follow-up. If you look at what are the challenges now in this year, 2025, we know that life expectancy is increasing, and if you look at the average life expectancy which is expected in this year, in India itself it is about 72.84. Arthritis in young patients has been increasing rapidly, and nowadays in our clinics we see many patients with osteoarthritis who are very, very young, and sometimes we don't know what to do with them because it is difficult to actually propose a knee replacement in them. But still, they are in such severe condition, we may need to think about that. So there comes the, the chances how to improve our results and how to improve the longevity of these surgeries which you have been doing. And there we have seniors who expect to be active in retirement, which was not there before. Everybody wants to be very active. They want to go everywhere, and they also want to participate in sports, whether it is possible or not. And all this may compromise the longevity of the prosthesis which we are putting. We all know that conventional knee replacement work beautifully, and it has been the gold standard. Even now, it is the gold standard. And if you see, they really change the life of this. If you do the surgery and it's a successful surgery, they change the life of these individuals. Even in difficult knee replacements, conventional surgery is still the goal, and we can do wonderful results even in these patients. So This is just 3 months post-op. But patient satisfaction and functional outcomes remain inferior to total hip replacement, with up to 20% patients remaining dissatisfied following total knee replacement. So for a well-performed total knee replacement, it gives us good functional outcome, implant stability, and long-term implant survivorship. But for a successful total knee replacement, there are many surgeon-controlled variables like accurate implant positioning, balanced flexion extension gaps, proper ligament tensioning, and preservation of the periarticular soft tissue involvement. All these are very important steps when you are performing a knee replacement. And if you are doing it perfectly well, this knee is going to work beautifully well. But with conventional jigs, which we use for doing a total knee replacement, we use preoperative radiographic films, and there are intraoperative anatomical landmarks which we use for taking our cuts. Now, if you see, we use for tibial cutting. This, for example, I'm giving a tibial cuts, which we are doing. The slope, or we are taking the center of the knee joint to the ankle joint is the axis which we'll be taking for our bone cuts in the tibia. But if there is a foot deformity, and it's in valgus, where the anatomical landmark is already changed, there might be a wrong calculation of your the alignment, and that's how you can go wrong in that. And this manually positioned alignment jigs guide bone resection, also subsequent implant positioning, which is absolutely in the hands of the surgeon. And if there are any mistakes in that, again your implant positioning will be wrong. So these handheld techniques have poor reproducibility of alignment guide positioning. Obviously, in cases when we are going with an experienced surgeon, this doesn't happen very often, but there is a possibility. Inadvertent saw blade injury to the periarticular soft tissue involvement. Again, this is not a very common scenario. Limited intraoperative data on gap measurements and ligament tensioning to fine-tune. Because this is basically, the surgeon's perspective. He looks at it, it is his experience and how you are developing. But there is no objective data which we can develop when we are doing these handheld techniques. So the suboptimal implant positioning or gap balancing may lead to poor functional recovery, reduced clinical outcomes, increased instability, and reduced implant survivorship. So there is a 10-year survivorship decreases from 90% to 71%, even just with 4 degrees of malalignment. So that is with the naked eye. Sometimes it is very difficult to judge how much of a malalignment we are getting. But your results definitely depend much on that. So if you look at the robotics which have come into orthopedics, it's not very new. It has been there for quite some time. It was developed first in 1986. The Robodox was the first system with Orthodox, the robotic arm, to be used for knee joint replacement surgery. From there, it has changed a lot. And nowadays, how with the robots work, the robotic TKR actually uses computer software to convert the anatomical information into a virtual patient-specific 3D reconstruction of the knee joint. So we can actually virtually see that. And this anatomical information may be obtained either using a preoperative CT scan or by a combination of preoperative radiographs and intraoperative osseous mapping, which I'll be showing you in the later demonstration. So how these robotics work? The surgeon actually uses this virtual model to plan optimal bone resection, implant positioning, bone coverage, and limb alignment based on the patient's unique anatomy. An intraoperative robotic device helps to execute this preoperative patient-specific plan with a high degree of accuracy. So eventually, the robots gives us the improved component positioning and alignment, soft tissue balancing, avoidance of bony and soft tissue injuries, and better functional outcomes and patient satisfaction. There are different types of robotic systems like passive, active, interactive, teleoperated. I'm not going into the details, which I am used to as an active system which is there in my hospital. And the robot actually performs a task independent of any surgeon involvement. That doesn't mean the surgeon doesn't need to do anything. We obviously have to open the knee joint to the robot, and the robot does just the cuts which we have planned for the robot, and that will be doing. So if there is a miscalculation by the surgeon, again the robot is not going to work properly. So there is a lot of accuracy which is needed, and the surgeon also needs to be trained well to get into a satisfactory outcome. So the QVs also which we'll be using is in this group. The setup is very similar. The robot actually works as the surgeon, so it's on the patient's or the surgeon side. We use you can see the robot there, and there is a camera with the platform which is positioned on the other side, and that guides the robot how to go ahead with this, depending on the calculations the surgeon feeds into that. Usually it's a standard medial parapetal approach. There is, while doing a knee replacement, it's not that the length of incision is smaller in a robotic surgery. It's, in fact, sometimes it is bigger than the normal conventional surgery. So it's not that. But there is we usually position the trackers, one in the distal femur and one in the proximal tibia, which gives us the mapping of the patient's knee. And this check proper positioning and the lock trackers will register different bony points or bony landmarks around the knee, and the computer will actually create a 3D image of the individual patient's knee. It will give us an idea of the amount of deformity we are dealing with. As you can see here, the limb varus is about 12 degrees, and you can see there is hardly any medial opening in the joint space. So there is a varus deformity, hardly any opening there, whereas there is a lot of laxity on the lateral side. You can see the 10. If you see the pointers, we have a pointer here? Yeah, so that is the lateral opening. So we have to actually match this to get a proper soft tissue balancing. And once you do the balancing, you will get nearly by millimeters how much of balancing you get. And this is an objective balancing which we are getting. And that's how we can perform a good surgery. And this is the way the robot works. It's performing the bone resection. We have to open and give it to the robot. It will make the cuts, and then ultimately you check it. Is there any possibility of soft tissue injuries? Yes, there is a possibility, but that is limited because the surgeon actually decides the bone boundaries. We can decide how much is the robot going to cut. So we can form a boundary for the bone cutting, and that has been taken here. So the robot will never violate that. This has already been controlled, and it has been fed to the robot. And that's once you have the robot has made the cut, we'll just put the trial components and have a look whether our the alignment is all right and the soft tissue tensioning is all right. And once that has been done, we can complete the final implantation. This is a 72-year-old gentleman who had multiple keyhole surgeries before, and this is before the surgery, and this is just 2 months after surgery, how he works. And the next thing came is a partial knee replacement. There is a both conventional way to do it, which is also absolutely very good, and there is a robotic way to do it also. And this is for the fixed bearing, we do that. The beauty of the partial knee replacement, that there is a soft tissues are normal, the ligaments are normal, gaps are flexible and stable, and it avoids stretching of the tissues. So this unicompartmental knee replacement is a motion-guided implant, where total knee replacement is an implant-guided motion. So we have preserved all the ligaments. It's a bony surgery, but there are very strict selection criteria for unicompartmental knee replacement. There has to be isolated medial compartment disease. you have to have an intact ACL, and it has to be non-inflammatory arthropathy. So in cases of rheumatoid or other inflammatory diseases, partial knee replacement is not going to work. You have to have a correctable varus deformity of less than 10 degrees, FFD of less than 15 degrees, and a range of motion more than 90 degrees. So these are the selection criteria which we need if you want to have a successful partial knee replacement or a unicompartmental knee replacement. There are two types of implants, the fixed bearing implant or mobile bearing one. Usually for the robotic one, we use the fixed bearing, and when it's a conventional, we use the mobile bearing, the UKR implant. And this is after the articulation which has been showing there. And the aim of our unicompartmental knee replacement is a tissue sparing surgery. We have to restore the native kinematics. So we are not going towards the correction of varus deformity. It has to be the constitutional varus which we will be accepting, not the mechanical alignment. And there has to be internal alignment between the components and prevent loading of the other two compartments, like the lateral compartment and the patellofemoral component, which is absolutely imperative if you want to have a successful unicompartmental knee replacement. This is preoperative planning. The largest and thinnest tibial component, we try to put it in there. Restoring the soft tissue tension is essential, and component alignment should achieve maximum congruence and minimum edge loading. This is the robot in action when it does the robotic partial knee replacement. And this is after the final bone preparation. We just implant the processes, and we check the gaps. When you get absolute good alignment, we can just implant it in place. And this is after final cementation. This is the post-operative picture. This is 6 weeks post-op, how the patient works. It's without any support, without very little pain. This is another one, 2 weeks post-op. And because the ligaments are preserved, you can actually advise the patient to even squat on the floor. That is without any negative effect on that. So the benefits of robotic partial knee replacement, it is a significantly less post-operative pain, precise placement of the artificial joint, no chance of fat embolism, faster recovery time and shorter hospital stay, more natural feeling knee, and enhanced long-term outcome, including improved range of motion and significantly less pain. If you look at the literature, again, if you ask me personally, in my practice, probably more than 80% is still conventional knee replacement and even partial knee replacement, because there are other factors in that. This is still a developing, the robotics. I will not say that this is the gold standard as yet. This maybe in the future, when we get long-term results, we will know exactly what is the long-term data on the survivorship of the robotic assisted knee replacement. There have been few publications. If you look at that, patient-reported outcomes in robotic assisted versus manual total knee arthroplasty. It was compared between 393 primary robotic assisted TKS to 312 manual TKS, and it demonstrated significant improvement over manual jig-based instruments in all the functional scores, if you see. But I don't know about the long-term data, it is still not there. Robotic assisted versus conventional, another paper with conventional total knee arthroplasty. This is a meta-analysis, indicates that robotic knee replacement offers superior post-operative anatomical mechanical alignment compared to conventional TKIs. Despite this, clinical and functional outcomes as well as complication rates were similar between the two. So you will see that clinical results ultimately down the line will probably be still similar. It is the initial part where the patient is slightly more comfortable. So in conclusions, robotic surgery allows us to improve component positioning and ligament balancing. Personalized surgical procedure improves radiological outcomes, reduce revision rates in UKR. I'm not so sure as yet, and long-term results are still awaited. Thank you very much.
Thank you, Dr. Kamila, for such a lucid lecture and making us understand that the surgeon is the brain and the robot is the hand. So this session is open for question. If there is any question from the house, please come.
Good morning, sir. I am Dr. Sucheta Shah. I am a senior consultant in rehabilitation medicine at Institute of Neurosciences, Kolkata.
Right.
Today, we are very lucky to have you as a speaker, and I would like to utilize this opportunity in discussing a clinical scenario that we faced in our rehabilitation ward. So we got an elderly lady with TKR, conventional TKR. Later on, she was diagnosed to have a spinal cord tumor, and she got operated. She developed paraparesis even before the surgery, and gradually she developed spasticity. She was in our rehab ward. She was undergoing neurorehabilitation. Suddenly one day she complained of the knee pain. One side of the knee was swollen, not inflammatory swelling, but there was a hard swelling over the knee. And we got the X-ray done. We saw the implant was displaced. So at that time she was having severe spasticity, spasms. So can it be a cause of implant displacement in case of paraparetic patients? And one more thing I would like to ask, if there is such kind of implant failure, what should be the next step from our side, like orthopedic surgeons? What can they do for this kind of patients?
See, I think, regarding the implant, which is, you are saying it is displaced, there are two ways. One thing, if there is a violent movement and it has dislocated, that is something different. But usually it is attached so well, it is just by movement it will not going to displace. Okay, so there must be a point of trauma or spasticity.
Yeah, spasms were there, sir.
Yeah,
Very,
so
vigorous
that can
spasms.
actually cause, yes, because of the trauma, there might be a fracture or periprosthetic fracture where you have a displacement there. Okay, so in cases of this, you need to have a look at the implant, whether the implant per se is loose or there is a fracture around, and depending on that, you will need to have your course of action. If the implant is completely loose, it's out of the bone, then obviously it will need a revision surgery. But you have to take into consideration the patient's clinical condition, like the paraparesis and everything, and whether she will be able to take it, and whether we're going to get a functional joint in that. That is most important in that.
Thank you, sir.
We have questions from the audience.
The robotic system is a very good result, but some surgeon is still now doing high tibial osteotomy for genuine deformity. So, what is your opinion, whether it will be continued or replace the robotic surgery only?
No, I think there is a different perspective altogether. For younger patients, when you have a genuine deformity with early osteoarthritis, high tibial osteotomy works very well, and that gives you much more long-term, results. You can always convert a high tibial osteotomy to a total knee replacement later. But once you have done a total knee replacement, the next is a revision surgery, which is definitely a much more difficult one, and obviously you would need different, implants. So that doesn't replace, the robotic knee replacement doesn't replace high tibial osteotomy, not at all.
Correct. Thank you.
You're welcome.
I'm a rheumatologist. Sorry for my basic knowledge. I was just asking Kendu.
Yeah.
When implant surgery was not there, what surgeons were doing for these patients?
You mean when knee replacement was not there?
What they were? Arthrodesis or something?
Arthrodesis, is completely obsolete now because obviously
I'm
it fuses the
asking,
joint.
When the replacement surgery was not available,
Yeah.
what exactly surgeons were doing for this knee?
Many of the times, see, the steroid injections you used to buy time, but at end point, when there was nothing, you couldn't advise anything other than wheelchair mobilization.
So it means it was nothing actually.
Actually
So
nothing.
it's a very historical thing to have
Yeah.
this.
Obviously.
No, I'll intervene, sir. It was not as if it evolved from nothing. We were doing PFOs, we were doing fibular osteotomy for earlier stages, stage 1 and 2s, we were doing HTOs until implants came. Implants have arrived almost 50 to 60 years back that we have started doing knee replacement surgeries. The uni has probably a later entrant, but then we were doing surgeries without implants for a long, long time to come. It was not just we were putting in injections into the joints. Surgeons were actually picking up the knife and doing small deviation corrections of the knee, especially when the patient was overweight, patient actually had a problem moving around without support.
Another question which patient ask, both side or one side karalu? So what is your...
I think it's patient's choice and the surgeon's choice also. It can be done, bilateral knee replacement can be done in a very fit patient without any problem, but there are chances of complications which one needs to explain to the patient, and if the patient is willing to accept that, one can go ahead. Because there are multiple papers, several papers where bilateral knee replacement has shown very good results and very safe and effective.
And last question, how to prevent fat embolism? But a lot of people, my friends and all, if some mortalities occurred because of this, unfortunate, but since we knew them and we knew that it's because of this it has been done. So I was thinking whether it is preventable.
Yeah, I'll tell you, I'll not say it is completely preventable, but you can reduce the risk. In conventional knee replacement where you use the intermedullary jig, there is chance of fat embolism. What we now do is to actually suck the fat, the marrow from there, suck it. That tends to reduce the chances of fat embolism, and that is the best thing about robotics because there is no intermedullary jig placement and there is no chance of fat embolism in that.
Thank you. Thanks.
Last question, I guess.
Could I just ask you a last question? Do you assess the quality of the bone before you do joint replacement? If they are very, very osteoporotic, they could fracture in other parts of the body.
Absolutely, you are very true. See, if you with the X-ray itself, we can see if there is a osteopenia or not. If you are expecting osteoporosis or osteopenia, we get a DEXA scan done. We check what is the T-score level. If we feel it is very low, sometimes we give a course of teriparatide, build up a bit of this, but we do not refuse. We just say, can't do it. You take a little longer, postpone your surgery, maybe 3 months to 6 months, and then once you have done your teriparatide injections, you can go ahead with a knee replacement.
One
Yes,
question.
please.
And as a surgeon,
Yeah.
when would you prefer to get the patient for surgery? Other way around, what would be your message to us to refer the patient to surgeon? Ideal situation for TKR.
I think ideal thing is in the C, once your medical treatment is actually failed, when the patient is comfortable walking around, doing their normal lifestyle, I do not advise for a knee replacement. It's not just a simple surgery, you can go and get it done. It's not that way. When it is hampering your lifestyle and the patient is in significant pain and it is not managed with conservative means, with your medications, physio, everything, that is only where the role of surgery comes.
I mean, doing well or coping well is a different thing.
Yeah.
Majority of the patients tell them, no, I am doing well with all these things, but it's not doing well, it's basically coping well.
Yeah, obviously coping well. Doing well in the sense coping well.
Acha.
When see, there are very elderly patients in 80 years old who are not going to do much, so they are not going to do outdoor activities. So in those patients, if they have a little bit of pain while walking, they outside only there, but they are doing housebound work, I do not advise them because that's taking a big risk going for the operation. So that is the, I think, point we need to take.
Sir, what you have said, that is a social factor that is very much relevant in our society. So there is a very good interactive session. I will like to conclude the session and go for the next session.
Thank you very much.
Thank you, Ranjan sir, and the chairpersons and the participating faculties for the wonderful and interactive session. Now, let's welcome upon stage Dr. Utpal Bandyopadhyay sir, Associate Professor from Department of Orthopedics at North Bengal Medical College, and Dr. Abhilash Sarkar sir, Assistant Professor from Department of Orthopedics at Malda Medical College, to preside over the next talk of the day.
So, we are calling Professor A.K. Pal sir to come over the podium. He will be talking on the skeletal biomechanical abnormality in early osteoarthritis. So far we have heard about the osteoarthritic scenario when the conservative, all the conservative management measures, they will not working. And Professor Pal will be talking about the early stages of this arthritis. And I'm sure every time Professor Pal comes over the podium, he always give us a sense that all of us how less we know. And I think at the end of this lecture, we will all agree how less we know. Sir, please.
Thank you, Dr. So I'm little bit changed my topic. So I think that's from severe molecular biology to the real life scenario. So I think you have to know your wealth. Your journey of the human life is to know yourself. So I think my lecture is dedicated to know yourself and how to predict our fate. And I think now I'm very thankful to Dr. Professor Parashar Ghosh, Professor Alkendu Ghosh, he is my teacher, and also Dr. Vishwadip Ghosh also for inviting me. And this is the topic, and you have already just after that, the knee replacement is the ultimate, it is the end, it is for the end stage disease. So what can be done before that? See, this is the osteoarthritis, and you can see this is the robotic I've just discussed, but the still same patient, if has a spine problem, so what to be done? So see, this is the initial radiograph, it is a spinal fixation, it is done, but after that this fixation is increased, it has to be level is increased, and also it is under the robotic surgery. So what is the problem? So do you have any connection? So story may not end, may not start from this. Can this be predicted and prevented? So let us see the scenario. So where to go? You have to knee surgeon, or to spine surgeon, or to the specialized surgeon, or the robot, or all, or both. So this is the dilemma. So now this is a 64 years old lady with chronic low back pain for 20 years and a painful stiff both the hips for last 10 years. So what to be done? So where do we go? So it is a knee surgeon. So this is the first surgery it is done, and this is the THR, and this is the scenario of the back. Now this is the second surgery it is done within 3 years. Now see the spine is going to become worse, and there is osteoarthrosis is progressive on the knee. So what to be done now? So it is going to become operated for the spine, knee also, and for the spine also. So everything will be metal inside, all inside the body. So this is the problem now. So what is the problem? So ladies and gentlemen, so this is the spine hip knee syndrome. So we have to looking beyond from the molecular biology to the real life scenario. So basically we have to know ourselves. At the end of the study, I think you will be very sure to predict your future. So what you are going on, whether you are going to be undergo the total knee replacements or the spine surgery, spine fixation, and that will progressive spine fixation. And one case I have seen, there's spinal fusion, it starts from the L4, L5 level, it starts from the whole lumbar spine, then the thoracic spine, and up to the cervical spine. So now at the end of the lecture, you will be understand by yourself whether it will be predictive for your future or not. So what is that special radiograph? It's very simple. It is a spinopelvic radiograph where the spine, whole of the lumbar spine and the hip will come together. I'm going to discuss what is that. And that will, so simple parameters. This is the pelvic incidence, sacral slope, and the lumbar lordosis, and the pelvic tilt. It will detect your future. Now this is the another study. As you can see, this is a case scenario. 72 years old lady came, can't walk for the low back pain and pain of both the knee, more on the left sides incidentally. So this is the radiograph. As you can see here is lumbosacral spondylosis along with the osteoarthrosis. Now the question is there any connection? Yes, let us see. That is whether the knee osteoarthritis is secondary to the lumbosacral degeneration. And see this scenario, this person, it is standing like that. Now see, this is the clinical clue for early diagnosis of the loss of the knee extension. There's a knee flexion in this scenario. So see, this is the normal weight bearing axis from it should come from the tragus of the knee, the ear, that is behind the hip and in front of the knee. In this case, what is happening? This is going faulty. This is the sagittal axis is going in front. And now I think those who are already sitting and they are going to become a sagittal axis in front of your hip joint. So beware of that. So you are sitting for more than 2 hours. So that may be a factor to ultimate goal. So prolonged sitting, that can lead to this sort of problem. Now, ladies and gentlemen, this is my topic. It is a skeletal biomechanical abnormality, and this is for knowing yourself parameters and parameter by single. Now, see, this is the efficiency conus of the Dobu set. So there are two corner zones we are living in our system. There is an inner zone, inner comfort zone, and outer inner society. Similarly, the nature has produced two cones. One is, it is a very stable cones. Another is another larger cones. These are very stable cones and these are larger cones. So where we have to walk by leaning forward, leaning backward, side bending. And this is the zone of compensation. That depends on your flexibility. Those who are highly flexible, they can increase their zone of comfort. So if we go beyond that, what will happen? So looking for beyond the horizon. See, this is the spine, as you can see here. Now, this is the Barthoner's biomechanical construction. And see this, there is lumbar lordosis. It is only the human being have. The subhuman doesn't have the cervical and the lumbar lordosis. So be aware that this is a God-gifted wealth of you, even much more precious than your finance. So this lumbar lordosis that determine the sacral slope. See, this is the sacral slope, mind it, one by one. And if the dorsal kyphosis increases, that occurs in every aging process. Even as you are sitting with your increasing dorsal kyphosis, and that should be compensated by your increasing cervical lordosis and the lumbar lordosis. And beware of another, ladies and gentlemen, because of your shifting your sagittal spine why you are keeping your heads in front of your body. That is because of your specs. Those who have bifocal specs, so you have to look like that. So from over that, so you have to keep your heads in front, and that is also another factor. Those who are prolonged sitting use these bifocal specs, and there are several. Now the configuration of specs is bifocality is little bit changed now, so I'm not going to detail. That is also another factor. So what is that? Now see, if you see this simple radiograph, spinopelvic radiograph, this is Schwab's formula. So this is the pelvic incidence, this is the midpoint, again right angle to the sacral slope, and this is the center of the hip. So this is the pelvic incidence, and see, this is the sacral slope, that is the angle with the horizontal, and the rest of the midpoint of the sacral slope to the vertical is the pelvic tilt. This is a mathematical formula, is this pelvic incidence is equal to PT plus SS, so that is constant. So basically normal PI is the 45 to 55 degree, and that is a constant afterward. So PI indicates the adequacy of the pelvis. Those who are gynecologists, they become very important for that. So this is this pelvic incidence. If it is, this point is much more behind that, so PI will be much more, so their pelvis is much more spacious. In those cases, so the normal delivery is possible. Otherwise, if the PI is very low, that means the pelvis is constricted, and there's a high chance of difficult labor. So it is another important parameter for the gynecologist also. In the sacral slope, as you can see here, the sacral slope is almost determined by the lumbar lordosis, and this normal sacral slope is 10 degree less of the pelvic inside, within 10 degrees, it's 35 to 45 degree. And the rest of the pelvic tree, if you deduct it, that is around 10 degree. So in this case, suppose it is a pelvic incidence 45 degree, it is a summation of this, a very easy solution, 35 plus 10. Now, with aging, is lumbosacral degeneration that reduces the lumbar lordosis, and this raw formula, this lumbar lordosis should be equal or 10 degree less than the pelvic incidence. Now, this is the parameters by you can check yourself also by this simple radiograph, and whether you are going to become the victim of the end stage disease. Now, this is what is the cause of low back pain is a mismatch of the pelvic incidence and the lumbar lordosis, as you can told it, if this more than 20 degree. So that is a mismatch, and that can lead to chronic low back pain. Ideally, it should be investigated by this EOS radiograph. Now, if this increase of the dorsal kyphosis, that should be counteracted by the cervical lordosis and the lumbar lordosis. This is the normal phenomenon. But if the lumbar spine can't compensate, what will happen? Who will come to compensate? This is the question. Now, see, this is the normal parameters of the young person. So, if there is a reduction of the lumbar lordosis or increase of the dorsal kyphosis, so that it is going to become front like that. So, we are going to shifting our center of gravity. How it can be managed? By increasing the cervical lordosis or the increased lumbar lordosis. But if the lumbar lordosis cannot be maintained, then that responsibility is going down to flex the hip and the knee like that. So then also dorsiflexion of the ankle. So this is the compensatory mechanism. Now, once the knee is flexed, now once if the patient is walking with his knee flexed like this, so there is a point contact stress on the articular cartilage of the knee. So once the extension is the wealth, extension, see this is the last developed movement of the hip joint. That is why nature has given only 15% extension of the hip, not more than that. Flexion is 140 degree. So every subhuman have that. But the extension is only 15 degree. So once the hip fails, next responsibility is going into the knee. So when there is a knee flex, so there is a point contact on the articular surface, it is going to become progressive degeneration and the osteoarthritis. So this is the see. So this is if it is cannot be done, so that can be compensated by the knee osteoarthritis, and that is the secondary to this the hip problem. So we have selected 252 patients, 161 female, as low back pain is much more common in our society. And the required radiograph along with the standard radiograph is the spinopelvic radiograph, as I discussed. This is the only special radiograph I use that. And see, this is the normal scenario. This is the normal radiograph, as you can see here. So this is the corpse angle, modified corpse angle, as you can see here. This is sacral slope, and this is the pelvic incidence. And see this lumbar lordosis. It is a standing and the sitting. This is a standing scenario. This is the whole of the lumbar and both the hips centered. And this is the sitting scenario. And this is the change of the lumbar spine. The lumbar lordosis. It is within 20 degree. And that is the normal scenario. This is only low back pain for 3 months only. There is no knee pain. This is the normal parameters. But whether it's a hypermobile but severe PLI mismatch, you can see here. This is the standing scenario. This is the lumbar lordosis. This is the sacral slope, and this is the pelvic incidence, where it is significantly changed when patient sitting in his normal position. This is a little bit slouching position. Sitting in slouching position for long period, and see there is a significant mismatch as instead of the hypermobile, that is the pelvic incidence 68, but it is lumbar lordosis is hypermobile, more than mismatch is more than 20 degree. Whereas the low PI, see this is the low PI. You see, low PI is pelvis is very contracted, low PI, and see, and there is a hyperlordosis. But so there is a low PI, the sagittal that's imbalance occurring. The body tends to fall forward, and that is compensated by the knee flexion. There. So this method, there is a specific distal 4 to 5 gates were selected. Specific mixture, I will show what mixture. That mixture of solution was injected 1.5 to 2 ml in each gate to block the sodium channels of these gates. There is a clinical response was assessed by the VAS code and the Osteoarthritis Disability Index. If the pain is it is significantly reduced over the first injection to block the pain of the radiculopathy and the back pain, then that case's diagnosis is predominantly back symptoms. But if the pain persists and it requires second injection after 7 to 10 days or at least after 2 days, that is diagnosis predominantly knee pathology. So the solution used is basically 3 ml, 2% lignocaine, there is 30 microgram clonion, clonidine, 20 milligram triamcinolone acetate, with the rest of the is completed by the distilled water to make a 10 ml, and that is 1.5 to 2 ml is injected in each gate. And see, this is the different types of the different gates in the lower limb. Only if you give injection in the foot, the specific gate, the pain of the radiculopathy and the this low back pain relieved. So there are different gates. I'm not going into detail. So this is the pain. This is a significant relief. You can see here. This is a significant relief of pain. This is a low back pain with left sciatica for 10 years. It is relieved of this injection. And see, this is the case. This is the patient cannot walk straight. It is walking like this slouching position because of the severe this low back right sciatica for 1 year with recurrent exacerbation and revision, PIVT L5S1, and now after the injection, patient is walking upright. So this is another case. This is a Feldback syndrome. As you can see here, even after the surgery, spine surgery, patient couldn't walk without stick. So immediately after the injection, patient was given the patient was walking freely, and this is the patient. It is admitted the second injection. So this is a knee pathology is the primary one. He came in wheelchair. After that, patient can walk. Patient can walk without wheelchair. So result analysis, the 2.205 patients have significant relief immediately after first injection, 43 required the second injection. So basically it is a predominant knee pathology. And so this is basically sodium channel block. This is substantiated by the Satish Chandra Goren and Suren Kulkarni. It is confirmed by giving injection and specific gate that causes significant relief of back pain. And this is immunohistochemistry suggested that is a accumulation of the sodium channels in the nociceptors. And this is sodium channel blocker. It is a lignocaine. It is proved by this gentleman. And this diagnostic test is converted to therapeutic test by the Aravind Divakar. And this is published in the sodium channel blocker injection for reduction of the low back pain by Satish Kumar of Chennai. So pain phase suggests the low back pain causes the knee osteoarthritis. Our experience shows the spinopelvic radiographic study is valuable for detection of the biomechanical abnormality, and we found this PI-PL-LL mismatch that in majority is 75% cases and low PI in 25% cases is responsible for the back pain, and that can lead to secondary osteoarthritis. So it is a significant diagnostic and the predictive value, and the distal sodium channel block is effective procedure for relief of the backache, and definitely after this blockage, it requires significant physiotherapy, and this combination reduces the dose of the analgesic also. Immediate relief of the pain causes the immense satisfaction, and for both the patients and treating physicians, break the pain anxiety cycles, and this pain portal block procedure plus selective physiotherapy can cause long-lasting pain relief. So there is a therapeutic and diagnostic value. Thank you.
Thank you, sir, for a wonderful presentation. It was very insightful. And the session is now open for questions.
It's a nice talk, Dr. Paul. I'm Dr. Divakar from Hyderabad, sir. The gate block is very interesting. Actually, the patients had a remarkable relief. The pain is somewhere, they gave injection, and then they walk, as you said. How long it lasts usually for each patient in your study?
Absolutely, it's a very good question. This is the use the lignocaine. Is basically that for significant relief of pain at least 5 to 7 days. So if it requires, it can be repeated. It's a local injection, there's no problem at all. After 5 to 7 days, you can repeat it. Now I am using this ropivacaine, 0.75%. That increases the block. That increases the block time, that is more than 2 weeks, 2 to 3 weeks. And I have used this clonion. You can ask, why use this clonion? The clonion is basically clonidine that causes vasoconstriction. So that increases the block time. So that is, and also this little bit steroid, low dose, very low dose steroid. that is a membrane stabilizing effect. I will say. Yes, sir,
Thank
please.
you.
Sir, please.
Thank you, Dr. Pal, for your very nice presentation.
Thank you,
Simple
sir.
question. I'm just asking a patient having the grade 2 anterior spondylolisthesis L4 or L5, along with the grade 2 osteoarthritis of the knee joint. My question, the treatment will be say conservative or surgery?
Yes. So it's a very good question. I already told. So these are the dilemma. Apart from this disease process, those who are apparently healthy individuals, they have this dilemma. So what to be done first? So I have used this technique, whether the pain is significantly relieved or not, at least 50% reduction of the VAS score and the osteoarthritis disability index after the first injection. So in that case, so this is the spine is the main cause. So in that case, I have used this. This is always I use this conservative, and initially when the conservative fails, only after at least 3 months, then you will go for the surgery. I have also spine friends I have sent me. Thank you, sir. It's very good question.
Thank you,
Yes, please.
Professor Pal.
Yes. Yes, please.
Sir, how do you select the gate points?
Yes, that is a very good point. So that is actually basically it is published. There are several publication is there. So for the Satish Chandra Gore, and he have found this. There the one first gate he have published, that is the at least 2 centimeter in front of the lateral malleolus. That is the first gate where he injected this solution for this sodium channel blocking. That was a reduction of this radiculopathy. And there are some maybe scientific basis, I don't know actually exact molecular problem. So if you block this, so see the L5, it is L4, L5, the neuron, it ends over that. So if you block the gate, that blocks the final common pathway up to the brain. So that is the first gate. There is 2 centimeter in front of the lateral malleolus, and there is just behind the lateral malleolus, that is the second gate. There is the third gate is behind the medial malleolus, and the fourth gate is the fourth intermetatarsal space, just below the little toe. So these are the common 4 gates for the low back pain and the radiculopathy. If it is not relieved, then again we have to give the another gate, this superior tibiofibular joint. And if it is a high up disc prolapse, or it is coming from the higher up the spine, there is a quadriceps gate, at least 10 centimeter above the upper border of the patella, inside the quadriceps. So these are the usual gates for the low back pain and the radiculopathy.
Okay, thank you, sir. We
Sir,
are
one more
running.
question, sir.
We
Yes,
are running behind schedule, so you can ask sir personally during lunch, and we have to close the session now.
Thank you.
Thank you very much, and thank you, sir.
Thank you, sir. Thank you. I can't. Thank you.
Thank you, A.K. Pal sir, for the wonderful and enriching talk. Please join me in welcoming our next chairpersons on stage, Dr. Arindam Banerjee sir, Consultant Orthopedic Surgeon at Narayana Health, NSH and NMH, Kolkata, and Dr. Ashish Raj sir, Consultant Orthopedic Surgeon at Narayana Memorial Hospital, Behala, Kolkata. Please, sir.
Good afternoon, everyone. We've all been told that surgery is the failure of medicine, and patients require surgery. After all, medical pathways have failed. Now, today we are going to hear Dr. Sharmila Tulpule, who's an orthopedician and orthobiologist from Dubai, and she's going to tell us how the physicians have upped their game and how, with the help of basic sciences, regenerative medicine is helping in osteoarthritis. Thank you.
Thank you so much. It's taking some time to set up this. So good morning, everyone. I'm really excited to be here. Thank you, organizers, for inviting me. and I didn't really know that a society like this for arthritis exists till I was invited actually. So uh, let's see what regenerative medicine has to say for osteoarthritis, primary osteoarthritis. What happened? Yeah. So I'm an orthopedic surgeon, but I'm extremely interested in regenerative medicine since I've seen the results that it is giving. And these are my disclosures, none are relevant here. If you remember, 2003, there was an article or actually an issue by Time magazine which said that epidemic of arthritis is coming. In 2004, they followed up by saying that chronic inflammation is the secret killer, and that's the basis for all the arthritic cases that will be happening, and how true that turned out to be. So what is the present status? It already is an epidemic. Actually, you see over 180 million people in India affected by osteoarthritis. Indian population is just 17% of the world population, but arthritic population is 39% of the world population. And this is documented. So mind you, when you're looking at patients in OPD, at least in my OPD, I see at least 75% of females who come to me have osteoarthritis. And that too in the age of around 50s now, 45 to 50. And so, if we can stop and reverse the lesions in the beginning, how does that sound? So present treatment options for osteoarthritis treatments, we have already heard it enough, but NSAIDs, viscosupplementation, physiotherapy, lifestyle modifications, all of this is the primary basis of all the treatments in osteoarthritis. Intra-articular steroids now have proven that they do have chondrotoxic effects, and that's why are not advocated. And then we as orthopedic surgeons have nothing but to wait for the patient to land up in surgery. And can we reverse this? All of these treatments, none has disease modifying capacity. So as rheumatologists in the audience, rheumatology has completely revolutionized by disease modifying agents, and osteoarthritis is still struggling. For intra-articular steroid injections or soft tissue injections, we have innumerable evidence that it has chondrotoxicity, and that's why intra-articular steroid injections are not to be advocated, repeat injections at least. We've already got evidence that it will hasten the process of actually it deteriorates the joint. Sorry. Yeah. So why is it so difficult to treat osteoarthritis? Simply because I think understanding osteoarthritis has taken very long time. We were still thinking, and we thought that cartilage lesions is what constitutes osteoarthritis, wherein cartilage lesions is the result of the process which is happening, which is low-grade chronic inflammation in the body. And so, inflammation is the driver and not the cartilage lesions, and that's why we were always focused on cartilage lesions, and that's why we were grappling with how difficult it is to treat osteoarthritis. But what we know now is osteoarthritis is not a pure wear and tear disease. If it was so, every old patient will be having, or every old person will be having osteoarthritis. It's a chronic low-grade inflammation which is the driver of the disease. There is an autoimmune element also, as we have listened in the morning lectures. It has local and systemic components. Both are equally important. We are always, as orthopedicians, always focused only on the local component and not on the systemic component. Hormonal, I cannot overemphasize hormonal element. Most of the females who are in perimenopausal age are neglected completely from that point of view. Most of the time they are with the gynecologist for perimenopause, and gynecologists just bat them to the orthopedicians. We don't know what is happening, and actually they do not receive any hormonal supplements or even anything to do with hormones. Metabolic element is crucial as well. So OA is not one disease but clinical end point of multiple diseases. We have seen this enough. There is an imbalance between pro-inflammatory cytokines and anti-inflammatory cytokines, so which leads to ultimately breakdown of the cartilage there. But there has been no talk on gelsolin, which is a protein found in plasma as well as synovial fluid. This was researched very well in 1970s actually. And so what they found is that gelsolin levels in plasma as well as synovium, they go down drastically in osteoarthritis. So which indicates a systemic element in osteoarthritis, that's one. Second, in all the autoimmune diseases as well as rheumatoid arthritis also, this gelsolin level is found to be drastically reduced. And how does it work in regenerative? We will be going to that also. So we are always talking of this chronic inflammation in the body and how it is affecting the joint and how it is leading. But where is this chronic inflammation in the body happening? How is it happening? So this leads us to the root cause of this chronic inflammation, which is gut. What happens is that because of the drastic change in the diet that has happened over past few years, that there is gut dysbiosis. That means the normal bacterial flora is altered, which leads to increased permeability to the toxins or the cytokines from the intestines into the bloodstream. This is such a beautiful slide which is actually showing that. And so because of gut dysbiosis, there is increased intestinal permeability, which leads to these toxins ending up in the bloodstreams and leading to chronic inflammation, next leading to osteoarthritis. We've got enough evidence to prove that, and there have been at least 15 research papers in level 1 evidence which is showing that. So cause and source of pain in osteoarthritis. Now cause is different and source is different. Causes could be inflammation, ischemia, microthrombus, neurogenic causes, microfractures. There could be bone marrow lesions in the subchondral area. The source of pain could be synovium, subchondral bone, capsule, meniscus, ligament, and fat pad. Since the cartilage is aneural, these are the sources actually of where from the pain is coming. Now regenerative treatments, we have to target, and we have been able to target local inflammation, systemic inflammation, immune element in the osteoarthritis, and also have regenerative effect on the cartilage. So pretty much regenerative treatments are now almost targeting everything in osteoarthritis and able to solve it when mechanical effects have not set in. Supportive treatments like hormonal treatments, physical, that is looking after muscle health, bone health, and mechanical aspects is extremely important. So orthobiologics is new and fast developing field which uses biological elements for orthopedic problems. What should you know about orthobiologics if you are wanting to practice it or interested in it? Important to know when to use it, what to use. There are so many orthobiologics like a Swiss knife. So you are confused when actually you want to use it in the case. How to use it, and most important, when not to use it. There's no point in using orthobiologics in each and every case that is coming to you in the OPD. Doesn't work that way. It's stuck. It got stuck. So when to use? When your traditional routine methods have failed. Second, when mechanical changes have not set in. So if there is a gross varus deformity seen in the patient, it is very obvious that nothing biological is going to work and you have to tackle it mechanically, doing an high tibial osteotomy or doing a total knee replacement. So there's no point in doing an orthobiological treatment there. So you exhaust all the traditional treatments and mechanical malalignments have to be corrected. When to use? Again, grade 1, 2, 3. But grade 4, yes. If it is bone on bone with mechanically derailed joint, no. When not to use? When legally it is not permissible for you to use, or the product that you will be using is not legally approved in the country. If you don't have enough training, that's extremely important, and your facility does not have license. That this holds true for most of the outside India facilities actually. Mechanical malalignment has to be corrected pre-op workup like any other. What are the orthobiologics that you can use? Now this is a very basic classification. I'm not going into the detail, but gene therapy is developing and will be obviously in clinical use probably next to 5 to 10 years. So I'm not going to in the details of this. You can classify as acellular and cellular. Cellular is stem cells and PRP. Stem cells are autologous stem cells. That means your own stem cells, not somebody else's. PRP can be classified into leukocyte poor and rich. Acellular could be some types of serums, which are autologous conditioned serum and very, very advanced gold-induced cytokine therapy or gold-induced autologous conditioned serum. We'll be talking about that also. Which are the commonest ones which are used in ortho? We use PRP. We use autologous conditioned serum like Goldic, and we do use autologous stem cell therapies, either a bone marrow aspirate concentrate or adipose stem cells. That means stem cells taken for fat. Fat is not all that bad. We have been cursing it enough since morning. I'll be telling you good points about fat also. Do these have real regenerative potential? No. PRP does not have a true regenerative potential. It has not been shown to really regenerate the cartilage, nor is autologous conditioned serum. But we have got enough evidence to say that there is regenerative potential in cell therapies, that is adipose and BMAC, and we've got enough regenerative potential in gold-induced cytokine therapy as well. Effects, so PRP mainly works on anti-inflammatory effect and tissue repair effect with angiogenesis, whereas stem cell therapies, they work on tissue regeneration with progenitor cells and terminal differentiation of these cells, along with anti-inflammation and repair mechanisms. Orthobiologics, they target local disease like intra-articular, peri-articular, subchondral, or peritendinous, these injections, and also systemically, wherein we can give an intravenous infusion of gold-induced cytokine therapy, which we will talk about a little bit later. Whenever you're doing any orthobiological injections, doing them image-guided is critical. So PRP, as we all know, when we centrifuge the blood, there is a buffy coat which is rich, concentrated in all the platelets. Now, we have seen this happening with the 10 ml tubes, but is that good enough? No, that was good enough for hair and skin PRP because hair and skin have their inherent regenerative potential. Here we are talking about a very tough tissue like cartilage, and so this is not sufficient. PRP, there are innumerable growth factors which are there in the PRP. I'm not going into the details, but suffices here to say that there are chemokines, which we have already gone through a lot in the morning, and there are lots of interleukins. They have growth factor levels which increases in the joint, and they have anti-inflammatory as well as antimicrobial properties. If you're using a PRP in a hospital setup, you will be needing a different setup, and if you're using it in your smaller clinic with a procedure room, the requirements are going to be different. So in a clinic-based practice, I would say ready kits which actually process the PRP in a sterile, closed loop are more beneficial than a hospital setup. Check counts. PRP count is extremely important. Now we know that it has to be minimum 7 to 10 times of the basal platelet count that you're having, or for a major joint, it has to be minimum 5 billion platelets as a bolus dose. That otherwise you will have a lot of failures, and that's why, so unless we learn to do all this, we'll not get good results, and then we simply blame that PRP or regenerative doesn't work. Okay, standardize the blood draw amount and strict asepsis and protocols is critical. So how do you get an ideal PRP for orthobiological use for a major joint like knee osteoarthritis, you need to take 60 ml of blood minimum. If you take that your basic platelet count is at least 1.5 lakh to 2 lakh, then this is the amount of blood draw that you will need to get it to around 9 to 10 billion, which gives fantastic results. Get 6 to 8 times basal platelet count, inject 6 to 7 cc of this PRP, you are bound to get very good results. We are getting at least minimum 90% good results with this formula. Second comes, so I'm not going into details, I'll just be touching on all the orthobiologics. Second is BMAC. So bone marrow has a very good amount of stem cells here, which are mainly MSCs, that is mesenchymal stem cells and pericytes in endosteal region. So we actually take it out by a simple Jamshini needle. We actually concentrate it and then we inject it. There is bone marrow aspirate with all these elements there. Adipose tissue has, I'll be taking a little more time, okay? Adipose tissue has lot of other cells like pericytes, pre-adipocytes, stem cells, M2 macrophages, and endothelial progenitor cells, which actually have a lot of regenerative potential. So if you actually analyze, these regenerative cells are 37% of the adipose stem cells. Effects, it reduces inflammation, modulates abnormal immune response. So again, immune aspect of the arthritis also taken care of by this. It prevents senescence and it secretes growth factors and cytokines for repair, regenerates the tissue. This is a simple thing that this is how we actually harvest the adipose tissue. We process it in a very closed circuit processor, washed, micronized in the same sitting, and then we do the injection under ultrasound guidance. It's a very simple procedure, takes about an hour. Adipose versus BMAC, we have got to know now that adipose has much more stem cells. It's more than 2,000 times that of bone marrow. So it's extremely rich in stem cells and it is giving extremely good, quicker and very long-term results. Biocomposite therapies are when we combine stem cells with blood elements. Coming to gold-induced cytokines, the concept is very simple. It actually, blood is incubated with gold particles. Now these gold particles get attached to monocytes and T cells in the blood, and that secretes all the cytokines, a whole lot of cytokines, growth factors, as well as the element or protein which is called as gelsolin, which we mentioned earlier. And this gelsolin is the key. This has huge trophic effects on most of the systems of the body. So if you can see, gelsolin is upregulated 10 times in this serum. There are other growth factors. These are the factors which actually stimulate the stem cells in the body. So gelsolin has trophic effects on neurological system. It has got oxidative, antioxidative action. It has got anti-aging action. It has got trophic effects on all musculoskeletal system and so on and so forth. Yeah. So this is how it is processed. I don't know, it's again not getting connected. So we incubate it for 24 hours. Then you centrifuge it, it is filtered, and then it is injected. It is given in 4 doses. It's not working here. So if we compare gold-induced cytokine and PRP, gold-induced cytokine has gelsolin as an additional factor. PRP does not have gelsolin, so that's the main difference, and that's how it has got longer-term effects. So if you know, this IL-1 reverse antagonist is a very strong anti-inflammatory cytokine. Now that is there in PRP, but that is there in more amount in gold-induced cytokine. Plus granulocyte colony stimulating factor and the other one, they are more in gold-induced, so that these stimulate the stem cells in our body, leading to longer-term effects. Is there evidence for regenerative medicine? just to enumerate, I've enumerated this in a table. There are total 165 level 1 randomized controlled trials for PRP till date. Out of them, for knee osteoarthritis, there are 62 randomized controlled trials. These are all in only PubMed indexed journals. So this is level 1 evidence, RCT. 62 are positive for osteoarthritis. Totally 149 are positive for rest of the joints also. There are only 16 negative trials which actually showed that the platelet count was much lesser than that 5 billion mark that we know now that it is needed. So it has got extremely strong evidence now. This is evidence for platelet dosing. Minimum absolute platelet dose is 5 billion. This is stem cell RCTs till 2021. So there are more than 55 randomized control trials for BMAC stem cells. This is for adipose stem cells. This is our own research paper in which we did 302 cases wherein we did a biocomposite therapy with phenomenal results. This is our Goldic published result in lumbar canal stenosis, in IV Goldic for chronic allergies and autoimmune diseases. So intravenous element is extremely important and very useful with Goldic. This is our own papers again for osteoarthritis in which we published 206 cases. I'll just show you a few cases in which we have actually seen regeneration on cartilage. Okay, so this is where there is subchondral edema, subchondral cyst, grade 4 chondromalacia patella with a cyst. So we did a treatment of Goldic in this and see at 3 years complete regeneration, beautiful healing. No subchondral edema, no subchondral cyst. This was in a 52-year-old female. This is another one in which you can see the breakdown of cartilage here, the total degeneration of the cartilage on here. This again is at 2 to 3 years that we got complete regeneration of the cartilage. This was done on the same machine with the same radiologist and all. This is another one for adipose stem cells. We did look at the degeneration here and look at the regeneration at 1 year. So this is what we are doing. Every case we do an MRI and actually try to find out how much and how fast is the regeneration. Again, this is 32-year-old male treated with BMAC 1.2-year follow-up. Look at the edema here, okay, and look at the healing here. This again is another one with large 3 centimeter defect. Not a very good quality of picture, but it has shown regeneration actually in a smaller print there. So this was a male athlete, 58-year, with large medial chondral defect. And this was definitely for surgery, but somebody wanted to just try it for a thesis purpose and we actually got good regeneration there. This is not in arthritis, but because there are so many rheumatologists, I just wanted to show some enthesiopathies that we have treated. Tendo-Achilles tendinitis in a golfer, 55-year-old, treated with everything. She was about to go for surgery and we treated it with Goldic, and this is at 6 months. She was fully healed. We got an MRI done which showed again complete healing of the Achilles lesion. We got innumerable MRIs like this with us now. This again just an interesting case I wanted to show that this was polyarticular rheumatoid arthritis. An old lady could not tolerate anything. No rheumatoid, no DMARDs could be given. And so we did intravenous as well as local gold-induced serum treatment and look at it. At 3 months, she was walking. This again is an autoimmune lupus erythematosus patient in which we had done regenerative treatment at 3 months. She was completely healed. And these are longer lasting. Most of the times we're getting minimum 4 to 5 years follow-ups till now, which have done extremely well. And we're waiting for further follow-ups actually. I won't say that this is the end of the treatment, but it's worth exploring all these. So in conclusion, regenerative medicine is rewriting the treatments of osteoarthritis. Its ability to target local as well as systemic disease. Evidence is building up fast, but training is crucial. And I think more we learn, more we are going to get towards better results. So we do conduct American Board of Regenerative courses for anybody who wants to do it. And we are actually having a conference in Chennai on August 1, 2, 3, Region 2025. So anybody who's interested can get in touch. Thank you so
Thank you,
much.
ma'am,
I'm so sorry
for
that
such
I
a wonderful
actually
talk
overshot.
and insight into this
Sorry.
topic, which is quite an upcoming topic related to osteoarthritis. Sir, actually we are running sort of time. Yeah, we'll take one or two questions. One or two questions, please, sir.
Many, many thanks, ma'am, for your excellent and elaborate presentation.
Thank you.
A very simple question. 62 years already, having early grade 3 osteoarthritis of the knee joint along with the effusion and Baker's cyst. Whether you suggest injection PRP in this case or not?
So if there is no mechanically deranged joint, meaning no gross varus, no FFD, range of motion is full, then we will be doing aspiration, wash of the joint and do regenerative, gives fantastic results.
Madam, how do you, most of the time in neurology we come across with the lumbar canal stenosis.
Yes.
So how this particular therapy will help? Because that is a very fixed type of things. And how you are not thinking about the chondrocyte generation or anything else.
Absolutely, you are so right.
Then how it will help?
Yeah,
you?
actually I'm not able to explain everything in short time, but we are getting an excellent result in lumbar canal stenosis with just epidural injections of this gold-induced serum. So not everything is actually explained, but till now, I think we have got at least 8 years follow-up with phenomenal results. With a very tight stenosis, also it is giving very good result. So what I would say that radiology is not what we are treating. It's the patient that we are treating. So if patient has severe claudication, definitely response. We've got more than 95% positive results in that actually.
Thank you.
Thank
Very
you so
interesting talk. Unfortunately, we are unable to take any more questions because of the paucity of time. But if you have any pressing doubts, please do contact the speaker whenever possible. This brings us to the conclusion of this session, and I would request the organizers to call the next chairpersons.
Just, can I add, Sharmila, for claudication in lumbar stenosis, how it works? Actually, mainly it reduces the pain by the anti-inflammatory effect and neuromodulation. They do the neuromodulation also. It's not that they will do the stenotic, they will widen the stenosis, not like that. They are not changing the structure, but regenerative therapy, they work as a very good anti-inflammatory. And once you install, after that only pain reduces.
Thank you, Sharmila ma'am, for your insightful session on regenerative medicine. An important announcement, e-posters are being displayed currently in the art gallery downstairs, so interested delegates may visit. So for the last talk of this session of interventions in OA, let's welcome upon stage Dr. Swarnendu Samanta, Senior Consultant Orthopedics at Peerless Hospital, Kolkata, and Dr. M.K. Roy sir, retired professor from CNMC Kolkata and consultant neurologist in Kolkata. Sir, please.
Yes, so it's a great honor to meet one of my senior colleague, that too from NRS Medical College, Anukenduda. It is a real honor for, and I know Krishna for last 20 years. He has been in the pain management for last 20 years. And in the morning also I was discussing with her about what is the current status and what are the recent advances about this. So it's, and now she is in a position of as the president of the study of the pain, management. So it is, we are really lucky. And I am also been honored to share chair with Professor Rai. Thank Krishna, are you ready?
Yeah, just they are setting up. Sometime this Apple.
Small announcement, e-posters are getting jazzed in the art gallery downstairs. So in the lunchtime, if anybody wants to see the e-posters, there are very good posters, around 15 of them. So you can go and see e-posters. First time in Sarkhan.
So good morning and thank you organizers for inviting me for speak on the regenerative is mainly in mesenchymal cell therapy in the osteoarthritis. So most of the thing you have now overview on the regenerative medicine in the orthopedic condition by my friend Dr. Sharmila. So I will speak on the only the mesenchymal cell MSCs or the BMAC in the osteoarthritis knee. Think they have the some problem. ওখান থেকেই লাগে তো नहीं होगा. So just adding some points with the talk. She has the extensive experience. I'm doing for 3 years this regenerative therapy. Other than the PRP, I think most of the all here present are doing. So now we are shifted to the BMAC. And I have and I'm doing the SVF, stromal vascular fraction. It is from the adipose derived mesenchymal cell because adipose tissue mesenchymal cell you can make from the fat by the microfat or nanofat what Sharmila was spoken about. And there is a stromal vascular fraction that is a pericytes around the vessels which is common in every and that has the most regenerative capability that I am using that. And for the making the SVF you can use as a ultrasonic machine. They take out the SVF or you can use the other method that is a chemical, but nobody uses chemical because that is not a very good quality of the mesenchymal cells. So we use the ultrasonic machine. I use the ultrasonic machine for making the SVF. First slide. Sorry, I'll have the from here only because very difficult. So as we are talking for 2 days, osteoarthritis is a very destructive joint disease causing degeneration of cartilage. Next, yeah. The one more announcement I want to do now in pain medicine, we have the DM courses. DM courses. In the 3 of the AIMS Rishikesh, AIMS Gorakhpur and AIMS Mangalkehri. And now we have the FNB pain medicine from the DNB board, and that is we have the 6 seats, that is 2 years dedicated course, super specialty course for the anesthetist. 1 FNB seat in Calcutta I have in Southeastern Railway, so it's my honor to be having the 1 FNB seats. We have the 6 seats. So, and now the pain medicine is coming up for the anesthetist as the super specialty. This is just for one introduction I wanted to give. And as we are talking about the osteoarthritis since yesterday, there are a lot of good lectures, prevention, treatment, many things, disease modification. So now how we can regenerate? At least we can do the something which we can reverse the degeneration. So there is no approval treatment for this. We don't have anything. And here the mesenchymal cells has emerged as a very possible alternative for some type of the regenerative therapy. How it started in history, if you say long way back, we have the ancient Egypt where we have the iron, if they have the amputation after that, they used to have the iron foot or something. And from there, if you see in the Boston 2016, they have come up with a totally regenerated hand. So now we are coming in a big way, not for only the joints, for the other thing also as a regenerative therapy. If you see the stem cell timeline, I'll say most important is the 1968, where the Robert A. Good has done the first successful bone marrow transplant. After that, the bone marrow or BMEC stem cell has come for the other users also. In 2006, adult stem cells were used. They have made the embryonic-like cells, and the first stem cell used in the spinal cord injury in the 2010. Actually, what happened, we followed the US, everyone. So in US, previously it was banned about the stem cell because cloning has come long back, everyone remember, and then they stopped this, all the research. But Obama has opened again the research, and then lot of research has been done in the regenerative treatment for everything. So what is the mesenchymal cell? It is mesenchymal cells are the multipotent progenitor cell, and adult stem cell include bone marrow, peripheral blood, placental tissue, and adipose tissue has some mesenchymal cells. Can obtain from the synovial fluid, articular cartilage, pulp, skeleton muscle, or anything. And I think all orthopedic surgeons are doing this stem cell. AVN, they decompress, they send the cells to regrow, and they chondrocyte, then bring and then implant. So this has been done for a long time. This is not new. And most adult cell has capacity to differentiate into sub, but not all cell type. By definition, standard criteria of the mesenchymal stem cell defined by the Mesenchymal and Tissue Stem Cell Committee of the International Society of the Cellular Therapy. They should be plastic adherent in vivo, that is because of the CD44. They should have ability to form colony formation or fibroblast like CD73. Ability to differentiate into the mesoderm linings like osteoblast, adipocytes, chondrocyte, and that is due to CD90 and CD105. And CD is the cluster of differentiation, and they should have the promotion of the hematopoiesis. Because of this quality, we use as the bone marrow transplant for the cancer, and the self-renewal potential, that is HLA-ABC. These are the quality, two are the where we use as a bone marrow transplant. So mesenchymal cells are the multipotent cells which we are using. These are the mesenchymal cells. So, and they have all quality to differentiate into the all adipocyte, chondrocyte, and osteocyte. What type of the mainly mesenchymal cells we use present in the PRP? Bone marrow aspirate, stromal vascular fraction or the microfat or nanofat, and amniotic fluid. Amniotic fluid concentrate we don't use in the clinical practice. Whatever is the allogenic product is also available, that is made from the bone marrow, from the other donors, but not from the, so amniotic fluid concentrate, these are all in the research here, but clinical practice we use mainly autologous in the same sitting with the very less manipulative cell therapy. So what the BMEC, it delivers various growth factor and the cytokinin, which is important for the anti-inflammatory effect, and they do the activation of the cell proliferation, differentiation, and angiogenesis, and their angiogenic effect is used in the AVN of the hip, and they have the all anabolic and anti-inflammatory effect, have the cartilage repair, and they stimulate the chondrogenesis, cartilage healing, and they do the immunomodulation. How they work in the like stenosis, the anti-inflammatory and immunomodulation. These two quality of the mesenchymal cell help in the. They have lot of the growth factor, I'm not going details. So, and they have the angiogenic effect, as I said. This angiogenic effect is used in AVN hip, and I have done 2 cases of the AVN hip without decompression, the grade 3, but we have an intraosseous implantation of the mesenchymal cell, and they are doing very well. In osteoarthritis, indications are the osteoarthritis grade 2, 3, 4, not all patients, but if the patient has deformity, of course, we always counsel for the knee replacement, which is the gold standard for the grade 4. But some patient actually, they don't want surgery, then I have done the BMEC for them patient. They are doing well, but after that, we do the correction and all the deformity, we give the braces for that. Meniscus tear, chondral lesion, ACL tear. Our experience with the patient selection was the total 100 patient we have done from the January 2023. I'm doing this. Male-female ratio 6:14. Age mainly from 50 to 75 for the osteoarthritis. One patient I have done 24 years, sports person, ACL injury. Without arthroscopy I have done and he's doing good. And mainly, as I said, grade 2, 3, 4 sometime. ACL tear, meniscus tear. One patient in the railway hospital we have done, she is the 20 years old nurse and she had the avascular necrosis of the lower part of the tibia and lower part of the femur, including joint also. And we did the decompression and then we implant the bone marrow and she's doing very good. And post-ankle trauma in especially 2 sports person, there also PRP didn't work and then when I have done the BMAC, both are doing good. We do the initial visit workup for this patient, thorough history examination, lab test, MRI, USG, if required, WOMAC, all the WOMAC, Oxford and KL score, and see for the other morbidity, and anticoagulants are stopped. So, how I do, the BMAC is the patient in the lateral position with the fluoro, and after the local anesthetic infiltration, we give this Gemshell needle, which has the special needle for the BMAC aspiration, has the 5 holes, and I normally do the post-iliac crest. And we take in the syringe the ACD, which is come with the kit normally, or the ACD is taken, and after that we aspirate the bone marrow. We have this special type of the syringe also, which has the vacuum, so that easily come up. And the most important thing, we should not take the more than 5 ml of the bone marrow aspiration from one place, because after that blood start coming, so you change your needle direction from the maybe the same entry level, but you can always have the fan shape or the deep and superficial. So now I use the kits. I normally do the 50 ml for minimum is the 50 to 60 ml, otherwise it is not sufficient to have the BMAC. So we use 2 kits, 25 each, and then it is centrifuge. So the centrifuge also done twice. So after first centrifuge, it is like the same if anyone is doing PRP, so doing, and then we do the second, and this is the end result. This is the cells goes down in the kit, and the upper fluid that has the most of the concentrated stem cell or mesenchymal cell and all the growth factor and everything, which is implanted under either ultrasound or fluoroscope, both can be used. So normally we do under ultrasound or maybe sometime hybrid technique, because and intra-articular also implant I do, and other than we do the medial meniscus, or if the patient has the MRI, whatever the problem, sometime we do the intraosseous injection also, and the medial meniscus and the medial collateral ligament. Normally if you do the medial, because that is the maximum place where the pain occurs or which is the weak, because if you don't strengthen this ligament also, then the result doesn't come much. Follow up 2-4 weeks and 3rd month, 6th month, 1 year. If pain relief is not satisfactory after 3 months, so sometimes we do the 1 PRP for the. So out of this all patient I have done for 2 patients, because results were not so satisfactory. Pain relief was not good. I have done only 1 PRP after that, 3 months. The results was score 0 reduced a lot, and it improved, and improvement in pain and function by the 70 to 80%. Duration of benefit, because I am doing since 2.5 years, so I can say 2 years, and the future will tell at least my results. And patient satisfaction is very high. There is no pain in the donor side. Normally people ask me, if you are doing aspiration for iliac crest, is there any pain? So most of the patients, they don't complain about that, and safety profile is very high. And post-op care, 0 to 3 days, just range of movement exercise at home, and first day I don't allow them to wait beer, at least only going to toilet is allowed, otherwise not. And from the 3rd day they can walk at home, and I don't allow them go out of home after till 1 week, and after that they start. And at 2 weeks they can start the exercise, and at 4 they can do the weight bearing exercises. Complication, really not much. One or two patient had pain for few hours, I will tell, and that is mostly injection pain because we do under local anesthesia. And most important is though there is a no NSAID for 2 weeks, so people cannot take the NSAID if the pain is there. So we just allow them to have the paracetamol or tramadol. Cold sponging is good for the pain relief, and the steroid, at least not any type of the steroid for 1 month after the regenerative therapy, any type of the therapy. So this is a post-procedure care, no smoking, no alcohol, that is very important, and they should stop all the anticoagulant 72 hours before and for further 24 hours after the post-procedure, and no steroid for 1 month. What are the evidences which can support our treatment? So that is a multi-central analysis of the adverse events which is done in 2,370 adult patients undergoing autologous stem cell therapy for the many orthopedic condition, and it has been seen the lowest rate of the adverse event, or not much for the BMAC injection, but the high rate of the adverse effect. There is a no higher adverse effect for all this therapy in these patients. And MSCs in the osteoarthritis, there is an improved quality of repair and decreased risk of the re-rupture occurs. Most people give when they do arthroscopy repair of this patient, and then they implant the BMAC with that, and they have seen the better result with this, and there is a no risk of the re-rupture because most of the time this re-rupture occurs. And what is the evidence for the stem cell in the treatment of early to moderate osteoarthritis of knee? Again, a systemic review studies published, and that is a level 3. Evidences are there. Again, this is published in Internal Journal of Molecular Science, and in 2020, bone marrow uses in the osteoarthritis. So it has emerged very much promising biologic tool for the regenerative medicine. Studies published have reported very favorable outcome, and they are mainly clinical improvement. So if you are saying Dr. Sharmila has published many where the MRI report, MRI also there is an improvement, but at least I can say clinically patient do so well after the implant. Even the second day they have the reduction in the pain more than 70 to 80%. So now we have the allogenic product available, stem 1 in the name of the stem 1 in the market, and that is the again study has been done which is the better, autologous or allogenic. And the studies, that is a Prisma complaint meta-analysis of the randomized control trial done, and allogenic versus autogenic. And the autologous source of the MSC is superior to allogenic source of the MSC with regard to their consistent efficacy, pain, function, outcome, and safety. And I will say in the cost also, because those are very, very expensive. But if you compare both, the autologous is not so expensive. Culture, again, I know for the AVN, for the long time, people are sending for culture. So again, it has been reviewed and seen the cultural expansion of the autologous MSCs is not a necessary factor to obtain a superior result in management of knee osteoarthritis. So same sitting, when you are taking out the BMAC and prepare and implant, so you don't require to send for the culture and chondrocyte. Again, it is expensive and it is not superior to the same setting. So again, this is the stromal vascular fraction. I have not done the detail of here because there is a short time. I have done the detail for the BMAC. I do the bone, that is a adipose-derived stromal vascular fraction. And there are also many papers published for the SVF. So how the microfat, there are two products, microfat, micro or nanofat, or maybe the SVF. SVF is prepared from the ultrasonication of the microfat. So here is the autologous adipose tissue derived SVF application patient in the 1128 patient, that is 1856 joint. So there is a no serious side effect, systemic infection, cancer. There is a no cancer recorded for the regenerative treatment in any of the patients. Most patients improved 12 months after the treatment, and 75% score improvement in the 63 patients. And after 12 months also, patient shown the more than 50% score. So obesity in higher grade of osteoarthritis always related to the, as we had already talked about the obesity. Yeah, that's the last slide. Stromal vascular fraction therapy for the osteoarthritis. Now these are the publications. Lot of references is there for the SVF and BMAC or mesenchymal cell. So if you, and Dr. Shamla also shown ki how many now references or the publication has been done suddenly after the 2018. So lot of, but now we need to have the protocol, standard protocol. We are preparing our protocol from the core group and ISSP also for the regenerative therapy, because there are a lot of differences in individual kit, individual method of preparing. So there are a lot of differences. So we need to have the standard protocol for regenerative therapy. People have doubt and always ask if is the legal. Yes, it is legal because it comes under the less manipulative cell therapy and autologous with the same setting. We are not taking out of the OT. So it is totally ICMR legalized treatment under the government of India. The take home message, integration of the regenerative medicine and interventional pain medicine is very important for all the osteoarthritis or joint diseases. Emerging field, variable evidence, but we have to do more and then we can say how the results are. Use tissue-specific therapy, best available evidences, but you should know your limitation, your training, and your skill. Thank you so much.
Thank you, madam.
Thank you, Krishna.
This is an excellent talk because there is this, I think it's a very pragmatic approach because when the medicine fails, these types of definite approach is always appreciated. And I think a lot of works are going on. And only one or two queries I have got in my mind before I throw these things to the audience. Probably these embryonic cells and the amniotic fruit cells and the placenta is not recommended in our country, not yet legalized now.
Yes, sir, not.
So
it is all what people are doing research. For the research only they are using.
Yeah, they are on the research purpose. Next, I want to know, do you want to have any LLT therapy before you implant these things? This is, LLT. Okay, low level laser therapy, which is actually practiced in some areas as far as the literature is concerned.
No, sir,
because that will give rise to better chondrocyte generation if you just implant this mesenchymal cells. Have you got any idea or do you like to say?
LLMT, I don't use that type of the therapy.
So the one or two questions can be just asked from the floor.
The one question.
Two questions from the floor.
Thank you very much, ma'am, for your excellent presentation. Simple one question. In your long-time practice, and the grade 4 osteoarthritis of the knee joint by injection of mesenchymal stromal cell therapy is successful.
So, sir, actually, as I said, the always knee replacement is the gold standard. But some patient who really doesn't want surgery and they come ki do anything, but I don't want. So, if patient is really very elderly, like 85 years old or more, then I do normally for the radio frequency of the genicular nerves for the pain relief, because it is just for a pain relief and it gave the long-term result like 6 months to 1 year, then you can repeat. Because there also we are, after 85 years, the BMAC results I'm in doubtful, so I normally do. But if patient is 70, 75, so we have done the BMAC for those patients who really doesn't want surgery, who refuses the surgery. And to my surprise, few patients, 3-4 patients, they are doing well actually, sir. It's more than 1.5 years. But of course, I recommend them a lot of exercise and rehab program. They do after that rehab program and they are doing well. But basically, patient has a deformity, so I tell them that this is not for you, you should go for this. But you know, in India, some patients are really against the surgery. So for them, I try.
Ma'am, is there any hemoglobin restriction?
No, sir, not really, but sometime we do optimization, so it should be more than 10, but for the BMAC, not really. But if you do PRP, then you should see what is the platelet level. If the low platelet level, and they should not be antiplatelet drugs if you are doing
And second is, what is the rotation rate?
3,000. Normally 3,200, and then second is the sometime 3,000. Again, it is depend upon the different kit. The which kit you are using from which company, the recommendation of the company. What is the recommendation?
Yes, I think the last question is madam is waiting. Yeah.
Yes, ma'am.
Okay, you can ask. Okay.
Ma'am, sorry, ma'am, I'm here.
Yes.
By ACL injury indication,
Yes.
what is the parameter you're checking for? Is it the healing or you're talking about the patient's pain?
Pain, of course, reduces, but healing also. So if you do MRI repetition, so you will see the
In a complete tear as well? Or?
complete tear. Actually, non-sports person. We have done 2 cases where the patient was non-sports person and again doesn't want any surgical fixation. If the complete tear, I will again recommend for the surgery. But with the arthroscopy repair, again you can give the regenerative. It has a better result.
No, if there is a complete tear, it is a mechanical issue. Just like the grade 4 osteoarthritis. Okay, if there is a mechanical problem, if it is a complete tear, I think there is no point in going for the MSC. Okay, because this is the regenerative purpose, which suppose for the partial tear, suppose for the stage 2, stage 3, KL, then you can go ahead. But for a complete tear, I think if whatever treatment you do, if the patient is symptomatic, having the pivot shift and all these symptoms of instability, better to go with the surgery. She also told that during the lecture.
No, my
Grade 4.
question was basically, what is the parameter? Pain is the parameter, not instability.
No. Pain is there, definitely, but the mechanical problem of not having the ACL
Instability
inside, it is the problem is the instability. The patient will come with the less of confidence and they will be always telling that my knee is pivoting. Okay, last question.
Sir, last question, sir. Thank you. This field is actually being expanding, and based on the 2019 recommendation from the Ministry of Health and Family Welfare, one can use even the prenatal tissues like umbilical cord stem cells and the placental stem cells, and there are specific guidelines given in 2019 where that can be treated as a drug, but you need to have very stringent regulation with efficacy studies and with several PCT studies, again approved by the CDSCO governing body of the Department of Biotechnology and the ICMR. And now there is an expansion not only of the bone marrow, one can also go for the prenatal. So I just wanted to add the
Yes. People are all telling about the amniotic cell and the umbilical cord blood and all this.
So
These people are all last for 10-15 years. People are even preserving that blood.
So now, and they seem to be more immunomodulatory and more acceptance as compared to the bone marrow.
Yes, but
so that is what the government is now allowing.
The government has given that guideline. The problem is that the ease of having the BMAC from the posterior iliac crest, it hardly takes 5 minutes time.
Sir, more than the BMAC will only give you the total bone marrow aspirate, and the percentage of stem cell is just 1%.
Yes,
So we
1%.
can't say that BMAC is stem cell treatment. No. So we need to take out the stem cell, give ex vivo expansion. That is what we are doing in our lab. Unfortunately, I have only a 7 minutes paper presentation. Otherwise, I would have gone into the depth and given. But the BMAC has its own promises. But when you are able to give a stem cell therapy isolated from the BMAC or from the placenta, it has its own much more folder beneficial effects in the repair process.
Yes.
Yeah, madam. Lot of work is done in the lab because in AIMS and everywhere for neural tissue and the liver tissue that we are aware of. But it is for the clinical practice. Clinical practice you can't do that unless it is available.
It is available, madam, because already Stempetics have come out with in the market.
Stem 1 is from BMAC only.
No, Stempetics has done from BMAC. Now they have started with the prenatal ones.
Okay.
Thank you.
Okay, thank you, Dr. Krishna, for excellent talk.
Thank you,
And
sir.
thank to my co-chairperson. I think we will conclude the session now. Thank you.
Thank you, Krishna ma'am, and the chairpersons for such a wonderful session. Now I would like to request everyone, the delegates and faculties to proceed for lunch now. The interested faculties and delegates can also have a look upon the e-posters that have been displayed in the art gallery downstairs. So we will again be meeting very soon for the next session that will be starting at 2 p.m. Thank you. Hello. So, after a hearty meal, I once again welcome you all. And so, let's restart this session, the final session of the day. I would like to call upon stage our next chairpersons, Dr. Vashundhara Ghoshal, ma'am, and Vashundhara Ghoshal, ma'am, Associate Professor from Department of PMR, IPGMR, Kolkata, and Dr. Datta Kumar, sir, Consultant, Sri Deepti Rheumatology Center, Hyderabad. Sir, ma'am, please.
Hello, good afternoon, Postlands. I welcome Professor Kiran Seth, Secretary, SOR. The topic is medical ethics in musculoskeletal disorders. Welcome, madam.
Thank you, chairpersons. So I think after a very, बंगाली खाना खाने के बाद सबको नींद आता है, but मुझे लगता है कि अगर हम ethics की बात करेंगे, तो इसको जानना बहुत ज़रूरी है, because what we are preparing is like the future generation, and now with lot of chaos in the society, we know that we have to set some principles that where we are going. So if you see the musculoskeletal diseases, they are the leading contributors to disability worldwide. They significantly limit mobility and dexterity. About 1.71 billion people have musculoskeletal conditions worldwide, and treatment strategies, they aim to alleviate pain, improve function, and prevent further progression of the disease. So if you see what will happen on the road if people don't follow traffic rules. And you know, like from the times of Hippocrates, because he was the one who brought medicine into real picture, the only two properties, like one, not to do any harm, and we physician must work in the benefit of the patient. That was the two most important principles he laid down. But if you take back the history, it was like the disease and the religion, they were interrelated, and people thought that whenever the disease hits a person, it is some evil force. So there were a lot of priests and other people, when they got the power, they started, like misleading people and also taking a lot of benefit out of them. At that time, like to keep the medicine in the best practices, the ethics were talked about. The laws governs the society, and at the individual level, it is the ethics, the moral duty of a person, where it is his choice that what he's going to do. And each individual is a power. When they follow some principles and some ethics, they become more powerful. And set of more powerful people, they form the, society. And then this society, which is formed by the powerful people who are following some ethical principles, they can bring the change. And this change really govern the life of the people and the country and the world itself. So one has to always keep seeing himself or herself that what they're doing is right or wrong. So an important part of every aspect of the medical profession, that is, I have just talked about concepts of moral and professional duties of the medical professionals, and deontology, the set of rules and principle of medical ethics that govern a member of the medical profession in exercise of his professional duty. So see, like every society, there is a local chapter, and then it goes to the state chapter, and then like the Indian Medical Association, which also becomes the part of the World Medical Association, and they have some code of the medical ethics. Excuse me? can be made bigger. Like, there are 2 slides running, if it can be made only one. Because I cannot read. Yes. So the general principles are like this. The primary duty of the physician is to promote the health, well-being of the individual patient by providing competent, timely, and compassionate care in accordance with good medical practice and profession. Sorry for this. The physician must practice with conscious honesty, integrity, and accountability while always exercising independent professional judgment and maintaining the highest standard of professional conduct. When medically appropriate, the physician must collaborate with other physicians and health professionals who are involved in the care of the patients who are qualified to assess or recommend care options. That is when to take the referral. In providing the medical care, the physician must respect the dignity, autonomy, and right of the patients. The physician must commit to the primacy of patients' health and well-being and must offer care in patients' best interest. Must respect the patient's right to be informed in every phase of the care process. And when a patient is substantially limited, underdeveloped, impaired, or fluctuating decision-making capacity, the physician must involve the patient as much as possible in medical decisions. In addition, the physician must work with the patient's trusted representative, if available, to make decisions in keeping with the patient's preferences, when those are known or can reasonably be inferred. When the patient's preferences cannot be determined, the physician must make decisions in the patient's best interest. The physician must ensure accurate and timely medical documentation, must respect the patient's privacy and confidentiality. So, when I started searching for this presentation, I hardly found any Indian data, any Indian article. And it was the West, where I can really see a lot of papers for this, about the medical ethics. So it was Buchamp and Childress framework. He identified 4 clusters of ethical principle. That is the beneficence, contributing to the welfare of the patient. That is the actions which are done to benefit others or the patient itself. And the non-maleficence, an obligation to avoid the causation of harm. Then autonomy, which encompasses an individual's freedom of will and decision-making capacity. Then there is a distributive justice, which embodies the concept of fair and equitable treatment among individuals. So these 2, autonomy and distributive, are the recent. Otherwise, during the Hippocrates time, the first 2 were described. What are the derivatives of the principle of autonomy? One is the informed consent. That is, for informed consent for the medical procedure or research, the patient must be competent to understand and decide, receive a full disclosure, comprehend the disclosure, act voluntarily, and consent to the proposed action. The truth-telling, the second derivative of autonomy, vital component in a physician-patient relationship. Without this component, the physician loses the trust of the patient. An autonomous patient has not only the right to know his or her diagnosis and prognosis, but also has the option to forego this disclosure. So this is very important that we tell the truth in full, to the patient. That is really very important. Confidentiality, physician should not disclose confidential information given by the patient to another party without the patient's authorization. Exceptional cases where medical information can be shared while referring to the consultants, other healthcare teams, legally required reporting of gunshot wounds, STDs. But in today's world, when we are working for the corporates, when there is an electronic medical record services, like this principle, confidentiality, is compromised at many places. So if you see what are the medical ethics in pain management? So according, if we apply the 4 principles, the beneficence compels providers to offer the effective pain relief to improve patient outcomes. The non-maleficence leads to careful consideration of pain treatment risk, especially the opioids, which causes addiction, overdose, and other adverse effects. So we must know, like in the acute pain condition, we should not offer these medicines to the patient. Respecting patients' right to make informed choices about pain management, including accepting or refusing treatments, and equitable access to the pain management resources, and addressing disparities in pain treatment across different patient population brings justice. So in the chronic conditions, you know, the it has a complex interplay because there is a complex balance between providing relief and managing associated risk. The primary objective is to alleviate pain and enhance the quality of life while balancing the risk of the treatment, opioid dependency and medication side effects we are talking about. And then patient-centered assessment requires careful assessment of each patient's unique circumstances, the medical history, pain intensity and causes. Then ethical consideration, like ensuring informed consent, respecting patients' autonomy, providing equitable access to pain relief. Then what is the professional responsibility is to maintain the professional integrity and adhere to regulatory guidelines throughout. And opioid use is effective but carry high risk of addiction, dependence and misuse while treating chronic conditions, and include alternative therapies like physical therapy, CBT, non-opioid medications. They are there, but benefit as well as challenges must be outweighed. Under-treatment risk is always there because there is a fear of addiction and regulatory scrutiny which may lead to under-treatment of pain that must be ethically addressed. So if the pain is not getting cured, then we must know when to refer to orthopedicians. That is the keys to collaboration. For a patient under rheumatological care on maximal medical therapy who is still not fully controlled, we have to properly communicate between the specialist, planning to determine when to stop biologic use or disease-modifying drugs in advance, planning to stop steroids to avoid complications of surgery, provisions of information about the previous medication use, and the timing of referral also very important. That is when the medication and interventions fail, pain increasing, and function continues to deteriorate, that is the time when we should refer, and early referral will always bring better outcomes. So what are the drawbacks of the ethical principles and what are the proposed alternatives? Like the drawbacks are like principle is the autonomous decision making. The drawback is insufficient in chronic illness where daily decision making matters. Patient may lack access to information. That is why it limits the ability to make the best decision for oneself. The alternative proposal is like highlight the importance of community, moral agency, and access to resources when considering autonomous decision making, and the contrast traditional views of autonomy that focus solely on individual independence. Then the distributive justice, like which patient should get what care. It is criticized as insufficient when applied to the chronic illnesses. Like procedural justice includes the right to actively participate in decision-making process affecting their lives, express their opinions, and they should be heard. The right to ensure that the process used to reach decisions are fair and transparent, and thus allowing them to have a sense of control over their own actions. Like all four principles are criticized as neglecting their moral concerns. Mackenzie's proposal was to advocate for a more expansive approach to ethical decision making, and he emphasizes on the other parts like what are the virtue ethics, the care ethics, which prioritize qualities like compassion and trust. So, practical examples of potential challenges to each ethical principle like autonomy, inadequacy of subjects' understanding of the informed consent for a randomized trial may call into question whether subjects' independent wishes are being respected. Beneficence like investors uses true placebos rather than using active therapies for the control arm of the randomized control. So we don't know whether it is really in the favor of the patient. Non-maleficence like use of sham operations in randomized control studies for a surgical procedure is like we are just doing harm to the patient. Like distributive justice, preferential recruitment of the subjects from economically disadvantaged backgrounds for therapeutic trials, although the drugs being studied are unavailable to study subjects after the termination of study due to considerable cost of the therapy, so the patient won't be able to afford later. Now the ethical challenges in rheumatology. So a survey was done, about 12 non-open-ended questions were asked. They covered 5 core areas like ethical dilemmas in daily practice, in basic and clinical research, influence of the industry, regulatory policies, potential conflicts and disclosure, and personal education on an interest in ethics. There were 771 responses, and most common practice-related ethical issues were like the societal cost for the expensive treatment, patient cost of expensive treatment, and profits from the infusions. Additional ethical process-related concerns were the practicing defensive medicine, not spending enough time with the patients, caring for uninsured, among various other issues. These are other things which were seen. Now, the ethical issues related to industry relationship, more than 50% of the respondents perceived multiple ethical issues that majorly include serving on the board of directors, participating in speaker bureaus, serving as a consultant for the company, as shown in this figure. Now, let us see some practical example. Like the context is filtering information for patients. Scenario, patient sees a commercial or talks to a friend using a rheumatology medication. Patient does online research and concludes that this is the medication they want. Now, rheumatologists may disagree with the patient choice as the best next step. So what is the ethical dilemma which is faced over here is balancing patient's autonomy in healthcare decision, his access to abundant internet information, then physician's interpretation of that information. What is the key consideration? Patient autonomy is really very important. Informed consent plays a crucial role over here. Now, what is the physician role? That he can spend educating the patient, go beyond what the patient may have read or heard, so as to let him make the good choice for himself. Second contest is the access to treatment. Like there is a scenario like say, access to treatment becomes challenging, especially with costly medication. A patient may face out-of-pocket expenses, lack of insurance, or limited access. So a third party, like the insurance company, may influence the next step. The ethical dilemma over here is balancing patient needs with insurer policies of the system cost, risk of bias if treatment choices are influenced by industry relationship. Third-party involvement challenges the physician-patient relationship. The key considerations over here is prioritizing patient preference and quality of life, advocate for treatment based solely on the patient's benefit. What is the physician's role over here is educate patient on treatment and access options, work within or beyond formularies as needed, contact insurer, write letter, etc. when required, ensure decisions that are free from external influence. The conflict of interest, another context we can discuss. A common ethical issue is rheumatology and medicine is managing conflicts of interest between physician and pharmaceutical companies. Physician may engage with companies during therapy, development of clinical or the clinical research. So the ethical dilemma, should rheumatologists have relationship with pharmaceutical companies? How can physician balance industry collaboration with their allegiance to the patient? Key consideration, keep the patient-physician relationship central, maintain trust, stay aware of the potential industry biases, ensure transparency in clinical trial involvement, avoid gifts or undue pharma influence. The physician role over here is acknowledge the bias, don't ignore them, prioritize the patient's best interest in all the decisions, maintain boundaries in patient-pharma relationships, and reaffirm allegiance to the patient. Ethics related to the cellular and stem cell therapy in clinical practice. A lot has been talked about, and though there is some guidelines from the Indian ethical code, the stem cell interventions are increasingly used in musculoskeletal care. The ethical challenges are the lack of clarity on the stem cell nature, indications, outcomes. Direct to customer marketing exploits poor characterization of stem cells, concerns about alignment with ethical principles. The recommendations here comes is conduct adequately powered RCTs with standard of care as control, use validated patient-reported outcomes measure and test the minimal clinically important difference, promote a coordinated interdisciplinary approach involving physicians, legislators, professional communities. Medical licensing board should act through warnings, disciplinary measures, and revoke license for unindicated stem cell interventions. Now, there are a lot of ethical requirements for musculoskeletal research involving the human subjects. The research nature should be known, mostly clinical, with frequent human subject participation. In orthopedic, prostheses and implants play a role similar to drugs in the medical research. Vulnerable groups like children are frequently involved in the research. So principle to guide or conduct the ethical research is basically social and the clinical value, the scientific validity, fair subject selection, favorable risk-benefit ratio should be seen, independent review, and informed consent should be taken, then respect for potential and enrolled participation should be there. Now, milestones of ethical human research. The Declaration of Helsinki outlines ethical principles of medical research involving humans, protecting life, health, and privacy, ensuring voluntarily informed participation requiring external ethical review, and registering clinical trials publicly to prevent selective reporting and unnecessary duplication. According to the International Committee of Medical Journal Editors, registry is mandatory for all prospective studies that exposes the subject to a health-related intervention and assess outcomes. Informed consent is really very important. Here, consent should allow a clear explanation of the study purpose, method, risk, benefits, with the option of withdrawing at any time. In pediatric orthopedic, parents must give consent. A separate consent is needed to publish identifiable information, and subject must be informed about the material and its privacy implication. Ethics committee approval is really very important. All research involving human subject must be reviewed for scientific merit and ethical acceptability by independent committee before starting. And these bodies, they vary by country, like Europe has national, regional, local, and or institutional ethics committee, while in US, they are called institutional review boards. Now, with the advent of artificial intelligence, which is coming in rheumatology, though there are a lot of advantages, but there remains a lot of challenges and ethical issues. The advantages being remote patient assessment tracks health disease activity in rheumatoid arthritis using advanced hand motion recognition, accurate monitoring without in-person visits. Large language models like extract clinically relevant data from unstructured electronic health records, identifies complex phenotypes and disease trajectories, reducing diagnostic delays and improve treatment decisions. Medical imaging demonstrates diagnostic accuracy in detecting radiographic changes, has potential to catch subtle image alteration often missed by humans. Disease monitoring and management using large-scale clinical molecular imaging data to uncover natural disease patterns and patient subtypes enables data-driven stratification in complex rheumatic diseases. So these being the advantages, but the challenges comes like there are lack of randomized controlled trials. Evaluating the efficacy of AI models in rheumatology are still lacking. Rapid AI adoption, AI tools are being introduced too quickly, often without adequate clinicians training, limit their effectiveness in improving diagnostic accuracy. LLM hallucinations can produce plausible sounding but incorrect information poses a risk in the clinical setting. The transparency concern is there. There is a black box nature of many AI algorithm makes it difficult to clinician to trust AI generated insights fully. There are ethical concerns all the rheumatology raises. AI in rheumatology raises urgent issues around data privacy, algorithm bias, equitable access. Healthcare equality should bridge, not widen existing disparities in the care. There are regulatory alignment. AI adoption must comply with frameworks like the European AI Act, which promotes safety, transparency, fairness in medical applications. So, what are the ethical framework in different countries? While I was reading, I saw like in Saudi Arabia, most of the ethical principles, they are around their religion, like crucial framework grounded in the Islamic law, Sharia law, ensures healthcare professionals align with the religious and the ethical values. The principle includes all the four things, and there's a, basically they are more like with their religion. The challenges in rheumatology over there is a discrepancy between prevalence of rheumatic diseases and availability of competent qualified rheumatologists. There's shortage of rheumatologists. There's loss of interest in rheumatology as a subspecialty among internal medicine residents. And factors which are influencing the treatment and outcomes over there, that is the disparity between how patients and physicians assess disease activity, patient concern about long-term side effects of DMARDs, cultural background, age, and educational level. But if you like see the Canadian Medical Association, the Code of Ethics, the principle which they see looked at is fundamental responsibilities, responsibilities to patients, communication, decision making and consent, privacy and confidentiality, research. So there, like the ethics, it revolves around these 5 principles. And if you see the US Code of Ethics, there again, their context is like the patient-physician relationship, the informed consent and shared decision-making, privacy, confidentiality in the medical records, research and innovation, and interprofessional relationship. But if you see the Indian code, I think we really need to focus over here in our country because we are just having provisions of code of medical ethics in India. So there very little is on the research and upping, but now the medical profession, I think a lot of people are coming from outside to get treatment in India because of our infrastructure, the amount of doctors, the amount of medical professionals. But still, like, lot need to be seen over here, and I think as the societies create more power, they can do something over here. Because the provisions here are like maintaining good medical practices, physician must respect human dignity, continually improve skills, share knowledge, follow scientific methods, highest quality assurance in patient care, maintenance of medical records. I think still like we are not being able to come up with many of the researches because of the poor maintenance of these medical records. Now the EMR being used, obligations to the sick, payment of professional services, unaffordable cost of the private healthcare and lack of cost moderation, information imbalance is there, referral fees. The practice of paying referral fees is described as appalling and disgraceful, significantly adding to the cost of care and undermining the host relationship between doctors and patients, polypharmacy, alternative medicine, and cross-system medical practices. Just look at like what we are talking in our like Indian ethical issues, rather than like what the West is talking about, the research and the integrated medicine and all that. So there are a few case scenarios. I think, am I permitted, Dr. Vishnu? Shall I leave over here? So these are the conclusions. So medical ethics is a vital cornerstone of a responsible care in musculoskeletal diseases, yet it often remains under-discussed. If we fail to reflect on it and pass it forward, we risk leaving future generations with tools but no ethical compass. The true need today is not just innovation, but integrity, grounding our clinical advances in ethical reflection, equity, and accountability. As doctors, let's ensure that ethics evolves alongside science. Thank you.
Medical Council's requirement was that the session should be 30 minutes, and the secretaries were utilized in full, 29 minutes.
Thank you, ma'am, for a wonderful, elaborate discussion on the medical ethics and especially the challenges and dilemmas we face during our practice. So the floor is now open for questions.
Only comment, please.
Okay, the floor is open for comments, if any.
Nice presentation, very timely. What is the difference between good clinical practice and ethics?
See,
We
sir,
used to follow discipline.
whenever we follow the good clinical practice, like we always see the benefit of the patient. And if we see the ethics, then it becomes little different. Like the patient, somewhere maybe like he's suffering from cancer, he's dying. The good clinical practice is to make his end life like comfortable. That is the ethics. But sometimes many people like do other alternative medicines, whether they are benefiting or not. It's a good clinical practice. So it all in the mind of the physician, like what he thinks.
So with this, we conclude this session. Thank you, ma'am, so much.
Thank you, Dr. Kiran ma'am, for the insightful session. I would like to announce that all the people who are participating in the platform presentation are requested to submit their presentations at the operation desk towards the left side of the room. So after all these wonderful talks that delved into a variety of topics from pathogenesis, lifestyle changes, pharmacotherapy, surgical interventions, the advanced modalities for cartilage regeneration, we are finally proceeding to the last few sessions of the day that would include a debate, platform presentation, and quiz sessions. First, it would be a thought-provoking debate session we are surely going to enjoy. For presiding over it, I would like to welcome upon the stage Air Vice Marshal Dr. Shankar Subramaniam sir, Senior Consultant Rheumatology from Shillong, and Dr. Sucheta Saha ma'am, Senior Consultant at Department of PMR, Department of Neurorehabilitation at Institute of Neurosciences, Kolkata. Before starting the session, I would like to just overrun through the rules of the session. The debate would last for a total of 36 minutes. The candidate for the for argument will have 12 minutes, followed by 12 minutes for the against argument. Each will have 3 minutes each for the rebuttals, and the chair will provide their comments for 3 minutes, followed by 3 minutes for audience participation. Thank you.
Hello. So we are all assembled for unarguably the most exciting session of the 2 days. And I think the topic is also very interesting and controversial. It says there is little to expect from exercise therapy in osteoarthritis. So for the motion, that is someone who's going to tell that exercise is not really good, we have got Dr. Nilesh Nolka, consultant rheumatologist from Mumbai. And someone who's going to say that exercise is very good, we have Dr. Kshetra Madhav Das, HOD PMR from Bardhaman Medical College. But before we start, I invite the speakers to speak for and against the motion. I would like to know how many people believe exercise is useful. Please raise your hand in osteoarthritis. No, that's okay. We don't know all. Okay, now, how many people believe that exercise might not be so much useful? 1, 2, 3, 4, 5. I see 5 hands. So which would mean that the way we would be judging, I suppose, is that if at the end of the debate, if you are able to make 5 into 6 or 7, I think that you have been able to sway a couple of people. And if it comes down to 1 or 2, then otherwise, if with 99% anyway believing exercise is good, so the debate was already loaded against you. So over to you, Dr. Nilesh.
Many thanks. So the PPT is loaded. Yeah. So thank you. That show of hands actually is what I expected. When this topic was given to me by Dr. Vishwadeep Das, I was like, there is no chance I'm going to win it. But my 6 days of intense researching and 2 nights of intensely preparing this PPT in 2 nights in ITC, I think I'll try to sway most of the people here. So I'm debating for the motion that there is little to expect from exercise therapy in osteoarthritis, and thank you Dr. Vishwadeep Ghosh and team Sorcon for making me do this, and thank you for inviting a huge amount of PMR people here. so I am already on the negatives. So you should exercise for osteoarthritis, but somebody say, what's the point? I still have osteoarthritis. Let's clarify, what benefits do we want for OA patients in our clinic? Pain relief in short and long term, relative cost effectiveness due to long term nature, better functional capacity, sustainable effects, prevention of further damage and arthroplasty. You have to understand that I am talking for little benefit. I am not saying exercise has no benefit. You have to understand when I am talking of benefits on exercise on osteoarthritis, judge me on osteoarthritis effect. I am not saying exercise is bad. Exercise lot many other benefits, but does it really affect your osteoarthritic joint is the debate here. And the question is, we are talking about structured exercise program rather than just asking the patient to be physically active. Don't vote for what feels right. Vote for what was argued right. So as long as 2019, there was a trial which said, do we need another trial of exercise on osteoarthritis? They showed a funnel plot. There's enough evidence, even if probably some person comes with a trial saying that exercise is bad or good, it will not change the evidence. The evidence is good enough that exercise has at least modest effects in osteoarthritis. And during the last decade, it has become heavily promoted and commercialized around the world, so much so that the ACR and ORC says that the core therapy should be exercise. Now, the basis for strong recommendations stems from very good studies, but there is no problem. The problem is there is no comparator arm which is equivalent to an exercise arm. And study designs only partially account for contextual effect, and that will be my point of argument here. Now, this is in strong contrast with other treatments. You do acupuncture, you do transelectric nerve stimulation, and you arrange a sham placebo, and when they are not taking effect or they are equivalent to sham placebo, you say that they should not be used. But the same parameters have not been used to judge exercise, and you are still saying exercise should be done by an osteoarthritis patient, or a structured exercise program should be given to them so that somebody earns out of it. So why are we debating? So 2003, there was this paper where moderators of the effect of therapeutic exercise on knee and hip osteoarthritis, we had this individual patient data meta-analysis, which differs from a meta-analysis in the fact that when you judge a meta-analysis, you are only taking standardized mean difference and the overall data. But when you do an IPD meta-analysis, you take the raw data of that trials and actually subject it to more post-mortem and then get more data out of it. They retrieved IPD data from 31 trials with 4,200 participants. They examined whether exercise actually has any influence in the short term, medium term and long term. Do you see, they had pain relief, they had physical function relief. By what points? Maximum by minus 6.5 points, minimum by minus 3.4 points. Statistically very significant, but clinically meh. So pain and function scales, ORC and impact, what they say, what do you need for MCID? You need at least an improvement of 10 points to call it MCID or a relevant improvement in clinical practice. Leave alone minimum clinical improvement, nobody could reach large benefit. They did a moderator analysis, what are the factors which will help you to say that exercise works. The only two effect where probably it showed some benefit was patient who had higher pain, they said ki we got benefit, or patient who had higher poor function levels, they said they got benefit. And you have to have a very selected group of patients who have a very high pain and function disability score to say that it worked. Again, my argument is not that it has little benefit. My argument is whether it has a major benefit. So what are the problems with exercise trials in OA? There is selection bias, there is poor controls, there is short follow-up, there is diverse interventions, there is outcome limitations, and MCID is not achieved. For all those things, you will castigate every other treatment in OA, but you will not castigate exercise because you have been made to believe that exercise works in OA. So, I will give you some articles. Exercise versus intra-articular saline. So, if you give something against exercise, which has a strong placebo effect, it shows no effect. Again, when you do a randomized double control trial to show that whether a physiotherapy works even against placebo or normal attention control, it doesn't work. When you actually give an intensive diet and exercise regimen to a knee pain patient, again, against normal attention control, you give just attention to the patient, give some booklets, ask them to be physically active, it doesn't work. So, if you have a comparator arm, always remember this, what is the comparator arm? If you have exercises where placebo effect is there versus comparing with nothing, that is an attention control, exercise will win in the studies. Do you remember what actually works in OA? All the studies which works against an attention control works. Why this works, I'll come to that. But if you give exercise against a strong intervention placebo, for example, if you give saline injection to patients and compare with exercise, it will not win. Probably if you compare exercise with acupuncture, it will not win. So there are reasons why exercise wins in all the trials. So contextual factors have reported to explain on average about 75% of improvement. And that is the problem when you debate about a structured exercise program working in OA trials. The most frequent argument is it was a wrong type of exercise, they did not do strengthening, inadequate dosing of exercise, or there is a wide variety of exercise programs which has been reported to be benefit. In fact, if you murder the data, you will find everything is effective in OA if it is not used with a proper comparator arm. So they did a trial where they compared whether a high intensity program versus a low intensity program versus a normal attention control actually works, and voila, there was no difference in the treatment arm. And this is a very good trial published in JAMA. So are we actually having boxers fighting, or we have the ring masters actually winning the debate? Probably the boxers are not playing here. Probably it's the placebo effect, the contextual effect, and something called regression to mean. Beautiful word, regression to mean. If you have to take one sentence or one particular thing out of treatment in osteoarthritis, always remember placebo, contextual effect, and regression to mean actually explains most of the benefits in OA trials. And unless and until you nullify those effects, you are not going to be able to say that that intervention actually worked. So we need adequate blinding, and I'm sorry, the regression to mean slide is probably not here. So what basically regression to mean means, suppose if you have exercise has a waxing waning effect. So in regression to mean, what happens if you choose patient at different point intervals? When do you choose the patient? When they have maximum pain. But when you pool the data, all the patients who have varying levels of pain are actually taken at the height of their pain. And that data is pooled together. But that patient had different point intervals, excessive pain. But when you pool that data at their highest intensity of pain and follow them up, most of the patients will have some decrease of the pain. That is because of the natural history of osteoarthritis, and that is called regression to mean. And that is one thing which works the most in OA trials, and exercise has almost 60% regression to mean effect. So in the case of exercise, when the conviction of efficacy ends up being presented as guidelines as strong evidence, you can actually call it the truth, but it becomes the truth. It is not the truth. And if we say exercise benefits OA, why we are castigating acupuncture? Why are we castigating glucosamines? Why we are castigating TENS? And that is my point of argument here. So if you tell a lie 10 times, it becomes a truth, and that becomes the point here. I'll come to this story, a very famous story by a Dutch guy, where there is a very savvy emperor who actually likes to spend state money on clothes. He is made to believe by two viewers that we can actually give you one of the best quality of clothes which can be only seen by very committed people only and very intelligent people only. So the emperor goes to the factory. The factory is empty. Everything is empty, but the cronies and the emperor cannot say that they are not intelligent and committed. So they say, oh wow, you are making very nice clothes. And they actually wear those imaginary clothes and walk out in the procession. What the poor public can do, it has to believe and tell the emperor, oh wow, you are wearing a very good cloth, because we are intelligent and committed. We can actually see you wearing the cloth. But a problem is the child blurts out, oh, the emperor is naked, he is not wearing anything. So my dear friends, exercise definitely have lots of benefit in OA. You are made to believe that. But there is little to expect from exercise in OA, and be the child in the story and don't fall for it today. So this is what I was explaining. What is regression to mean? You take the patient at various time points, but you pool the data when they are in maximum pain. And in all patients, this is the asterisk when you pool the 3 patient data, But these patients had pain, high level at different time points, but while pulling, you showed that, okay, they had all the pulling was done when they had the highest amount of pain, and by regression to mean, this will actually show decrease in almost all the patients. And this is the problem. It can account for almost 60% of reported average improvement. So you have a placebo effect, you have a contextual effect, and you have a regression to mean effect. These three effects actually account for everything in OA when the trial is very poorly done. So structured exercise programs are offered as a valuable service. They definitely are of value, those who monetize it. And there is little to summarize, little to expect from structured exercise therapy in OA. But in acute OA with higher pain scores and worse functional scores only, can exercise increase pain and cause harm? Possibly, yes. Is that a structured exercise program, which can sometimes cost up to 5,000 to 15,000 rupees in India, is cost beneficial? It's very controversial, and if you look at the data very hard, there have been various cost benefit analysis which are negative. Applicability on a large scale, very difficult. Improvements are modest. So rather than doing that, just asking patient to be normally physically active with some pain improvement can actually go a long way in most of our patients. So does it ultimately delay or prevent knee replacement? Almost all the trials will say no, it does not. So it does not actually do anything if you look at the data at very hard pain points. So I know I'm standing against the guidelines, some consensus, PMR people, but remember, even Goliath had a weak knee, probably because the PMR people made them do too much exercise. Thank you. And if you want, I can probably end up with this poem inspired by Sapan Pandya sir from last week's RAG Con. So, once upon a knee gone bad, the patient came all limpy and sad, said, do something please, I am losing class. He landed straight in the clinic of Dr. Das. Muscle train, Dr. Das said, be brave, your knees will heal, just stretch and wave. So up the mat and down the grass went the loyal patient of Dr. Das. Week 1 scratched with SAS. Week 2 still fell on his body mass. Sir, I am more udas than the day I first met you, Dr. Das. Keep going, said Dr. Das. Strength is a must. This OA thing you just can't trust. But the knee said crunch with every pass, mocking the man and Dr. Das. Rehabs grew, sessions in a mass. Dr. Das upgraded to a premium pass. While the knee still groaned, the broken bars, the patient cried, bus enough, bus, Dr. Das. But I care, said Dr. Das with eyes of glass, and has he billed for one more gluteal class? Try Theraband with extra sauce. Patient replied, you are world class, but Dr. Das, Abbas. Now some whisper, not with malais or sauce. Is this rehab better than placebo, alas? For OA scores, stubborn and crass, often improves with or without Dr. Das. Yet Dr. Das smiles with a knowing grace. Some needs time, some just embrace. He still guides reps at a mindful pace with more hope than proof and a smiling face. Thank you.
Thank you, Dr. Nilesh. So, Dr. Das will be here on stage to guide us on something more than reps. So, I invite Dr. Khetro Madhav Das to take up the challenge.
Good afternoon. Hello? Hello? Is it? I'm audible here. Good afternoon, everybody. What he just told, I can't call it hitting below the belt. Rather, I will sportingly accept it like some punches above the belt. And though I'm not going to counter punch him above the belt, but still, let's come to the topic straightway. So it's my turn to speak against the motion of today's debate. There is little to expect from exercise therapy in osteoarthritis. At the outset, I would like to congratulate and thank the organizers for inviting me and also for choosing this topic as the motion of today's debate, because it is very important. Because though everybody raised their hands, almost everybody, for the therapeutic exercise, but forget about the common persons, non-medical persons. Even most of the doctors, including many rheumatologists, and to be very honest, including a number of physiatrists, also are not properly aware of the true efficiency, true usefulness of therapeutic exercises. Even my fellow speaker, Dr. Nolkha, has always mentioned exercise. He never mentioned therapeutic exercise or exercise therapy. There's a huge difference between exercise and therapeutic exercise. Our traditional mindset prevents us to accept that. Our traditional mindset prevents us to accept that therapeutic exercise, which is non-pharmaceutical agent, which is non-surgical thing, can be a major treatment component. Yes, we should admit that therapeutic exercise is not just, as we often call, the supportive treatment, supportive care, supportive therapy. No, it is the mainstay of treatment. It is the cornerstone of treatment, at least in the osteoarthritis. And I hope after this debate, this dilemma will be gone. Our traditional mindset, our misconception will be destroyed, and we'll be much aware of the true value of the therapeutic exercise. While I am thanking the organizers for choosing this topic, at the same time, I don't want to lose the opportunity to criticize a little. Here the word little is a less unsuitable, a little inappropriate, and a little loose for the motion of a debate, because a motion of a debate should have an objective delineation, and because of the use of this word, that objective delineation is getting hampered. No, don't take it so seriously. I'm just trying to infuse some true spirit of debate, and also doing a leg pulling for my friends, Dr. Vishwadip Ghosh, Dr. Parashar Ghosh, and definitely the friends from the academic subcommittee. So, respected chairpersons, my senior, junior, and contemporary colleagues, and of course, my fellow speaker, Dr. Nolkha. What a brilliant speaker he is. But unfortunately, today he had to speak for the motion, to trying to substantiate a non-scientific, unscientific lie and a non-evidence-based untruth. I may not match his oratory excellence, but I'm sure that after the end of my presentation, I'll be able to substantiate my point, because whatever I will say totally evidence-based fact, only fact, and nothing but fact. Because the exercise therapy, as you know, it has the strongest recommendation by all major professional societies. And no other therapy, no other pharmacological or any other tool can even come closer in the terms of strength of recommendations, the number of recommendations, also the consensus among different professional bodies. It has the highest number of evidences by Cochrane reviews, meta-analysis, and research articles. He has pointed a few articles, meta-analysis, etc. But most of the Cochrane reviews, meta-analysis, research articles, and unbiased one, they are supporting the therapeutic exercise strongly for the treatment of osteoarthritis. But last but not the least, and the most important point is, it is the most efficacious as far as pathogenesis rationale is concerned. It has the capacity to affect, to alter each and every steps involved in the pathogenesis of osteoarthritis. How? I'm going to explain in my next few slides. The three most commonly involved joints in osteoarthritis, all of us know: knee, hip, and first CMC. Because if you look at the evolutionary morphology, we can understand that these three joints have gone through extensive transformation. Knee, hip, the first two, because of our upright posture and the bipedal gait, and the last one because of our prehensile grip. So, to climb to the top of the evolutionary tree, we had to give some prize, and that is in terms of susceptibility to osteoarthritis. Again, we know that intra-joint damage takes place in the areas of maximal loading. So, the evidence is there to believe that osteoarthritis is a biomechanically driven disease.
At the same time, we know to alter this altered joint biomechanics, to adapt to this, chondrocytes and of course other cells, other structures had to go to transformation, something, and through mediation of this, not only this, some other steps are there, some other processes are there, I'll come into later on. They ultimately cause the osteoarthritis, destruct the joint. So the evidences are there to believe the osteoarthritis is a biochemically mediated disease also. Now, I like to draw your attention to this famous diagram. I have taken this from a rather older edition of Kelly's textbook of rheumatology. Here, the mechanical forces, I repeat, the mechanical forces is initiating this inflammatory cascade, ultimately leading to osteoarthritis knee. That means the biomechanics, the altered biomechanics initiates the process, and then biomechanics, biophysics, biochemistry all converge into one single point, and that single point is the pathogenesis of osteoarthritis. So these evidences were already there at the fag end of the last millennium. You may criticize me of using older evidences. So I am showing you the newer diagram. It has been taken from a publication published in 2023. And here you can see the same thing is happening. The mechanical stimulation is initiating all the things. Not only that inflammatory things, also the apoptosis, autophagy, sensation, and the methylation of DNA, ROS, etc., etc. All the process involved in the pathogenesis of osteoarthritis. And after we came to know about the structure and function of piezo-1, must be everybody is knowing about the piezo-1. We know that this is an ion channel protein primarily known for its role in transducing mechanical stimuli into cellular signals. So the mechanical stress, the mechanical stimulation is the primary thing which is causing the osteoarthritis knee through the mediation of all these processes. And that is the reason we know that biochemically normal joint, when non-injurious loading is applied to that, that results into normal cartilage mechanobiology. At the same time, the same non-injurious loading in a biomechanically abnormal joint results into cartilage damage. And at the point of time when it was believed that cartilage is the only principal structure of a joint to be involved in osteoarthritis, the famous osteoarthritis scientist, Dr. Brand, K.D. Brand, once told that cartilage is not the culprit, but the victim of the altered biomechanics. And now, as we know, that along with the cartilage, the subchondral bone, synovial membrane, and many other structures of the joint, of a synovial joint, is involved in the pathogenesis of osteoarthritis. We know that all of them are not culprit, but they are the victim of the altered biomechanics. And that altered biomechanics can be addressed by only one thing, that is therapeutic exercises. So exercises as these functions, they can even relieve pain. And because of our traditional mindset, we hardly believe that they can significantly reduce the pain. But actually, they can. Their pain relieving factor is comparable to analgesics and oral NSAIDs, and also with much fewer side effects. And at the same time, they have a protective mechanism through activation of cellular processes like autophagy, and also they can regulate inflammatory cascades, ECM pathology, autophagy, apoptosis, cellular and molecular events, as I have shown in that diagram. So they have both symptom relieving and disease modifying functions. This was the thing, all the processes involved in the pathogenesis of osteoarthritis, degradation of ECM, cell proliferation, as I was mentioning, and all these can be modified by therapeutic exercise. Huge evidence is there. Everything, the therapeutic exercise has positive effect on all the aspects of this pathogenesis, and this is a list of more than 50 odd trials, which is showing that the therapeutic exercise has the positive effects on the different phases, different processes involved in the
pathogenesis of osteoarthritis. And these are the ACR recommendation. And because of all these reasons, it is lying at the top. Also in the Euler recommendation, the OARCI recommendation for hip, knee, and polyarticular, everywhere it is lying at the top. And also in the NICE guidelines, it is advocated for all patients with osteoarthritis, their clinically important benefit, superior safety profile, and long-term benefit. And these are an interesting study which compares 6 guidelines for OA management, and they conclude that largely concordant with one another, all these 6 guidelines. And these are the huge Cochrane reviews, meta-analysis. I have mentioned just a few, but these are path-breaking studies which is supporting. Bearing a few studies like this, after the publication of these studies, many persons try to denounce and demean therapeutic exercise, but there they also admitted that low to moderate certainty evidence is there. Their only problem is there, that uncertain clinical importance, because the participants in most trials were not blinded. So they are not talking about the fallacies of therapeutic exercise. They are talking about the loopholes of different clinical trials. So exercise therapy is the only treatment which addresses the problem comprehensively, the only therapy which targets all the involved structures globally, the only clinical management with the potential to alter all the pathways of pathogenesis of osteoarthritis, and the only option with its effect on the central and primary cause of the disease. So I strongly believe that significant improvement is to be expected from exercise therapy when it is used judiciously and properly in osteoarthritis. Whether you agree with me or not, thanks a lot for patient hearing.
We can have rebuttal from Dr. Nilesh. And you can continue standing here, Dr. Das, so that you can answer his questions. And then you will get your chance. Sure.
So thank you, Dr. Das, for actually falling into the trap. Basically, again, I will reiterate the fact that I never argued that you should not ask patients to exercise. The question is, if you are giving an expensive structured exercise program versus just giving some pain relief and asking the patient to be physically active, which is what we say little to expect from therapy. In real world, the problem is not of evidence. I am a gold medalist in DM. But you know how many candidates we were? 2. So exercise is a gold medalist, but in a field of actually having no other counter argument. You are comparing it with a placebo effect, when actually if you compare it with a strong placebo effect, it falls null and void. Don't argue on the point it will be beneficial in some. Yes, it will be beneficial in some. The question is the larger studies and the effect it is showing that it will not be actually beneficial as a therapy in a huge number of population in the long run.
Please ask a question to him. In rebuttal, you are supposed to ask a question to your
Okay, so my question is, does it benefit in the long run? Does it actually have long-term effects? And the answer is actually no in most cases.
No, unfortunately, this is not the scenario, true scenario. In most of the cases, it is going in favor of long-term benefit, as I have already shown. Even in some meta-analysis, most of the meta-analysis, Cochrane reviews, they are showing long-term benefit when the patient is compliant with this. But the problem is that I have mentioned that is a core point, that because of a traditional mindset, we don't want to accept that something which is non-medicinal, non-surgical is a treatment modality. It doesn't prevail, this misconception doesn't prevent among the non-medical persons also. Only it prevails also in the mind of us, the doctors, medical professionals. And that is the biggest problem. The problem is with compliance. So wherever it is compliant, and everybody is mentioning that it is, whenever it has ensured the therapeutic, the patient were doing the long-term therapeutic exercise, they are gaining the benefit. But if the exercise therapy is for short-term only, then you cannot expect long-term benefit from that.
Any questions from your side to him?
Yeah, yeah, you were telling about that basic integrity of those studies which have utilized the therapeutic exercise. Yes, many studies have used sham exercises, but you know it is very difficult to formulate. Sometimes it is impossible to formulate the sham exercises. So they have compared with other non-pharmacologic therapy. Even they have compared with some pharmacologic therapy. There are lots of studies. I have mentioned around 51 studies, and among that 51 studies, at least around 20 studies, they have compared it with the pharmacological agents. And it is very difficult. You cannot expect the same kind of the RCT in pharmacological, using two pharmacological or placebo is quite easy. But here it's a difficult. So when it's a difficult scenario, we have to improvise it, and they are
Dr. Das,
improvising it.
please ask him a question. In rebuttal, you're expected to ask a question to your opponent, please.
Aren't we at the same time?
You don't have to justify. You already given your case.
Okay, I thought that rebuttal means cross-argument kind of thing, counter-argument kind of thing. I may be taken mistaken. Okay, anyway. So the question, okay, you're talking about that running the circus. You're talking about the business behind this therapeutic exercise. Is it the business, or the much more business is run by the pharmaceuticals company? That is the reason there was a huge hype about hyaluronic acid, huge drum beating about diacerin. At that point of time, we thought that some magical thing has come. But actually, I believe that therapeutic exercise is not getting enough support, because there is no profit. So big houses are not coming. What is your comment on that?
My comment is very simple. I have not drum beating about anything. In actually every trial in osteoarthritis, there is regression to mean, there is a contextual effect, there is a placebo effect. In fact, nothing works in OA. The problem is, if you keep on harping on the fact that you have to give a structured exercise program to osteoarthritis patient and it is actually working, it is probably not. I just want to ask you, you are talking about biomechanical factors, you are talking about these trials which are showing that there is definite effect. There is actually very good large editorials, very good data set to support that actually there is no in fact change in biomechanical factors. There are good references. If you can review Martin Agland's editorial, they will show you that the effect of actually biomechanical factors is most importantly explained by weight loss. So if you ask me what is probably the best thing, weight loss, probably exercise is the next best thing. But the question is not that. What I am arguing and what you have to answer, does it have more than little benefit, and can it be given on a mass proposal to a large number of patients?
Circles, so that we are good.
Yeah.
My co-chair, do you have any comment before you throw it up to the audience?
Yeah. So to summarize, we'll see that rehabilitation is, yes. Of course, both the speakers have done justice to their topics, but being a rehabilitation physician, I would like to emphasize it is not only the exercise therapy that is called rehabilitation in osteoarthritis knee, it is a holistic approach. It is the medicines, it is the exercises, it is the orthotics, and of course, the role of surgery comes on later, and even before and after the surgery, we need to rehabilitate the patient. We must think that whether we can strengthen quadriceps with any kind of pharmaceuticals, whether we can train the patient with undergoing TKR without any rehabilitation exercises. So these are the takeaway message that it is not only the exercise therapy and the holistic rehab, including the pharmaceuticals, including the joint protection, and exercise should always be supervised, because most of the patients are elderly and unsupervised exercise therapy can be detrimental for them. We should always guide them to do the exercises under a rehabilitation physician. Thank you.
I have 2 points to make. The first is to Dr. Nilesh. Actually, when you say there is little to expect, it means a little means itna, little to expect means zero. You exploited the English term which he gently hinted at, but he did not really catch on to it. Just my comment. And Dr. Das, when you said that people are not very happy with structured exercises, 99% people are on your side only. So it is not that people, everybody is actually on your side. So now I throw the thing, any comments, any questions by anybody? Yes, please come.
Sir, can I just clarify? I categorically mentioned, though almost everybody raised their hands, but most of them are not adequately aware of the proper utilization of therapeutic exercise as a treatment modality.
That's fine, but still the 99% believe in it.
Yes,
Okay. Yeah, any questions?
There are two meta-analyses published in recent times. One in Lancet Rheumatology in, I think, 2023, and another one is PLOS ONE.
I showed one of them.
Yes, PLOS ONE, probably.
No, Lancet one.
Lancet Rheumatology, okay. Both of them, same result. In short term, there is benefit of exercise. Medium term, doubtful. Long term, no.
Okay, yes, comments.
Sir, again, I am from PMR. So, although I won't be biased, being a student, I will just talk like a layman, neither an expert.
You're permitted to be biased, sir. Please go ahead.
Lancet. One of the common cause for this OA knee is obesity. So, every medical science book, every journal, first line they write, how will you manage the obesity is diet and exercise. It is proven. So exercise, as sir said, structured exercise, yes, definitely has a role. Loss of weight, we do need it, and we have found a lot of improvement in the patients.
Can I answer that? Or
Yes, please. Yes,
yeah.
please.
So, very good, thank you. I never said that exercise won't cause loss of weight and exercise won't cause. The problem is, if you are making a patient do knee exercises only and or asking them to just walk or giving a huge amount of structured exercise program, there is no doubt that exercise help osteoarthritis patients in many different ways. The doubt is whether exercise has any real benefit on the joint in motion on a large scale.
Or is it because of weight loss?
Yes,
Okay, any other
yes.
comment, please? Okay, there is, yeah, we have a comment there.
It will be moronish to argue that you should not exercise. That is not my point here. My debate is never was about that.
Given a choice, even Nilesh would have raised his hand
Yes,
for it.
yes,
He was given
yes.
the topic. Yeah.
A comment on the effect of exercise on knee joint. So what has been seen is that the cross-sectional muscle area and the fatty infiltration would affect the progression. So what happens in patients with osteoarthritis is that there is atrophy, muscle atrophy with fatty infiltration. With exercise, the cross-sectional muscle area builds up, and what has been seen is that if the cross-sectional muscle area is more and there is less fatty infiltration, there is independently related to the disease progression. So they are less likely to progress.
Agreed.
From
So
pathogenesis point of view, you're saying. Fair enough.
I can
So-
argue on that if.
Yeah, sure, go ahead.
So there are actually a good number of studies that even after 1 year of follow-up of a significant number of patients, where they actually followed up those patients, there was actually no change in difference to actually going to progression or osteoarthritis. So it does have imperceptible benefits, and that has some contextual and placebo role. But does it really in the long term change anything is the question here. My argument is not to be physically active. I'm not saying you don't become inactive, sit at home. I am saying whether a massive structured exercise program to a large number of patients in a poor country like ours, where cost effectiveness and issue versus a low dose drug bus plus some basic physical therapy or physical activity advice is more than enough, or you give a structured exercise program which is expensive to everyone. There are good number of studies which says that the Denmark program, the escape program in UK actually have shown benefits only when their contextual effects have been taken into account, and if you take off the contextual effects, regression to mean, they will not show any benefit in the long run compared, and I showed you high muscle strengthening group, low muscle strengthening group, and no
Chalo, done.
exercise
Dr.
group
Nilesh,
for a year.
What we'll do is
I
that
just
before we
want to
put
add.
the-
I just
Okay,
want
go
to
ahead,
add
yeah.
one thing. Yeah. Apart from the macroscopic changes, you are talking about the macroscopic changes. You should look in the microscopic changes too. The thing is that every treatment of every disease has been revolutionized after we started understanding the etiopathogenesis. And if we look at the etiopathogenesis, there are lots of
papers are coming. I have mentioned which has been done in the last decade or so. Previously, it was not done. Nobody has ever thought that therapeutic exercise may have some disease-modifying activity. But now, as it has been evidenced by both molecular and cellular study, at the same
Wonderful,
time,
Dr. Das. We can make out both of them are
There
now
is
emotionally
no
charged.
study
No,
to
enough,
say
Dr. Nilesh.
there is no study to say that exercise has a demote effect even after 2 years.
Perfect. Okay, now what we'll do, before we put the house for vote, last word by Dr. Das. No, so I think we have to go for the next program. We'll have Dr. Das. Yeah.
See, there are two things about osteoarthritis. One is whether it is what is a disease. The disease is damage to different parts of the joint, which is basically there is some damage to the menisci, which possibly is the starting point of osteoarthritis. There is a damage to the bone, the BMLs in the bone. There are osteophytes, and damage to the cartilage. So these are the four things which occur at the structure of the joint. Now, what are the clinical presentations? Clinical presentations mean what is the illness. So one is a disease. Osteoarthritis as a disease is different things. Just like in coronary atherosclerotic heart disease, there is atherosclerosis in the coronary artery. But as a disease, it manifests as pain. And this osteoarthritis manifests as pain. The second thing after pain comes is restriction of the movement of the joint. There is functional loss, and slowly that pain becomes a chronic pain, then spreads downwards and upwards, and sometimes it becomes a pain in the brain where the pain just keeps on happening whether or not there is any problem at that point of time. Now these are two different things: management of disease and management of the illness. Now, one thing that has not been done is clarifying that whether you are talking of the disease or you're talking of the illness. If you're talking of the illness, there are lots of things which can improve the illness, and you can have maybe 70, 80, 90 or even 100% benefit to the patient without giving anything, and maybe you can get some benefit in the illness by exercise also. In some people, the illness is made worsened by exercise, and they are much better off without exercise if they don't do an exercise. So this is absolutely a different gamut. The second thing is the proof of the pudding is in the eating. The question is, the proof of the pudding is in the eating. If you eat, then only you'll have the calorie, you will know what is the taste of the pudding and what the pudding is all about. So the question here is, have we been able to show that you have been able to change the disease in osteoarthritis?
Sir, yes, sir. Thank you.
No, this is a comment, the rhetoric. So we'll just have a show of hands, since it's easier to say how many people now believe. 5 people initially believed that exercise is not so good. How many people are in favor of Dr. Nilesh Nolka? Raise your hands. It's become, say, 20, 25. You still have a vast majority, Dr. Das, but from 98% you come down to 90%. Congrats to both of you. Thank you very much.
Thank you.
Thank you, Dr. Nilesh sir and Khetra Madhav sir and the chairpersons for a wonderful and a thought-provoking session. I think the audience must have enjoyed it thoroughly. So I would request you to stick to your respective seats, as we will be having some good papers that will be presented before you in the next session that you will certainly enjoy. To organize this next session, I would like to call upon stage Dr. Dipendranath Ghosh sir, Consultant Rheumatology at IPGMR. Sir, please.
Good afternoon. This will be a platform presentation. There will be 5 presentation. First of all, I would like to call Professor Bikash Agarwal sir, Professor SDPGI Lucknow, and Dr. Sunip Upadhyay, Consultant Rheumatologist, Indraprastha Apollo Hospital, Delhi, for evaluate the paper. There will be 5 papers, and these papers are from basic science as well as non-pharmacological therapeutic and pharmacological therapeutic. And presentation will be completed within 7 minutes, and for question and answer there will be 3 minutes. First of all, I like to call Dr. Vijay Lakshmi Venkatesan for presenting beneficial effects of bone marrow derived mesenchymal stem cell to negate knee osteoarthritis preclinical approach from preclinical way.
So at the outset, very good afternoon and thanks for the opportunity. So my job has been made very simple by the pre-lunch topics to show that the efficacy of BMAC and PRP, which has been already been practicing in our clinic. So coming straight to the point, our hypothesis that knowing that the BMAC has a lot of stem cell potential, so we went ahead with the isolation of the clinical applications of the bone marrow derived MSCs. So we have actually characterized the MSCs and then we have shown in a preclinical model in the management of osteoarthritis. So I work for Regenix company and their focus is on regenerative and repair process. So after going through the very hectic the pathophysiological changes in the osteoarthritis, I will skip that. But I will go into the mesenchymal cells because of their immunomodulatory, anti-inflammatory, paracrine, and the crosstalks what they bring about in situ. So that is what fascinated, and it's the important regenerative aspect in the stock. So our experimental strategy involved, we created a model of monosodium acetate mimicking the osteoarthritis, and after ensuring that there is an inflammation, we injected them with the bone marrow mesenchymal stem cells, 100% conferred by the cytotherapy with CD90, CD105, CD34 and HLA, and also the multilineage potential. And we looked into 4 different aspects, stratified aspects of their beneficial effects. So if you look at the stage 1, that is the joint histology, so it already shows that it is able to have a reversal effect. That is if you look at this 2.5, it is able to have through the OARS score, it is able to have the erosion minimized to a larger extent as compared to the MIA, which is having lot of erosion. The second one is further confirmed by the Janus Green, that is the cartilage regeneration. And we went through the micro-CT analysis and to show that there is a correction in the, the subchondral lesions and also the osteophytes. Although I won't say there is a total normalization, there is definitely a beneficial effect. And further going to the surface topography by the SEM, we show the smoothness with respect to the treatment stem cells post-administered to the MIA. So regarding the gene expression, we showed that there is a decrease in all the pro-inflammatory and upregulated in the anti-inflammatory. And very interestingly, we are also able to show the decrease in the COL2 biomarker characterization. And same thing we have done with the cytokines, and we see that there is a cytokine remodeling which is bringing by the bone marrow mesenchymal stem cells. So looking at the chondrocytes, we gained further insights into the chondrocytes, and the chondrocytes, all the allicin blue stem cells, and the chondrocytes are giving us a very good picture because it gives us a new insight about the mitochondrial biogenesis, and we find that there is more increase in number of mitochondria, and for the paucity of time, I did not give rise to the various structural and gene aspects, but we have done the entire battery of the cellular molecular profile. So we show that there is an enhanced chondrocyte viability increased biogenesis, decrease in situ free radical and oxidative stress, and also the knee joints are able to, at the end of 28 days, we are able to find the inflammation being decreased. So the discussion and conclusion is, so data collated from our present study, that is a morphological, biochemical, cellular, molecular, and functional studied in both serum in the knee joint as well as in the chondrocyte, suggests the promising therapeutic efficacy of the bone marrow mesenchymal cells, which has been obtained from our hospital with IAEC clearance, with the proper regulatory approval, and we show that the cells are able to home themselves using a labeled approach, which I have not presented here. Labeled approach, they are able to home specifically into the intra-articular region, and also the muscle which is adherent to the tissues are also able to cope up the stress induced by the MIA and able to recoup. So stem cell therapy has definitely opened up a feasible, non-invasive treatment in the osteoarthritis management because of the molecular therapeutic signature as immunomodulatory, as I already said, cell-cell contact, plasticity, and paracrine the secretome function. So way forward, we are advocating the stem cell application to address the needy subjects in the Indian scenario. And what I want to say is, we are not only restricting to the bone marrow mesenchymal cells, we are parallelly looking at the prenatal tissues of placenta, umbilical cord, and we are getting excellent leads in combination with PRP. We are trying to have a crosstalk, as well as we are also looking at the secretome as well as the exosome work. And for the, I thought my student will come and present, but for the, unfortunately she could not come. I'm very happy that Dr. Vishwajit Ghosh selected this, and just for us to share our idea from the group. So we are very actively working in this field, and I think I'd like to congratulate and thank my organizing chairman, Dr. Mova. He's from US. He comes every 40 days and treats the patient with BMAC and PRP. And we also thank the other members of the logistic team of the group. And these are the students who actually did a lot of work. Dr. Sunita, my postdoc, now she's working with me, Mr. Harris, Ramya, and our helping hand by Mr. Arun. So we are able to now go ahead with we have completed the PCT. We are looking out for the GMP accreditations and other regulatory requirements to go forward. Thank you so much.
Excellent presentation, madam. Just a simple query. There are lots of studies which has already been done with bone marrow mesenchymal stem cells. So how do you rate the quality and the sort of, where do you place your bone marrow mesenchymal stem cell? Because nowadays Stempeutics have got the approval for human osteoarthritis.
We take our product 100% because we have also confirmed with third-party validation.
Please use the mic.
Yeah, we have used a third-party validation for confirming ours, and we are sorting the cells through flow cytometer so that we get only the homogeneous population, and we are using the population at P5, sir. So we are not using the cells, we are extracting the bone marrow aspirate what we get from the hospital. We are isolating from the very rigorous technique, and at P5 only we are injecting the cells, and we are showing 0% CD34. Now the hemopoietic component interference is minimal, so hence our quality of cells are extremely good. So for therapeutic purpose.
How many mice or rat were used?
So we have used, for this study, we have used 6. This is an efficacy study, but for PCT, we are using around 250 animals for various acute, subacute, and chronic studies.
Right. So the paper is open for discussion or any comments or questions from the audience.
I have a comment to make. Yes. Now, if this product sees the next step and we go on to human trials, where do you see your product being different from one that is already available? There's this product called STEM1, and there's a company that makes these products that are taken off the shelf and injected into osteoarthritic patients, and this is ECGI approved. So I'm wondering where you would want to say that this is better than the product already available.
We are not going to have that kind of a debate, sir, which is good, which is bad. But what we are going to say is, keeping the alarming increase of osteoarthritis, which is actually being witnessed in Indian scenario, and because of the metabolic syndrome related osteoarthritis, even otherwise because of the diet induced osteoarthritis, we have seen the several confounding factors. So similar to so many drugs being present for a given condition being treated by various conditions. So we feel that having alternate and source and maybe the cost wise also we want to make it more affordable, because and also the million cells, according to their product, it is 25 million cells per given body, I mean for an individual. So since our product is as such what we have standardized in the PCT work, shows that we can go up to 15 to 20 million cells, which is able to bring the efficacy.
Thank you.
Thank you.
Second paper. Second paper will be from basic science. Macrophage-derived bone morphogenic protein signaling drives cartilage degeneration in obesity-associated osteoarthritis. It will be presented by Shahiba Thaleswari from IIT Kanpur.
Good afternoon, everyone. Today I'll be talking on the topic unraveling the mechanism of obesity-induced osteoarthritis, the role of chondrocyte hypertrophy and systemic inflammation. So looking at the burden of osteoarthritis, about 242 million people worldwide suffer from symptomatic and activity-limiting osteoarthritis. And it's the third most rapidly rising condition with disability and affecting mood, sleep quality, and participation in everyday life. When we look at the numbers, about by 2050, about 96.7 million people alone in India will be suffering from osteoarthritis. Now, this is a multifactorial disease. It could be caused by aging, mechanical injury, sedentary lifestyle, obesity, gender, or genetics. Today, I'll be focusing on obesity. And obesity alone increases the risk of osteoarthritis by threefold. Now, in case of an obese individual, it's not only the weight-bearing joints which are impacted by osteoarthritis, but also the non-weight-bearing joints, which can be attributed to the systemic inflammation persisting throughout the body of the individual. Now, this causes a healthy knee joint to shift to an osteoarthritic state. We'll focus on how the healthy articular cartilage looks like. In a healthy joint, you have a fine balance of anabolic and the catabolic factors, which result in the chondrocyte being secreting collagen type 2. While in case of an osteoarthritic one, the balance tips towards the catabolic factor, leading to the differentiation of the chondrocyte to a hypertrophic one. Now, the question arises that does inflammation trigger the differentiation of chondrocyte, or does the differentiation of chondrocyte trigger inflammatory cascade? To answer this, we took a 10-week-old mice and fed it with either regular chow, which is our control, or with high-fat diet for 4, 8, and 16 weeks. And at different time points, we harvested the load-bearing knee joint. We assessed it first gross by microcity analysis, and what we can observe is that at the articular cartilage, the increase in redness depicts the blood pool. While when we look at the 16 weeks old data, the redness or the blood pool amount at the articular cartilage has significantly increased. We further go ahead with the osteoarthritic markers, where in case of 8 weeks, you observe that there is significant thinning of the articular cartilage, while by 16 weeks, the femoral and the tibial condyles articular cartilage has thinned out. Furthermore, we validated it by the call2 marker, which marks the healthy articular cartilage, leading to gradual decrease of collagen type 2, while collagen type 10, which is a marker for hypertrophic chondrocyte, was gradually increased. Now, this transition between a healthy articular cartilage to a hypertrophic one is determined by the activation of the BMP signaling. This BMP signaling was upregulated by 4 weeks, and by 8 weeks most of the cells were positive. Now with any signaling there are two sets that needs to interact. One is the ligand, another is the receptor. So we checked for the abundance of the BMP-R1A receptor. The receptor is abundant throughout the surface of the articular cartilage. But with BMP2, the ligand, we observe that there are very few cells positive by 4 weeks, while they peak up by 8 weeks of high fat diet, gradually reducing. So the question arises that how does the cascade of BMP signaling initiate when the ligands are a limiting factor? To answer this, we moved our attention to the infrapatellar fat pad at the joint site, or the Hoff's pad. So now in an obese individual, you have the adipose tissue which gets infiltrated by macrophages, and they get polarized to the pro-inflammatory type, which in turn drive the healthy articular cartilage to an osteoarthritic one. Now, according to the literature, it's the cytokines secreted by the macrophages which trigger this cascade. But we already have NSAIDs available which act as an anti-inflammatory, which prevent this. But still what we have does not stop the progression of osteoarthritis. So we question, how do macrophages influence it? What we found is that by 4 weeks, the abundance of macrophage polarization to pro-inflammatory type has increased. Finally, which leads us to understand that it's the inflammatory macrophages which came in first, which triggered the cascade of the transition of a healthy articular cartilage to a hypertrophic one. This leads us to the question that is the BMP signaling involved in the crosstalk between the macrophage and the articular cartilage? For this, we isolated the bone marrow stromal cells from the wild type mice, derived them to the fate of macrophages, and polarized them to the pro-inflammatory macrophages. These macrophages were treated with PBS or saline as a control, or with LDN, which is an inhibitor of BMP signaling, as the test. We further performed the qPCR, wherein we understood that the IL-1 beta, which marks the pro-inflammatory cytokine, which is a pro-inflammatory cytokine, by 12 hours had gradually reduced, while arginase had significantly increased by 12 hours, and the BMP ligands had gone down. Further, we validated these results by staining for the macrophage and the pro-inflammatory cytokine, pro-inflammatory macrophage marker, and there we saw that by 6 hours, indeed there is reduction in the redness, while by 12 hours, again, even the phenotype of the macrophages have changed. So we concluded that in a healthy joint, we have abundance of anti-inflammatory macrophages. Because of obesity, the adipose tissue gets infiltrated by pro-inflammatory macrophages, leading to the transition of the articular cartilage, healthy chondrocytes, to an osteoarthritic one. And if we target it with the inhibitor of BMP, that reduces the pro-inflammatory marker. Thank you.
Again, excellent presentation. Just few queries. First of all, did you look for the markers of senescence also in your model?
No, we have not looked at
Telomerase activity was not seen.
No.
Okay, that is one thing. Did you look for the other pro-inflammatory signaling molecules like TNF alpha,
Yes.
interleukin 1 beta?
So we have looked at TNF alpha, interleukin 1 beta, IL-6, the others that we could. One of the representative one I have shown here, and all of them go down by 12 hours. And simultaneously, even for the anti-inflammatory markers, apart from arginase, we did check for one or two more, and even there we found the
Where
consistency.
did you narrow down to BMP2 pathway?
So BMP2, like my professor mentioned, it's common.
Can you use the mic, please? Mic.
So BMP2, we already know that the articular chondrocyte transition to a hypertrophic one, and the BMP signaling plays a major role. If by targeting that, by targeting BMP signaling, we could also challenge the polarization of macrophage and shift it to an anti-inflammatory type, that would be using one drug targeting two cell type, and that will lead to better results.
And the next question is that how do you correlate between the infrapatellar fat macrophages there and the osteoarthritis happening in the joint, because fat is outside the joint?
Through literature we have found out that the macrophages, the adipose tissue has resident macrophages. Those initially, because of the microenvironment, are either are towards the anti-inflammatory type, and in presence of the stress, they move to the shift to the pro-inflammatory state. Now these macrophages have a tendency to release their contents out, which possibly could move to the synovial fluid, which bathes the articular cartilage, thus bringing in the ligands.
Any questions from the audience? Very interesting paper. Anybody? Okay. Thank you, Dr. Sahiba.
Now third paper. Third paper will be trial on non-pharmacological therapeutic. It is the comparative efficacy between conventional versus pulse radiofrequency ablation in glenohumeral osteoarthritis. It will be presented by Dr. Shubhamo Datta from PMR IPGMR.
My topic is comparative efficacy between conventional versus pulse radiofrequency ablation in glenohumeral osteoarthritis. Introduction. Glenohumeral osteoarthritis is one of the common clinical diseases in elderly age group attend in PMR OPD. 16 to 20% adult older than 60 years of age have radiological evidence of GHOA. Women have increased prevalence of GHOA than men for the same age. Clinical features: sustained activity-related pain felt deep in the joint and joint line tenderness, crepitus and pain during joint movement, reduced range of motion, especially external rotation. Management option: various management options available. Conservative management, surgical management, and non-surgical management. Conservative management: rest, analgesic, diacetyl glucosamine, physical therapy, ultrasonic therapy, and TENS, transcutaneous electrical nerve stimulation. And surgical management is there also: arthroscopic debridement, arthroscopic capsular release, and hemiarthroplasty or total shoulder replacement. But there is limitation in the surgical management. Post-operative recovery often prolonged, requires intense physical therapy, not fit for surgery due to comorbidities. Non-surgical intervention is a great role. Radiofrequency ablation is effective time-saving technique with satisfactory result in controlling chronic shoulder pain, particularly targeting suprascapular nerve due to extensive nerve supply to shoulder and articular branches of axillary nerve. Minimally invasive procedure when compared with surgical option, but lack of data regarding this procedure in Indian context. This is my some review literature. Pulse radiofrequency ablation on suprascapular nerve for chronic shoulder pain give good and effective result. There is lack of literature in conventional radiofrequency ablation of suprascapular nerve. My humble attempt to comparison between conventional RFA and pulse RFA. Objective: to assess the improvement in pain and disability in visual analog scale and shoulder pain and disability index with conventional and pulse RFA to compare the improvement in both groups. Methodology: study design, parallel group, open label, randomized control trial, study duration 8 months, July 2024 to February 2025. Place of study: our department in PMR department in IPGMR and CSKM hospital. Study population: patient attending OPD and IPD in department of PMR. Sample size 22, 11 in each group. Inclusion criteria: vast more than 5. Clinically radiological confirmed case of glenohumeral osteoarthritis. Duration: pain at least 3 months and more. refused to surgery, patient between age 40 to 80 years, and vast more than 50% pain reduction after diagnostic block. Exclusion criteria, secondary cases, inflammatory infective cases, pregnancy, hemodynamically unstable, ICU admitted patient, recent trauma, fever, new onset neurological deficit, malignancy, fracture, RFA contraindication like pacemaker, coagulopathy, etc., non-cooperative patient. And shoulder pain due to other cause like adhesive capsulitis, bursitis, capsular tear, rotator cuff tear. Methodology, parameter হচ্ছে VAS and SPADI, follow up 4, 8 and 12 weeks. This is consort followed diagram. Ethical committee clearance taken, approval taken, and informed consent from patient. 11 in each group, or 2 lost follow-up, and analysis in 20 patient in each group, in 10 in each group, and for a total 20 patients. Study tools, sterile OT, USG machine, epidural needle 20 gauge, RFA machine, sponge holding forceps, and RFA probe with cannula, 100 mm with 5 mm active tip. And other needs sponge holding forceps, sterile gloves, spirit, bandage, syringe, or lignocaine or bupivacaine. Methodology, suprascapular nerve block in pulse RFA at suprascapular notch, and suprascapular nerve blocks in conventional RFA, that is at spinoglenoid notch after giving branch to supraspinatus muscle, avoidance of supraspinatus muscle weakness. And procedure under USG guidance, 20 G RF cannula with 100 mm length and 5 mm active tip, placed in appropriate position similar to diagnostic block, sensory and motor stimulation testing done. On sensory stimulation, pain produced around the shoulder joint, the same distribution, while the motor stimulation negative. After obtaining proper sensory and motor stimulation, conventional RFA, RF thermocoagulation performed at 80 degrees centigrade at 90 seconds. On the other hand, pulse RFA performed 42 degrees centigrade at 120 seconds. Sterile dressing applied after injection site. This is a procedure video from procedure. And result analysis. Result analysis is an age distribution of study, 40 to 50 years. More patient is available in our OPD. Then 50 to 60 years of age. Result analysis, no statistical significance difference in 4 to 8 weeks, but statistically significant difference between conventional and pulse RFA for 12 weeks. This is a SPADI, shoulder pain and disability index. Then we analysis another scale. This is VAS scale. There is also no significant difference between 4 to 8 weeks, but statistically significant pain reduction in 12 weeks. Discussion, patient receiving conventional and pulse RFA group showed reduction in pain and shoulder pain disability, but patient receiving conventional RFA group showed statistically significant decrease in pain and shoulder pain and disability and for longer duration. Conventional RFA suitable for chronic condition and prolonged pain relief. Pulse RFA suitable for nerve sensitivity and gives shorter duration of pain relief. Conclusion, conventional RFA effective for long duration than pulse RFA in pain and disability reduction in patient with glenohumeral osteoarthritis management, but further study with more sample population and longer observational period are needed to better determine effectiveness. This limitation, small size sample, very short study period, and single center study design. This is my bibliography and acknowledgement. Thank you.
So please repeat the 2 takeaway points from this. Which one of the 2 is better, and is there a mechanistic reason why one is better than the other? And if there is a difference, is it really significant enough for glenohumeral OA to be treated with one or the other?
Pulse and conventional 2 are equally effective, but for longer duration, conventional RFA is more effective.
What statistical tool have you applied to say that at 12 weeks conventional radiofrequency ablation is better than the pulse?
Pain reduction, VAS and SPADI scale.
No, what statistical analysis have you done? Because only 10 subjects in each group. I don't think it will be statistically significant anyway. And other query was, how did you actually rule out patients with adhesive capsulitis? Were all these subjects subjected to MRI?
MRI and radiologically differentiated from
And how common is it to see glenohumeral osteoarthritis actually?
radiologically.
Yeah, no, clinically, how?
Clinically, joint crepitation and restriction of movement, especially external rotation.
As a clinician, I'll tell you, we see generally patients of glenohumeral osteoarthritis if there is some secondary cause to it, rather than as a primary glenohumeral osteoarthritis. I'm surprised you got 20 patients for your study. Maybe, but in this part it may happen, but for me this is some kind of a news. I will more think in terms of adhesive capsulitis. See, this is a clinical paper, so I think there must be some questions from the audience. Manvi, you have to ask any question?
This is in a short-term study. This is
Small sample size. Okay, there are no queries, then thank you very much. Interesting concept, I must say. Thank you.
Again, we are back into basic science. This will be exploring the regenerative plasticity of articular chondrocytes in osteoarthritis, a response to mechanical restoration of the knee joint. It will be presented by Shaheda Foujia Iqbal from IIT Kanpur.
So today there has been a very fascinating debate about there is little to expect about physical therapy in osteoarthritis. So let's see what the chondrocytes feel about it. Hello everyone, my name is Foujia Iqbal and I will be presenting about the regenerative plasticity of articular chondrocytes in using immobilization based mice model. So let me quickly take you to the developmental basis of articular cartilage. Initially, there is a cartilage analoga. Is there a pointer? Initially, there is a cartilage analoga. And so, in 2015, Professor Bandyopadhyay gave a model that, which one? So he gave a model in 2015 that the same pool of proliferating cells can develop into transient cartilage and articular cartilage depending upon the signaling pathway they experience. So the one which experience BMP signaling pathway becomes transient cartilage which will make bone, and the one which experience Wnt signaling pathway creates articular cartilage. So then they go on further to follow up this study, and in another study they found that the restriction of mechanical movement of joint causes perturbation of BMP signaling, and the immobilization of the knee joint causes embryonic articular cartilage to become the transient cartilage. In adult subjects, we know that immobilization of the knee joint causes osteophyte formation. So when a healthy knee joint is fractured, so clinicians tie up the joints and there is immobilization of the joints, which causes osteoarthritic-like phenotype. And we know that this remobilization of the joint, when the cast is removed, then this causes the recovery of the knee joint cartilage. So I decided to utilize the immobilization-based mice model for exploring the regenerative capacity of the articular chondrocytes. So first, what we did, we used a custom inbuilt cast, which was titanium coated, to immobilize the mice at for different time points. So first we immobilized them at postnatal day 70 and harvested them and analyzed them for different time points. We found there was upregulation of PMP signaling pathway, which has been shown by the phosphosmad 159 here. You can observe that at post-immobilization day 14, there has been a significant upregulation of the phosphosmad 159, which is associated with the coltan upregulation. So coltan is a marker of a hypertrophic cartilage. So next we ask the question that yes, whether the restoration of the joint movement reverses this osteoarthritis-like changes that appear after joint immobilization. So what is the status of the molecular markers? We see that as compared to the control, in case of post-immobilization day 28, there is a significant upregulation of coltan, the hypertrophic cartilage marker, which is restored upon the remobilization of the joint. And with the col2, which is a native healthy articular cartilage marker, as compared to control, it decreases on the immobilization and again reverses back after the remobilization. So next, we also checked the vascularization changes, as we know that the articular cartilage is avascular in nature. So the red intensity shows you the intensity of the vascularization. So you see that after immobilization, there is a heavy vascularization happen, which gets restored after the remobilization of the knee joint. So how does this joint remobilization restore the articular cartilage? What is the mechanism behind it? So there can be two possible ways by this is happening. First is that the coltan expressing hypertrophic chondrocytes either dedifferentiate and revert their fate to the col2 expressing chondrocytes. Next is that either the cells residing at the surface of articular cartilage proliferate and become col2 positive cells. So we set out to explore the status of the newly born cells. So it is known in the literature that the cells, articular chondrocytes, proliferate when there is a post-traumatic event. There is a either ACLT-induced or immobilization-induced osteoarthritis. So we wanted to explore the status of these newly born cells. What we did that we immobilized the mice at P70 and then we injected PRDU. PRDU is a thymidine analog which gives us the idea that DNA synthesis has taken place. So the proliferation will have a new chain of the DNA synthesis. Then we allotted the mice into two groups. One was in immobilization group and one is the remobilized group, where the mice were immobilized and then they were remobilized for another 28 days. So we found that the newly born cells were expressing native articular cartilage marker post-remobilization, whereas they were depleted of the coltan marker. The newly born cells are marked by the PRDU. So we went ahead and also looked for another proliferation marker, which is Ki67. So we found as compared to the control where there is no immobilization, the immobilized mice knee joints has Ki67 positive. So Ki67 is a proliferation marker. And then we thought that as the immobilized joint mostly has the hypertrophic chondrocytes, but in literature hypertrophic chondrocytes are known to be non-proliferative. So whether they are expressing Ki67 or not, so we did the dual staining and we found surprisingly that the Ki67, the hypertrophic chondrocytes express Ki67, whereas compared to control, you see very less or negligible Ki67 positive chondrocytes. So next I tried to see that whether these hypertrophic chondrocytes also show plasticity. So surprisingly, I found these two articles where they have shown where they have shown in zebrafish and in a fracture healing case that yes, hypertrophic chondrocytes incorporate BRDU as well as they express, they incorporate BRDU as well as they express the dedifferentiation markers. So what I did that I also chased the same experiment that I tried to incorporate BRDU and looked at whether the hypertrophic chondrocytes express BRDU.
Can you please finish it off quickly?
Yeah, fine. Fast. So we found that yes, the hypertrophic chondrocytes also express dedifferentiation markers, TANOC, OCT3, which can be further utilized to direct the cells towards the native articular cartilage fate. So my conclusion is that immobilization of knee joint causes upregulation of BMP signaling, which finally leads to osteoarthritis-like phenotype. Restoration of the physical movement restores the microenvironment, hence leading to reversal of osteoarthritis. Expression of native articular cartilage, collagen type 2 by the newly born cells. And contrary to the existing narrative, hypertrophic chondrocytes incorporate BRDU, indicating re-entry of hypertrophic chondrocytes into the cell cycle. And last is that hypertrophic chondrocytes do express the stem cell-like features, such as expression of the Yamanaka factors, OCT4 and NANOG. Yes, finally, articular cartilage has an inherent ability to repair itself, provided a favorable microenvironment must be restored.
Thank
Thank
you.
you.
Very interesting mechanistic study, and she gives a concrete sort of evidence for Dr. Das' suggestion during the debate that exercise has a role to play in osteoarthritis. So, but there are few questions that I would like to ask you. Again, did you look for the markers of senescence? That is one. Telomerase activity, you didn't actually. And it's very surprising because when you see a hypertrophic chondrocyte, that means this is a senescent chondrocyte. And by definition, senescence does not allow proliferation of a cell because cell is arrested in the cell cycle. How do you explain that incorporation of BRDU? Use the mic, please. Mic, please.
So it has been believed that all the hypertrophic chondrocytes move towards the apoptotic program and they die, or either they become the osteoblast. But there have been literature that the hypertrophic chondrocytes of the articular cartilage have different fates. Some of them die by apoptosis. There have been people have done tunnel positive stainings for it. So some are certain that they become osteoblast whenever a joint becomes osteoarthritic. So this is a plasticity. What I feel that this plasticity of hypertrophic chondrocytes can lead it to different fates, depending on what environment you are providing. If I am, suppose I am doing remobilization, so I am providing a favorable environment. It's the reversal of the molecular markers. So then it can direct into a call to
very
expressing
surprising
cells.
and very sort of new, novel kind of results which we are not sort of tuned to accept actually right now. But anyway, you are showing the evidence, so we have to accept that. Not debating about that part. Which Yamanaka factors did you study?
So I have checked for OCT4 and NANOG.
No, NANOG is not a Yamanaka factors. Yamanaka factors were 4 actually.
So
CMYC,
it is
KLF4.
KLF4, OCT4. So I have also SOX2.
SOX2.
I have also checked for SOX2.
Okay.
Yeah.
So the debate is open, or the paper is open for any comment, question. Yes, Danvir.
Congratulations, very well conceptualized study. Actually, you have stabilized the joint, and then you have seen that there is increased vascularity. That is something after the fracture you usually see with as a CRPS. So you said that there is increased vascularization. Vascularization in the cartilage or somewhere that is in the
So it is the vascularization in the cartilage.
So it is avascular structure. How can it get vascularity? I don't know.
So yeah, it says avascular structure, but when we talk about the cellular basis, when the cartilage becomes hypertrophic, so these hypertrophic cells secrete the VEGF factors. They attract the blood vessels, and in an osteoarthritic condition, it becomes vascular.
Okay, thank you.
The last paper will be an open label randomized control trial, efficacy and safety of intraarticular triamcinolone versus subcutaneous adalimumab in inflammatory OA. And it will be presented by Dr. Isarul, third year DM resident, Department of Clinical Immunology and Rheumatology, IPGM here.
Good afternoon all. So I'll be presenting my DM thesis which we have recently concluded. So we just wanted to compare these two drugs, one of which is recommended. So basically it's a RCT open label comparing efficacy and safety of intra-articular triamcinolone versus subcutaneous injection adalimumab in a particular subset of patients, that is inflammatory OA. So it's basically a phase 3 open label trial having two groups. The first group A is adalimumab. So the group OA, in the first group, we have adalimumab 40 milligram. We are giving subcutaneously 4 weekly for 3 doses, that is monthly for 3 doses. And another arm we are giving intra-articular corticosteroid, and the compound we had used was triamcinolone acetonide. And we got ethical approval when we registered the trial before recruiting the patient. So it was basically a prospective trial. And inclusion criteria, basically the patient satisfying the ACR classification criteria, having a minimum disease duration of 6 months in the age group of 40 to 7 years and KL severity of 2nd and 3rd grade, evidence of inflammation, and having persistent knee pain, that is a VAS score of 4 out of 10 in spite of the baseline therapy, and on stable baseline therapy for at least 3 months. And in baseline we had allowed paracetamol, topical NSAIDs, duloxetine, pregabalin, gabapentin, and amitriptyline. Now coming to the important and the inflammatory phenotype we had defined by presence of 2 of 3, basically presence of effusion, raised CRP or ESR, and findings of synovitis and effusion in the contrast MRI. So important exclusion criteria, we wanted to rule out the known secondary causes of osteoarthritis, having severe significant trauma to the knee, high titer RF or anti-CCP, history of surgery or arthroscopy, history of tuberculosis or positive Mantoux test, raised liver enzymes, and triple serology positivity basically. So there are 2-3 objectives. One was that evaluate the efficacy and safety of intra-articular triamcinolone in inflammatory OA. Similarly, compare the efficacy and safety of monthly adalimumab for decreasing the pain and stiffness and improving the patient global assessment of the disease, and to compare the efficacy and safety of adalimumab versus triamcinolone in this particular phenotype of osteoarthritis. So basically for that we had taken outcomes. So primary outcome was the improvement in OMAC pain score in the 0 to 100 scale at 12 weeks, and we had multiple secondary outcomes, that is change in OMAC pain score at 4 and 6 weeks, and change in patient global assessment at 6 and 12 weeks, and change in basically OMAC stiffness and functions of subscales at 6 to 12 weeks, and then percentage of patients achieving a ORC OMRECT response at 12 weeks. So now coming to the results, so we screened 148 patients. Out of that we had 80 eligible patients in which were randomized to the 2 groups. The first group getting adalimumab 40 milligram 4 weekly for 3 doses, in which we have 37. And the second arm was getting a single dose of intra-articular triamcinolone in the worst knee, and that group has also 37 patients were recruited. So coming to the baseline characteristics, we can see the baseline characteristic between the 2 groups, that is group A and B, were mostly comparable. The age, the sex, the KL severity, the disease duration. Now coming to the early morning stiffness, ESR, CRP, presence of knee effusion, and the use of baseline medication were mostly comparable. So now coming to the primary outcome, what we found is that in both the groups there was significant improvement in pain at both 4, 6 and 12 weeks, and at 4 and 6 weeks the triamcinolone group performed significantly better as compared to the adalimumab group. However, in the adalimumab group basically performed numerically better as compared to the intra-articular group at 12 weeks, but it did not reach a statistical significance. this graph just summarizes my finding. This one, the upper line is basically adalimumab, in which you can see it's a decline from the baseline to the 12 weeks, while in the injection group, intra-articular injection group, it is decreased in 4 weeks, then it starts rising up. Similarly, in the OMAC function, the intra-articular corticosteroid group had performed significantly better as compared to the adalimumab group at 6 weeks, while the adalimumab group was numerically better at 12 weeks. In coming to the stiffness also we had similar finding, in which the intra-articular group basically performed significantly better as compared to the adalimumab group, but again at 12 weeks the similar findings are that adalimumab was numerically better as compared to the intra-articular corticosteroid group. And in the patient global assessment, the intra-articular corticosteroid performed significantly better as compared to the adalimumab group at the 4 and 6 weeks. However, at 12 weeks, no significant difference was present between the two groups. But the improvement in both the groups, the intra-group improvement was significant in both the groups at all points of assessment, that is 4, 6 and 12 weeks. And coming to the high improvement, which is defined by ORC as 50% reduction from the baseline in either pain or function, plus 20 mm improvement in the VAS in both these domains. So we can see that only very few patients, particularly in the adalimumab group, could achieve high improvement criteria, while in the intra-articular corticosteroid group, 27% of the patient improved high improvement criteria. Now, in all the patients who could not meet the high improvement criteria, we tested for moderate improvement as per the definition of ORC, and we found that in the adalimumab group, more patients had no moderate response, that is 79.4% as compared to the intra-articular corticosteroid group. Now, we did multiple regression analysis also, so we found that a higher X-ray severity had increased odds of non-response to the therapy. Both of the therapy, basically ESR, disease duration, BMI and CRP did not show any significant association with non-response. However, fibromyalgia showed a trend towards significance of non-response in both the groups with the odds ratio of 3.86. Now, just to summarize the previous adalimumab trials in the knee osteoarthritis, our results are very much similar to the open label study that was conducted in 2012, in which 70% of the patients had good response, that is ORC response. In our study, we could found that 87.5% of the patient had met the response criteria. And currently ongoing study is there, which the results, partial results are published, in which they have showed that adalimumab did not perform better as compared to the placebo. So to conclude, the triamcinolone provides rapid short-term symptomatic relief in inflammatory OA knee, while adalimumab shows gradual but sustained efficacy, achieving superior pain reduction that is only numerically superior, not statistically significant. And both treatments were well tolerated. In three patients of IACS group, I had seen increased pain post-procedure, and in adalimumab group, I encountered 3 infections that were minor infections. But in future trials should include placebo to control, imaging endpoints, and extended follow-up. So these are my references, and big acknowledgement to my department for providing all resources. Thank you.
Very excellent presentation and clinical paper for the audience, because we are all clinicians, so we are interested in something where we can change our treatment policy. So I'll start from the audience. If there are any questions from the audience? Okay, so none. Okay, I'll ask then. First of all, did you face any problem in getting the ethical approval for your study?
Sir, I was called once for the documentation and discussion of my trial, but no, as such, no questions were raised, significant questions.
Okay. Number 2, you didn't show any data on the adverse effects in your study.
Yes, sir, because of the paucity of time, but I
No,
just
these are very important actually. When you are comparing 2 treatment arms, one is interested in safety, but more than that, we are more interested in adverse effects also.
Sir, I just, in last slide, I have shown that important that I could found, sir, this one, that in 3 patients of IACS, they had reported increased pain and post-procedure, and in 3 patients in adalimumab arm basically had minor infections which were treated with antibiotics, basically, oral antibiotics.
So my question is that, okay, once we have treated patient with adalimumab, or we have planned this patient to be recruited to the adalimumab arm, what was the sort of pre-treatment policy in evaluating these patients? Were these patients given prophylaxis for tuberculosis? Were they screened for?
Sir, my inclusion criteria includes negative screening test. If they are tested positive, they are excluded. If the patient is positive for, because we are test for, in the inclusion criteria, it only includes if patient is MON2 negative, then only will recruit the patient.
For
Otherwise,
only
they will-
MAN2?
Yes.
No IGRA?
Sir, because patients are not able to afford and our center doesn't have.
No, because then there is a debate actually whether we should be doing both or IGRA.
Yes, sir. Ideally, both should be done. I think that is more.
So I'll caution everyone that please, if you embark on such a treatment, no doubt you have shown the result, but the results are similar and that we expect also. Glucocorticoids will have a immediate effect as compared to the adalimumab or any other molecular therapy, whatever we will give. But then we have to be very, very cautious in evaluating such patients and putting them into a trial. Because what happens after 3 months, once you have stopped giving them injections, then what is?
Sir, they are under still follow, but they are not officially part of the trial because the outcome was ideally had I more time, I would have followed 12 weeks more because it's always better to follow up. In most of the trials, they are following the patients for at least 10 to 12 weeks after stopping the trial. So that would have been safer, but they are still under follow-up, but not as stringent as the trial itself.
Because those kind of data is also very
Yes, sir.
important. What is the follow-up? What is happening to these patients?
Yes, sir. I totally agree, sir.
Okay. So any last chance for audience to ask any question regarding this presentation?
So I have a comment. It may make sense for you to then follow up the patients at 1 year stage, whether or not they complete the full treatment, but whether there was a difference in the structural, say the MRI or some such quantifiable aspect to treatment, say
Sir,
2 years down the line.
Sir, one important part of the trial, we tried to include MRI at baseline, which we have done in most of the patient if the patient has not refused, and then do a follow-up study 6 months down the line. But to be honest, I don't have that much time as part of DM thesis. That otherwise it is a must. You have to document multiple domains of improvement. It is clinical improvement, then it should be supported by probably radiological also. That gives you more. And then I also discussed that we should have placebo arm also, because if you are using such costly therapy, you have to show that there had a no placebo effect, right? I think so.
Okay. Thank you. Thank you very much.
There will be another paper. It will be presented by Dr. Basit. Association of OA knee and hands with metabolic syndrome. I am inviting Dr. Basit to present.
Respected chairpersons, faculty members, myself Dr. Basit Masood is here to present my paper on association of osteoarthritis knee and hand with metabolic syndrome under the guidance of Dr. Shweta Agarwal ma'am and Dr. Vishal Parmar sir. Introduction. Osteoarthritis is the most common form of arthritis characterized by progressive degeneration of joint cartilage and subchondral bone, leading to pain, stiffness, swelling, and reduced mobility. It most frequently affects the knees, hips, hands, and spine, severely impacting the quality of life and functional independence, especially in the elderly. Metabolic syndrome is a constellation of interconnected metabolic risk factors, including central obesity, hypertension, hyperglycemia, elevated triglycerides, and low HDL cholesterol associated with insulin resistance and systemic inflammation. Now, if we take the NCP ATP3 classification, it specifically mentions that the abdominal girth or circumference for male should be more than 102 centimeters, and for females it should be more than 88 centimeters. Hypertension, the systolic blood pressure should be more than 130 and diastolic blood pressure should be more than 85. Hyperglycemia, there should be a fasting glucose levels more than of 100 milligram per deciliters, and triglyceride levels should be more than 150 mg per deciliters. For HDL in males it should be more than 50 and in females it should be more than 40. Both OA and metabolic syndromes are increasingly prevalent due to aging populations, sedentary lifestyles, and rising obesity rates. Understanding their potential link may aid in early diagnosis, preventive strategies, and the development of comprehensive therapeutic approaches that target both joint and metabolic health. The primary objectives of this study were to assess the association between OA, knee and hand, and metabolic syndrome. The secondary objectives are to evaluate the influence of individual metabolic syndrome components on osteoarthritis and to explore different osteoarthritis knee and hand profiles. The study design is mainly a cross-sectional and observational study with 108 participants, and the location is Integral Institute of Medical Sciences, Lucknow. OA assessment is mainly based on clinical plus Lagrange-Lorentz grading, and METS definition is based on NCP 83rd classification that I have mentioned previously. And more than or equal to 3 of 5 criteria are essential for diagnosis of metabolic syndrome. Analysis statistical correlation between OA sites and METS parameters. Participants profile, total 108 participants are taken till now for the studies, of which 68% of the population have been found to be knee osteoarthritis, 28% of the patients have found to be on osteoarthritis hand, and 4% of the patients have found to be both osteoarthritis knee and osteoarthritis hand. All the participants have completed full assessment. Now this is the distribution of OA types among my participants, of which 68% have been of knee osteoarthritis, 28% have been of the hand osteoarthritis, and 4% of the participants have both knee and hand osteoarthritis. Now the key results from the study that I have found are metabolic syndrome is generally more prevalent in knee osteoarthritis group. Central obesity is significantly associated with osteoarthritis of knee, while hand osteoarthritis is associated with hypertension and dyslipidemia. Higher radiological grades have been observed in METS positive individuals. Now this is the metabolic syndrome components in OA. As you can see, central obesity, the patients who are obese have more prevalence of knee osteoarthritis as compared to hand osteoarthritis. And the patients who have hypertension as a metabolic component have incidence of more osteoarthritis hand as compared to osteoarthritis knee. And also the triglyceride levels have found to be more increased in patients of osteoarthritis hand as compared to osteoarthritis knee. Discussion. Our findings reinforce the growing hypothesis that osteoarthritis, particularly of the knee, is not solely a biochemical disorder but also influenced by systemic metabolic disturbances. The significant association observed between metabolic syndrome and osteoarthritis highlights the role of metabolic inflammation as a key contributor to the joint degradation. Central obesity as a major driver of metabolic syndrome leads to the secretion of pro-inflammatory adenokines such as leptin resistance and TNF-alpha, which may stimulate the cartilage breakdown and subchondral bone remodeling. The fact that OA correlated more strongly with central obesity supports the theory that adipose tissue plays a pathogenic role. On the other hand, the association of osteoarthritis with hypertension and elevated triglycerides suggests that vascular dysfunction and lipid-mediated inflammatory responses might also contribute to joint pathology, even in non-weight-bearing joints. This metabolic joint axis reflects a systemic disease model of osteoarthritis, calling for a multidisciplinary approach in patients' care. Instead of focusing only on pain management and joint preservation, clinicians should screen and manage metabolic risk factors in OA patients to slow progression and improve overall outcomes. These findings have paved the way for integrated treatment strategies involving lifestyle modifications, weight reduction, dietary changes, and pharmacological controls of metabolic syndrome components, along with conventional OA therapies. Conclusion and strong takeaway home messages are: a strong association exists between metabolic syndrome and osteoarthritis, especially knee osteoarthritis. Metabolic syndrome components like central obesity, hypertension, and dyslipidemia are influential in pathogenesis and progression of osteoarthritis. A comprehensive treatment approach targeting metabolic health may improve osteoarthritis outcome. Thank you.
Okay, thank you, Dr. Basit. Any comments or questions from the audience? It's a very clinical paper. It's well known that there is an association between the metabolic syndrome and the osteoarthritis. So my question is, how did you assess what were the inclusion criteria for hand osteoarthritis? You mentioned Kellgren-Lawrence, that is for the knee basically.
Sir, inclusion criteria was basically radiographic evidence, and along with blood investigations such as lipid profile of the patient, HbA1c
No,
of
that
the
is a
patient.
different thing. I'm just asking the hand OA, how did you, so when you say hand OA, which all joints did you look at?
Sir, mainly DIP and PIP.
So PIP doesn't cause osteoarthritis, doesn't have osteoarthritis generally. Because the commonest
Sir,
one is the first
CMC and DIP.
Okay.
Yes,
Okay. And did you look for any subset association between grade of severity, grade 2 versus grade 3 or grade 4? Was there any difference in the association?
Yes, sir. The patients with components of metabolic syndrome were found to be radiographically, they were found to be in grade 3 or grade 4 according to Kellgren-Lawrence classification.
Yeah, but you didn't show that data actually.
Sir, I have mentioned it.
Okay, okay. Okay, if there are no more questions from the audience, then I thank Dr. Basit for his presentation. Thank you.
Thank you, sir.
Now I am concluding the session. Thank you, delegates. Thank you, Vikas sir. Thank you, Dr. Shunik sir. Yes.
So after the platform presentation, we are moving on to the last session of the day and the conference. That will be the quiz.
So at the fag end of the gala program, we are now having the quiz, rheumatology quiz. We had initially 21 teams from different medical colleges, and we selected 5 teams for the final. So now it would be the final round. With me is Dr. Selim Mondol, who is helping me with the quiz, and Dr. Shashwat and Dr. Tej Shubro. So Dr. Shashwat and Dr. Tej Shubro are DMPDTs in our department, and Dr. Selim is SR Rheumatology, IPGMER, and myself, Dr. Sena Mohapatra. স্ক্রিনটা একটু অফ রাখুন। হ্যাঁ, দিয়ে দিন। Okay, so welcome to the quiz. So rule for each round would be a little different. I hope you would enjoy, and we have some audience questions as well. So team A to team E. A. Okay, so please introduce yourselves. Hey, microphone. Please introduce.
Tomojit Desharkar, SSKM Hospital.
Polomi Banerjee from IPGMER and SSKM. Ahili Ghosh Dastidar from Apollo Multispecialty Hospitals.
Alok Datta from Apollo Hospitals.
Aliul Alam from CNMCH.
Anubhav Chakraborty from CNMCH.
Aminul Ashram from NRS Medical College.
Shubhajit Das from NRS Medical College.
Saptarshi Das from Arjikar MCH.
Mohit Srivastava from Arjikar MCH.
So we have 6 rounds altogether, and the last round would be rapid fire round. So this is round 1. There is bonus question. For direct answer, the marks is 10, no negative marking. Any team answering the bonus would get 5. We will start from team A, and it would go from team A, B, C, D, E. Okay? So question to team A. 29-year man, smoker, diabetic with this skin rash and arthritis for the last 2 years. What's the diagnosis?
Psoriatic arthritis.
Right answer, psoriatic arthritis. Team B. 16 years boy with knee pain and some swelling. There is an X-ray and clinical photograph. You can try, no negative.
Hemochromatosis.
No. Team C.
Juvenile idiopathic arthritis.
No. Team D.
Osgood Slater.
Right. That's the correct answer. So Team D gets a bonus. Osgood Slater. There is osteochondritis as you can see here. And here is the swelling. So direct question to Team C. 52-year gentleman admitted in nephrology ward with fatigue. Hemoglobin of 10, blood counts normal, urea 72, creatinine 2.1. What could be the diagnosis? It might be difficult with with scanty investigations and no serology, but then the possible diagnosis.
IgG4 related disease?
No. Team D. No negative, you can try. 10 seconds for bonus. Done? Team E.
Maybe hyperparathyroidism, hypercalcemia.
Why did you say so? Team A.
Wegener granulomatosis, GPA.
No. Team B. Audience. Sjogren's. I mean, you can never see a lacrimal gland like this. So direct question to team D. 28-year-old man, waiter in a hotel, having joint pains, no morning stiffness, hemoglobin of 13, ESR 23, RF 12, CCP negative, urate 7.8. The diagnosis. Look at X-ray and look at the clinical features.
Polyarticular gout.
No. Team E.
Osteoarthritis.
No. Team A.
Hemochromatosis.
No. Team B. Team C. Audience. Huh? ACD. Spondyloepiphyseal dysplasia. You can look at the platyspondyli, flat vertebra, and the short long bones are involved. And obviously there is no morning stiffness or anything arthritis. Team E. 23-year lady from Darjeeling presents with fever, polyarthritis and rash. Deteriorated in a couple of days with WBC count of 2800, CRP of 1.3, AST 67, ALT 56, creatinine 0.9 and a ferritin of 1200. What could be the disease?
This is scrub typhus induced HLH.
Right. This is scrub typhus induced HLH. So 10 marks to team E. That brings us to end of round 1. This was a special question because today, 6th of July, is World Zoonosis Day. And on this day, Louis Pasteur gave the historical vaccination day. And that's why it is celebrated all around the globe as World Zoonosis Day. So marks after round 1, bolo.
Team A at 10 marks, Team D at 5 marks, and Team E at 10 marks. B and C are yet to open the score.
Okay. On আছে? ঠিক আছে. Okay, so we move over to round 2. Bonus, yes, but there are negative marking. So direct question, correct, 10, negative -5. Bonus, +5 and -5. Time for answering direct question, 20 seconds. Bonus, stat. Team A. These are all sitter questions, very easy questions. What is the name of the clinical test or the disorder for which this test is called? The sign or the test?
fracture dinner for deformity?
No. Wrong answer. So -5. Bonus, team B. Team C. Team D. Team E.
Piano key sign.
Piano key sign. There is an arrow mark showing it. So +5 for team E. Team B, what is the name of the clinical test or the disorder for which the test is done? What is the test?
Trendelenburg's test.
That's right. +10. Team C, what is being tested? Heel raise. What is being tested? Team C.
Calf muscle hypertrophy or muscular dystrophy.
No, wrong answer. Team D, Team E, Team A, Team B. Audience? No, this is not Thomas. Tibialis posterior dysfunction. This is a common cause of leg pain, and this is the heel raise test. Team C. This is Team D.
Figure of foot test.
Hmm?
Figure of foot test.
For what? What is being done? The leg is Team E, Team A.
This is Faber test.
This is Faber test.
Faber test. For sacroiliitis, that is ankylosing spondylitis.
Not just ankylosing
No, I
spondylitis.
mean sacroiliitis, yeah.
Till whatever is required. So this is Faber test. So bonus marks to Team A. Team E. What is this test? Look at the hand position of the examiner. Team A, Team B.
Thoracic outlet obstruction.
Okay, I'll give. This is Adson test.
Adson's test.
So they have named the disorder. That's why I'm giving it. Name the disorder. So bonus to Team B. Audience question. What is the relation between these two? What is a boutonniere? This is a boutonniere. A small flower with the stem which is used to be on the lapel of the coat. And actually it is put through the lapel hole, and the position of the finger, it looks like a lapel hole. That's why it's called a boutonniere deformity. Okay, so that brings us to the end of round 2. Marks?
Team A at 10 points, Team B at 15 points, Team C -5, Team D 0, Team E 15.
Okay, thank you. We come to round 3. I'm sorry, this is wrong, is -5, not -10. So there would be direct question, +10, wrong answer, -5, bonus, +5, -5. Starting again with Team A. In DEXA scan of AP spine for osteoporosis, which vertebra are usually included? Which vertebra are usually included? If you have ever seen a report of a DEXA, you must have seen it.
Yes, spine.
Which vertebra? Like you have to say C1 to C9.
L3.
L3. Wrong answer. C, D, E. Okay. So this is L1 to L4. The L5 vertebra is excluded. Team B. 45-year diabetic man on insulin with arthritis. An ultrasound was done with a characteristic sign. What is the diagnosis? Okay, so team C. Team D.
Double contour sign, gout.
Right, double contour sign on USG, gout. So team D gets bonus marks, +5. Team D, direct question. Sorry, team C, direct question. What is this phenomenon or the test called? This is an historical picture and quite a historical test, a landmark test in immunology.
Empiripolysis.
Hmm?
Empiripolysis.
What is that?
Empiripolysis or
No. Team D?
I'd say Ellie cell phenomenon.
It's an Ellie cell phenomenon. So wrong answer to team C and +5 to team E. Team D, direct question. What is this imaging technique? Team D.
Dual energy CT.
Dual energy CT. DECT. What for is it done usually? Gout. So +10 to team D. What is this technique?
Nail fold capnography.
Okay. Done. So we have finished 3 rounds. This is an easy question for anybody, audience. Name the plant. Beautiful flowering plants around the Black Sea and the Mediterranean.
Colchicum autumnale.
Colchicum autumnale. Marks at the end of round 3.
At the end of round 3, team A at 5 points, team B at 15 points, team C at -10, team D at 15 points, and team E at 30 points.
ওরা ট্রাই করেনি। ওরা L3 বলেছে। হ্যাঁ। কিন্তু দেখা যাচ্ছে মার্কস মানে হঠাৎ করে একটা টিম অনেকটা উঠে যাচ্ছে আবার নেমে যাচ্ছে একদম লাইক দি স্নেক এন্ড ল্যাডার গেম ইন লুডো not consistently performer so now from the other way round team E would start so team E to team A round 4 bonus there would be direct question correct 10 no negative marking bonus question correct 5. These are clinical problems, maybe a little difficult, that's why no negative marking. You can give it a try. 36-year-old man presents with cough, increasing breathlessness for the last 1 month, and ulcers over the elbow and the knuckles. And there is a periorbital puffiness as you can see. No fever,
no joint swelling, no muscle weakness. What is the diagnosis? Five seconds more. Team D. Team C. No negative.
Sweet syndrome.
No. Team B.
ANCA vasculitis.
No. Team A.
Magic syndrome.
No. Audience.
MDA5.
MDA5 dermatomyositis. They have amyopathic dermatomyositis, and in fact, for that reason, sometimes it's said pulmonary and dermatological syndrome. Team D, direct question. 22-year-old man with bilateral hip and back pain for 3 months, difficulty in walking, and skin lesions like this. On physical examination, bilateral painful hip joints and stiffness were present. Tenderness was seen in hip joints and costochondral joints. What is the diagnosis?
Sappho.
Good. Sappho. Plus 10 for Team D. Do you know what sign is this? This is typical sign for Sappho. Doesn't matter. Anybody else?
Bullseye.
Bulls. Bull's head. Team C, direct question. 32 years lady, bilateral parotid gland enlargement, dry mouth and dry eyes, tingling both legs for 1 month, admitted with dyspnea. SSA, SSB negative, HIV ELISA positive. What is the diagnosis?
Deals.
Deals. Full name?
Diffuse lymphocytosis.
Okay, give them the marks because they have said deals. Team B. 28-year-old male complaining of leg pain recently. On examination, he is afebrile, no rash, no joint swelling, anemic. Chest and abdomen examination is almost normal. Hemoglobin of 9. Total count of 4,500, platelet 1.05 lakhs, creatinine 0.9, bilirubin 1.6, AST, ALT normal, ANA negative, LA ratio 1.1, ACL, GP1 normal. What is the diagnosis? Team B.
Fibrous dysplasia.
No. Team A. Fibrous dysplasia would have a long history and not much of pain.
Majid syndrome.
Team E.
Hemochromatosis.
No. Why should a hemochromatosis patient have? Okay. Team D. This was direct to Team B. And Team C. What are these? These are bone infarcts. This is bone infarct or bone and the bilirubin is a little raised. This is hemolytic anemia, most likely. I mean, these patients have most likely sickle cell with bone infarct. And it's an acute presentation. You might or might not have the spleen, either because of surgery or because of autosplenectomy. Team A, direct question. Evaluation of a 38-year-old man with arthritis of hands, feet and knees and loss of energy, fatigue and breathlessness. Hemoglobin of 15, blood counts normal, fasting sugar 160, creatinine 1, urate 6.3. What is the diagnosis? No negative, give it a try.
IgG4 disease.
okay.
Hemochromatosis.
Hemochromatosis. That's right. How did you say that? So these are the signs, and the liver, and the blood sugar, and the hemoglobin being normal. So there were ample signs in the history. So we completed this round. What is the relation? Or chimera. This is a mythical animal from Odyssey, and this is a chimeric molecule. Okay, so at the end of fourth round, the marks are
Team A at 10 points, Team B at 15 points, Team C at 0, Team D 25, and Team E 35.
Team E again. So again, negative marking, correct would be 10, negative would be minus 5. Bonus plus 5, minus 5. 9-year-old boy, unable to walk for the last few months. On palpation, there are hard areas under the skin, no joint pain. What is the diagnosis? Team E. Seen this patient 20 years back. Team D, Team C, Team B, Team A.
Juvenile dermatomyositis?
That's right, juvenile dermatomyositis. Team D, direct question. Young man with arthralgia and pain in ears. Past history of 2 episodes of painful red eye treated by an ophthalmologist. Diagnosis. Disease. Team C, relapsing polychondritis. So the patient is having scleritis recurrent along with cauliflower ear, signs of chondritis. Direct question to Team C. 14-year-old boy with knee effusion. Straightforward. Diagnosis. Are you answering? No answer. Team B.
Myelonodular synovitis.
Team A.
নেগেটিভ আছে
হ্যাঁ Team D, Team E, Team D. The likely diagnosis. This is audience hemophilia. So the intercondylar distance, and this is typical. Direct question to Team C. What is this? Wait, what is this sign? Team C. This and this. There are other areas as well. Team B. B, Team A, Team E, D, audience, whiskering. It's more than whiskering. Okay. That question to Team B. 28-year IT professional with generalized body aches came for a routine checkup. No history of thrombotic episodes, no history of stroke, anticardiolipin and GP1 negative, diagnosis of the skin lesion.
Levator reticularis.
Huh?
Levator reticularis.
No. Team A.
Libido racemosa.
হ্যাঁ হ্যাঁ এটা কাদের প্রশ্ন ছিল? ইয়েস ঠিক আছে, টিম এর অন্য একটা প্রশ্ন পরে দিয়ে দিচ্ছি, তোমরা খেয়াল করোনি। যাই হোক, audience, what could be the possibility? Or anybody amongst you? I say this is not libido. What is the closest differential of libido? In an IT professional working from home, erythema ab igne, which used to happen with people who are having living in cold weathers and putting fire in front of them. But this also happens with laptops being put on the lap because of the heat that is generated. Truly. So one question from them is waiting. ওটা আমরা পরে করি। This place is related to a key aspect of molecular medicine. Can anybody say what is the relation between the place? Yes, TAC, PCR. Where is the place? Where? Huh? No, sir. Arizona. Okay, so we move over to rapid fire round. এক মিনিট স্ক্রিনটা একটু অফ করুন তো, আমি ওটা আগে করে দিচ্ছি। হ্যাঁ, হ্যাঁ দিন। Team A, direct question. What is the lesion? This is a boy of osteogenesis imperfecta being treated. You can look at fractures over here. Team A, direct question. There is negative marking.
Sir, X-ray finding টা বলতে হবে। White line of wrinkle.
These are zebra lines, bisphosphonate therapy.
Zebra lines. This is zebra lines from bisphosphonate. So negative marks to team A and bonus 5 for team E. আরেকবার অফ করুন, তুমি মার্কস গুলো বলে দাও। আর একটা rapid fire.
Team A at 10 points, Team B at 10, Team C at 5, Team D at 25, and Team E at 40.
হ্যাঁ একটু প্লিজ, আমি শুনিনি, একবার বলো।
Team E leading with 40 points, followed by Team D at 25 points, both Team A and Team B at 10 points, and Team C at 5 points.
Okay. So the last round, rapid fire round, 1 minute time. Selim, time. 1 minute, 5 questions. The more number of questions you can answer. There is negative marks, so you get no bonus, obviously. Direct question 10, negative -5. So we shall start with team E. So your time starts now. Mechanism of methotrexate in rheumatoid arthritis is DHFR inhibition. True or false? True. Serum AC is not a sensitive test for sarcoidosis. True. Commonest disease to affect the first MTP is gout.
False.
Granuloma in renal biopsy is very characteristic of granulomatosis with polyangiitis or Wegener's disease. BIP is the most frequent site of joint involvement in established RA.
False.
So let's see the answers. You said this to be? They said it true. This is false. The mechanism is through adenosine pathway. So this is -5. Serum AC, they have correctly identified. Commonest disease to affect first MTP is gout. False, they have said. By the way, which is the commonest disease to affect the first MTP? Osteoarthritis. Good. And granuloma in renal biopsy is very, they have passed. So the answer is no. You don't find granuloma in kidney, you find granuloma in lung. This is crescent. And number 5, you answered correctly. So 3 correct answers, 1 wrong answer, 1 pass. Am I right? What's it? Team D, your time starts now. Etanercept is a soluble TNF alpha inhibitor. True or false? This is time bound. Pass. HLA is located on chromosome 6.
True.
Pseudo widening of SI joint is the earliest X-ray changes in ankylosing spondylitis.
True.
Non-erosive swan neck deformity and ulnar deviation are found in SLE.
Pass.
ANA is a good screening test for SLE. True. So let's see the answers. This you passed. So it's true. HLA you correctly identified on chromosome 6. Pseudo widening you said yes, which is not correct. Non-erosive swan neck deformity you passed. And AN is a specific test for SLE. You said true. Again wrong. Oh, sorry, that was sensitive. Good screening test. Huh. So that is correct. That is correct. That is correct. So you have 3 correct, 2 passed. 2 correct. 2 correct. Screening test they said yes. 2 correct and 1 wrong and 2 passed. Team C. Your time starts now. Chalk streak fractures occurs in Paget's.
False.
Trigeminal neuronopathy is the commonest neurological manifestation in MCTD.
False.
Amsler grid is better than OCT for HCQ toxicity screening.
False.
Rivaroxaban is a better drug for antiphospholipid syndrome with recurrent deep vein thrombosis. Recurrent.
False.
Gel phenomenon occurs in osteoarthritis.
True.
True. So This you didn't answer. Trigeminal neuropathy, correct. Amsler grade, false. Rivaroxaban, false. And gel phenomenon, true. So they are 4 correct. Four correct. Just a minute. Bolo, konta konta? 3, 4, 5 they have correctly done. 1 and 2 are wrong. Team B. Most common type of ILD in rheumatoid is NSIP. True or false?
False.
False. Acute anterior uveitis commonly occurs in oligoarticular GIA.
False.
Semaglutide can be used in osteoarthritis.
Pass.
Romosozumab is a rank ligand inhibitor.
False.
Yamaguchi criteria is used for Takayasu's disease.
False.
So this you identified wrongly. You said false. This is true. Sorry. You said false, and which is true? It's UIP. Acute anterior uveitis, you said false. Semaglutide, you said false. Pass, pass. And romosozumab, you said false and false. So 4 correct, 1 pass. Okay. Team A. Casper criteria is used in psoriatic arthritis.
True.
Bouchard's nodes in osteoarthritis involves DIP.
False.
Rheumatoid factor is typically IgG against Fc portion of the IgM.
False.
Tofacitinib acts by inhibiting interleukin 1.
False.
Patients with chronic liver disease has low C3.
True.
I think they have identified all correct. 5 correct. Finished? Bolo, marks, bolo. When we crack our fingers, why do they sound? Why do they make sound? That's the audience question. Bubble of what? Carbon dioxide. না টাই হয়েছে কিনা দেখে নি ওরা সবাই ভালো বলেছে
Team E, Arjigor Medical College leading with 65 points, and first runner-up is Team A, IPGMER with 60 points.
60. So no tie. That makes my job very simple. So thank you very much. It was a wonderful experience. Dr. Selim, please. Oh, okay. Okay, he has to leave. His train is at 6:30. So Dr. Selim, thank you very much. Can we hand over the prizes? আমি কি অলোকেন্দু স্যারকে ডেকে নিতে পারবো? Valedictory? Okay. Okay. So thank you very much.
Hello everyone. Now, Secretary Shwar, Dr. Kiran Seth, I request you to come to the stage. Chairman of Organizing Committee, Sarkan 2025, Professor Parasar Ghosh, I request you to come to the stage.
Animation করিনি.
Where is Parasar? Arey, Sasrat, where is Dr. Bharsha Ghosh? And I request Dr. Shamasis Das, Treasurer of Swarcon 2025, to come to the stage. Shamasis Das, yes. Thank you everyone for being with us, helping us, enlightening us. In the very beginning, I like to give the prize for platform presentation. Come. I shall request Professor Olokendu Ghosh to give the prize for platform presentation.
Platform presentation first prize goes to Saida.
Saida, please come to the stage.
Saida Fauzia Iqbal.
Next one. Sahiba Thaleswari. No, paper presentation. Second prize. It is second prize. Okay, please come. I request Dr. Israrul Haq to come for the third prize. Now, for the poster presentation, I shall request Dr. Sandeep Upadhyay, sir, please come and give the prize for poster winner in the poster presentation. First prize. Shushmita Hallar, please come to take the first prize in the poster section. Second is Shourabh Khanna. Anybody in the Institute of Saurabh Khanna to take on behalf of him? No. Okay, we shall keep it and send it. Third one? Achha, Kabbosri Sunil. Kabbosri Sunil, are you there? No. Okay then. Kabbosri Sunil is the first runner-up. I do not know which institute. Kabbosri? Which institute? You want to take on behalf of him? Her? Kabbosri. No, first runner-up. Second. No. No taker for Saurabh Khanna. Is there any? No. Thank you, sir. Sir, one second, sir. do you have anything to say regarding our conference? What should have been done? Constructive criticism? Sir, come here, sir.
Thank you very much for the great array of stars and people from all walks of science, both basic and clinical applied. So therefore, that's the uniqueness of osteoarthritis SORCON, where I wasn't expecting such detailed bench to bedside sort of transition, and there certainly seems to be so much happening. Work in IIT Kanpur, IIT Delhi, and indeed some translational work that sort of connects scientists in clinical medical fields in SGPGI, All India Institute, Indraprastha Apollo Hospitals, with the best technology centers in India. That's the major plus, that we were able to listen to this work that should certainly in maybe 5 or 10 years' time see treatment being finalized or being discovered. And the youngsters had so much of enthusiasm, and I'm sure that when clinicians go back, they'll also look at osteoarthritis from a very non-bland or a three-dimensional perspective. And thank you everyone for the hospitality, and wish you the best in the next session as well. Thank you.
Now I request Dr. Iwakera to come to the stage and give the prize for quiz and then make an announcement. Sir, announcement first or prize first? Prize first. Okay. Hey, quiz, prize. Quiz, who? Quiz, depend, quiz, who is? First from Arjigor Medical College. You come here to take the prize. First prize. Name? Hand mic ache to? Hand mic, hand mic, hand mic. Oh, somebody give the hand mic to them.
I am Dr. Mohit Srivastava from Arjigor Medical College.
Saptarshi Das from Arjigor Medical College and Hospital.
This is Sorkan. We are not miser. Second prize goes to IPJMER. Please come to the stage.
Dr. Tamujit Ishwarkar, IPGMR and SSKM Hospital.
I am Dr. Polomi Banerjee, IPGMR and SSKM.
No, sir. Okay, sir, please come. First, some constructive criticism of this conference, and then your announcement.
Well, it's very difficult to identify any fallacies. It's excellent, actually. We did the previous SORCONs, and this is the best. And he has raised the bar so much. Next time in Hyderabad, we find it very difficult, actually, to at least to be equal to him. So much of himself and his team Congratulations and all the best wishes to you. They went on very well. It's a sweet memories we are going home with so many memories. Can I invite our organizing secretaries, Dr. Shiv Shankar Challa and Dr. Dattu Kumar. So we as a team, and of course we have to announce, the dates have been announced, you know that. Professor Ghosh was mentioning whether July is correctly. July is a bit, monsoon season in Hyderabad. So we may change the dates. Please come onto the stage. Yeah, team of the Hyderabad. And we have, we will announce the due dates for the scientific committee, the registration and other things. And then Dr. Ghosh would promise us whenever we need his expertise, we request him for his and his team for his expertise in day-to-day time. Thank you very much. We are really going with a good memories. And this hall is always full. Of course, this is many people are going, even we are to leave. So much of knowledge we have quite an osteoarthritis, which is a commonest disease in rheumatology, in fact. So thank you very much, sir.
Anything you want to say? All I'll say is please grace your presence in Hyderabad next year. If people who don't know me, I'm Dr. Shiva. I'm an orthopedic surgeon, basically. So my plan is actually to integrate this particular disease, which is common in both orthopedics and rheumatology. So that's how the theme is going to be. So we would love to have all of you there. And as you know, Hyderabad is one of the booming cities in Hyderabad, in India itself now. So we all look forward to see you there. Thank you.
Sir, thank you, sir. Okay. Anybody there want to say anything from juniors, our students? Any student of us? You?
Dr. Bandyopadhyay is there.
Yes. You can say from there also.
So, every year I and my group, we attend this Sorkan conference. And we come here because we learn a lot. So I bring all my students, and this year the topics were so broad, in depth. We have actually taken detailed note. We have created some collaborations potential, so we will work with the doctors. So it was a very successful conference from our perspective, and thank you very much for organizing it.
Any student want to say anything? Any juniors? Student or any juniors? So far only seniors have spoken. No juniors. Okay. Now, pharma company I call pharma companies if there is any cheap sponsor. And our secretary Swar, if you want to add something in short, within a minute.
I'm really very happy to see the seeds now becoming little trees, and West Bengal chapter has really done justice to the 7th National Conference. I'm really very happy to see so many people collaborating, exchanging knowledge and everything. So I'm really very happy at the end of the day, bidding goodbye to you people. And I hope at Hyderabad it will be a next new chapter written.
Now, organizing chairman, Professor Parashar Ghosh.
So many thanks to each one of you who has come from different parts of India to attend this conference and make it successful. And it's very heartening to see that such a galaxy of experts, they have gathered here to enhance their knowledge in osteoarthritis management. It's many thanks to you, to all of you, including the scientists here. Thank you.
Dr. Shamasis Das, organizing treasurer, and treasurer of organizing treasurer, and the treasurer of WBBIRA at the same time.
I actually thank you all. Thank you very much for coming to this conference and making it very successful. Thank you.
I thank you all, my colleagues, organizing committee. Students of IPGMR, students of INK, students of IIT Kanpur, other institutes, IPGMR, RGCOR, NRS, all students, patients, our patients. Then our senior teachers, our colleagues. I cannot forget our WBBIRA office bearers. I can see only one of them here. But there are 3 of them. I am indebted to them for last 6 months. They have toiled. Our students, I didn't know that they have such zeal in them. I think they will go many steps up. The souvenir is a great work of imagination by Professor Gitabali Sarkar. She is not here, but I must thank her separately. The scientific session, I got immense help from Dr. Sumantra Mondol and Dr. Partho Garai. I couldn't do it alone. These 2 people are instrumental, and I must thank the organizing chairman, treasurer, and the SOAR secretary. Whenever I asked anything, almost in all the cases they said yes. Almost never said no. And when they said no, I asked them second time, then they said yes. No impediment for these 3 people sitting here. Without them, this conference was not such a grand success. Immense help from some of our colleagues of West Bengal branch of IRA. Immense help. I thank you all. Lastly, I thank the chief sponsor of this conference, IPCA Pharmaceuticals. Do you have anything to say, IPCA? If you want to say, you come and say it here. Come here, Purijit. IPCA here, not only money, but the manpower, but the help, which goes beyond manpower and money.
Thank you, sir. Thank you very much for the appreciation. First of all, I thank you, Dr. Vishwadeep Ghosh and Dr. Parashar Ghosh, for trusting IPCA over the years, longer period of time. And as long as rheumatology will be there, IPCA will be always there as an academic partner. Thank you very much. Thank you very much, sir.
Perhaps next year we shall hold election of SOAR. Our SOAR president, Dr. Pooja Dhawan, is not here, but she is toiling very much with that. I thank you all. Please be with us. Good evening, good night.